Good morning, everyone. Welcome to the BW Healthcare World Oncology Summit 2022. So basically, oncology is not only a branch of medicine that deals with tumors, it is the one that deals with the treatment, prevention, and diagnosis of cancer. It's my privilege to welcome you to this summit. The opening note for BW Healthcare World Oncology Summit will be by Dr. Anurag Batra, Chairman and Editor-in-Chief, BW Business World, and founder, Exchange for Media.
Good morning. It's my honor and privilege to be at the BW Healthcare World Oncology Summit. BW Healthcare World is a community of professional stakeholders in the business of healthcare, in the business of well-being. The last 2 years have shown us that the most important asset that we have is healthcare, is our health. If we are healthy, everything else matters. The business of healthcare in the last few years has galloped in India. As Corona has shown us that the healthcare infrastructure in India needs to be supplemented in all aspects. One big part of healthcare is preventive healthcare. We are making big leaps and bounds in preventive healthcare. Today, we are at the BW Healthcare World Oncology Summit. My congratulations to Mr. Harbinder Narula and his team for putting this together. Oncology is a domain which is growing in India. In the next 4 to 5 years, it's expected to become 2 times in terms of the amount of investments, growth, and work in all spheres of oncology. Today, at the BW Healthcare World Oncology Summit, you'll hear the leading practitioners in the oncology space discussing about what's happening in the domain, what is needed to amp up the investments, what is the new technology, and how we can save lives. Oncology is becoming preventive too. Early detection of cancer, early phasing out of cancer, how nutrition, dietary changes, lifestyle changes can help in preventing cancer. So BW Healthcare World brings you live the Oncology Summit on bwhealthcareworld.com. I look forward to meeting all of you virtually at the bwhealthcareworld.com. All the best. Stay logged in to bwhealthcareworld.com.
So that was Dr. Batra. And we're going to start off with the keynote address on radiotherapy, past, present, and the future by Dr. S. Hoku, Chairman and Senior Consultant, Radiation Oncology, BLK Max Super Specialty Hospital. Dr. Hoku, can you hear me, sir?
Yes, I can hear you.
Thank you, sir.
Is there a call from your side?
Dr. Hoku, maybe I request you to put your camera on. Dr. Hoku, you'll need to put your camera on to be going live.
Is it fine?
Dr. Hoku, we can't see you.
My camera is on. Can't see me. Shall I start?
Yes, sir, please.
Good morning, ladies and gentlemen. In the next half an hour, I'll take you to, with the past, present, and future of radiotherapy, and we'll see what is in store for us. Next slide, please. Radiotherapy is also known as radiation therapy or radiation oncology. It is a treatment modality based on the use of high energy rays or radioactive substances to damage tumoral cells and to halt the growth and division of these cells. Radiotherapy has been an effective tool for treating cancer for more than 125 years. It is estimated that about 2/3 of all cancer patients will receive radiation alone or in combination with surgery and or chemotherapy. Next, please. Let us now go through the past, present, and future of radiation. History or past is like a mirror that can be used to guide evaluation of the present, and it can illuminate the future through reflection on the past. Lessons from the past can guide radiation oncologists, medical physicists, and others on the way forward to develop new radiation therapy technology. Before looking at the history, let us see the cancer scenario in India. We have about 12 lakh new cancer cases per year, 25 lakh prevalent cases. There are about 550,000 cancer deaths per year, and patients who need radiotherapy in the country per year are around 8 lakhs. The common cancer sites in men is mouth, lung, and esophagus, although prostate is catching up very fast. And in women, cervix, breast, and mouth. In metros, breast is number one in women, and in the periphery, cervix is number one. Now, let us look at the world history. We all know that Willem Conrad Röntgen discovered X-rays in 1895. Soon after, that is on January 29, 1896, just 3 days later, X-rays were used for treatment of cancer by Dr. Ludlam. Then Stenbach and Jogren used it for skin cancer, and in 1903, Sen first attempted treatment in a leukemia patient. Next, please. In 1928, people were using radiation for some time, but there was no method to measure radiation. And therefore, in 1928, scientists developed what they call ionization chamber, which helped us to measure the dose of radiation. They also realized that radiation, although can be used to treat cancer, can be dangerous to the person who uses it. And therefore, in 1928 came International Commission on Radiological Protection, which was created to address the question of radio protection, and it is continuing till today. Then when we move from 1930 to 1950, earlier to 1930, there were only superficial cancers which were being treated by these X-rays because the energy of these X-rays was not very high. And therefore, from 1930 to 1950, scientists developed machines which were able to produce X-rays of slightly higher energy, that is 50 kV to 200 kV, that is kilovoltage. And that was called the orthovoltage era. Introduction of the electron beam therapy, a useful therapeutic option able to deliver higher and variable energies for treating deeper tumors. So with this 50 to 200 kV X-rays, they were able to treat deeper tumors. Then when we moved from 1950 to 1970, we call it a mega voltage era. Now, during this era, more and more development took place, and machines were produced which came out with higher energy, and therefore still deeper tumors could be treated. And in this era came the cobalt teletherapy unit, which produces high energy gamma rays. The energy of these gamma rays was 1.3 million volt as compared to 250 kilovolt in the orthovoltage era. And these cobalt therapy machines became the standard workhorse. And till today, in India and in the developing world, there are many centers which are still using cobalt teletherapy machines. Further to cobalt, the machines which were developed, they were called linear accelerators, and these linear accelerators had energy ranging from 6 million volt to 18 million volt and higher, and therefore they could treat still deeper tumors which are deeper than cobalt. Moreover, the orthovoltage era, the deep X-ray therapy machines, the dose got concentrated on the skin, and the deeper as the rays went down, the dose reduced. Whereas in cobalt and linear accelerators, there was a skin sparing effect, and so the deeper tumors were treated, and the skin was protected, and that was really helpful for the patients. Next. These pictures you see, the top one is the earliest cobalt unit, and the picture below on the right hand side is the most recent cobalt machines which are being used in large number of hospitals still today in India. Next. Now when we moved from 1970 to 1980, more and more computers came into play. Radiotherapy was becoming a recognized medical discipline. First radiological associations were formed, and in India, we founded Association of Radiation Oncologists of India, that is AROI, in 1978. And I had the honor of being the founder member of this association in India way back in 1978. New studies were confirming the efficacy of radiotherapy in improving survival of patients with different types of cancers. Innovative devices with a computerized control were introduced in the medical practice. Next, please. 1990 onwards, a lot of techniques came into play because imaging improved, computer software improved, and we improved the technology of delivering radiation. And some of these techniques which came into 1990s were called 3D conformal radiotherapy, stereotactic radiation therapy, stereotactic radiosurgery. And in the new millennium, we saw the introduction of still new techniques called intensity modulated radiotherapy, IMRT, image guided radiotherapy, IGRT, adaptive radiotherapy, which is called ART, and stereotactic body radiation therapy, SBRT. And all these techniques mentioned here are being used as of now across the world, including Indian hospitals. Next. The picture will show you in the next slide how it works. On the left-hand side, you can see 6 beams entering into the patient's body. The area which is covered by red color is the tumor, and the cylindrical part above that is the normal structure we want to protect. You see the radiation is entering from different directions and is concentrating at the center, the red area, which is the highest radiation dose. The area in yellow and blue is a very low radiation dose. So that was the advantage of 3D CRT, where high dose was given to the tumor with normal tissue getting protected. People improved 3D CRT and we came to IMRT, which is on the right. You can see that still the red area conforms much better to the tumor as compared to 3D CRT, as the radiation is entering from different sides of the body. So IMRT was able to save the normal structures to a greater extent than 3D conformal radiation. And both of these techniques are being used in the hospitals in India and the world today. Next. These are the pictures of some of the modern radiation equipment which is being used. The top 2 pictures are the linear accelerators, which are adapted to give IMRT and IGRT. The picture below on the left is an equipment which is a robotic equipment called CyberKnife, and the picture on the right is the machine called tomotherapy. These are also accelerators which have different qualities, and they deliver different types of radiation. Next, please. Then we have some more equipment like gamma knife, proton beam accelerators, which are in use in many hospitals in the world. Next. Let us now look at the history of radiotherapy in India. As I told you, X-rays were discovered in 1895. And very soon, that is in 1910, the first department of radiotherapy was opened in Calcutta Medical College. In 1940, 4 radium institutes were established, one each in Patna, Agra, Madras, and Lahore. And in 1949, Dr. Ramaiah Naidu, who was the associate of Madame Curie, who discovered radium, has established the first radon plant in India at Tata Memorial Hospital. Next, please. In 1956, the first cobalt teletherapy unit was installed at Cancer Institute in Madras. In 1958, another Theratron Junior, which was also a cobalt unit, was installed at Tata Memorial Hospital, Bombay. And in 1978, 57 departments had radiotherapy units, and another 6 centers were waiting to have a cobalt machine, making it a total of 63 departments in India in 1978. The first linear accelerator also came to Chennai, to Madras at that time in 1976. And in 1978, Christian Medical College, Vellore, had a machine called Betatron. Next, please. The greatest landmark in the history of radiotherapy in India was the development of a linear accelerator, low energy linear accelerator in India. That was the work, combined work of PGI Chandigarh, CSIO Chandigarh, and Samir Mumbai, Bombay at that time. And I am glad to say that PGI Chandigarh took the lead, and it was led by my late professor, B.D. Gupta at PGI Chandigarh. I am also, that is my alma mater. I trained in PGI, and that was the greatest landmark that India could produce a low energy linear accelerator indigenously. Next, please. Now let us come to the present. Modern day radiotherapy uses techniques, which I discussed earlier, which help us to deliver a targeted radiation and at the same time protect the surrounding critical structures. This helps us to deliver higher dose for better tumor control and reduces the side effects. These techniques are not only increasing the cure rates, but also providing a better quality of life. Just to give you a few examples. When we give radiation to the brain, earlier, the cognitive functions of the patient went down. Now we have methods of protecting the areas in the brain. One area is called hippocampus. If we protect the hippocampus from radiation, then the cognitive functions don't go down, and we have methods to do that. Head and neck cancer, when we treat, the 2 salivary glands, one on the right, other on the left, the major salivary gland, which are called parotid glands, got a very high dose of radiation, and the patient, although the cancer was cured, but the patient could not produce saliva throughout his life. There was dry mouth, there was no taste, very difficult to speak, very difficult to eat. So the technique IMRT, which came in, when you treat head and neck cancer with IMRT, very low dose goes to the parotid glands. And even after the cancer is treated, the patient has the saliva in the mouth, just like before treatment. And therefore, this is, the xerostomia, which is called the absence of saliva, which used to happen prior to IMRT, is no more there. So the quality of life of the patient is very good. Similarly, when we treat breast cancer by radiation, we protect the heart and lung, reduce the dose drastically to these areas so that the patients don't have complications related to them. Similarly, treatment of cancer of the cervix, of the uterus, we reduce the dose by IMRT and IGRT to rectum and urinary bladder. Like prostate cancer, again, the dose to rectum and urinary bladder is drastically reduced, and the patient has a good quality of life. Similarly, protons are being used, especially in children, so that the growth of children is not affected. So this is, a great advantage with these techniques, that in addition to tumor cure of the tumor, we are able to give a good quality of life to the patients. Next, please. Now I will show you some clinical examples of the patients which I treated throughout my career. And this was the first study which we undertook when IMRT and SRT came when I was working at Apollo Hospital, and we saw the radiation dose to the critical structures in 108 patients of brain tumor called glioblastoma. Next slide. I will share some of these slides with you and show you how these techniques work. Now, this is a case of brain tumor. You see on the right side, there is a tumor which is covered by orange. Orange shade tells you that this is a high dose area. The heart-shaped structure in the center, which is covered by green color, is the brain stem, which is one of the most, the midbrain and the brain stem are one of the most critical structures in the brain. Similarly, if you see two round structures in front, they are the eyes, and the cords coming at the back of them are the optic nerve. So the optic nerves and the brain stem and midbrain are covered by green color. That means they are receiving a very low dose. And the tumor, which is covered by orange color, is receiving a very high dose. And the distance between the tumor and these critical structure is only a few millimeters. So that is the beauty of techniques like stereotactic radiotherapy here. And in the next slide, you will see the same type of tumor being treated by a technique called IMRT. The next slide, please. See, here also, the tumor in orange gets a high dose, and the heart-shaped structure in the center gets a very low dose, which is covered in green. So that is the beauty of these techniques, that a few millimeter distance, the dose falls off drastically. Next slide. This is a case of prostate cancer. The prostate gland is covered by the red line, and red line is a dose which is 81 gray. Whereas the structure below that red line is rectum, which is receiving 50 gray. So only, they're touching each other, but the prostate is getting 81 gray, and just, a millimeter or two beyond, rectum is getting 50 gray. So the side effects will be much lower. Next slide. Same thing, you can see this was the CyberKnife patient treated on CyberKnife, and this is a patient treated on IMRT. Same thing, low dose to the rectum, high dose to prostate. Next slide. This is a case of pancreatic cancer. You see the tumor which we want to treat is covered by green color, and two kidneys which are just close to the tumor receive almost no radiation, very, very low dose of radiation. So they have no damage to the kidneys, whereas pancreatic tumor gets a very high dose. Next slide. There are certain non-cancerous conditions also which we treat, and many of them are in the brain. It is not that radiotherapy is effective in the treatment of cancer, it also treats non-cancerous or benign conditions. This is an example of what we call AVM, or arteriovenous malformation. Surgery is done in most of these cases, but in some cases, surgery is very difficult and can produce complications. Radiation is used, and we treat these AVMs. You can see the area covered by red in one single shot of radiation. The effectiveness and the success rate is as good as 95 to 98%. Next slide. Another benign tumor which we treat is shown in the next slide, and that is called the acoustic neuroma or acoustic schwannoma. You see that area which is covered in green, that is the tumor, and the brain stem, which is just on the right of it, not even a millimeter away, gets a very low dose, and this tumor gets a very high dose. This is also a benign or a non-malignant tumor. Next slide. Another benign tumor which we treat is called pituitary adenoma. That is the adenoma arising from the pituitary gland in the brain. Next slide. Another benign tumor which is very common and which radiation is very effective is called meningioma. These tumors are treated by radiotherapy, and the treatment is over in 1, 3, or 5 days. The treatment is not very long. It's a very short treatment. We give a high dose in a short time, and the success rate in most of these cases is more than 90%. Next slide. This is one of the classical and very, heartening to treat, but it is very, very difficult to treat. This is, a case of trigeminal neuralgia where the patient feels severe pain along the distribution of the nerves on the face. And many of the patients don't get any relief with the analgesics. So this is, a small area in the brain, which is a few millimeters, which we treat by radiation. And this radiation is a very, very high dose of radiation, is equivalent to 70 gray in one single shot to an area which is a few millimeters in diameter. You can see the accuracy and precision of the radiotherapy techniques in these days. And the pain just goes away and the patient will, bless you throughout his or her life. Next slide. This is, another example I'm showing you. This is a small series which we did in 2015 and 2016. And I would like to draw your attention to the lowermost line that after treating these prostate cancer patients by radiation, 27 out of 28 patients had normalization of PSA at 1 month. Excellent result by any standards. One patient had normalization at 3 months. That is the beauty of radiation, and the complication rates are almost nil. Next slide. Radiotherapy is based on the use of two main types of radiation, the electromagnetic and the particulate ones. The first is represented by X-rays, which come out of linear accelerator, as I showed you, and gamma rays, which come out of cobalt machine or gamma knife. The second type of radiations are particulate radiations, like electrons, neutrons, and protons. Neutrons were used for radiotherapy many years ago, but because of many logistic reasons, they are out of fashion now, and we use electrons and protons. Radiation may be delivered externally by machines called cobalt units or linear accelerators or gamma knife or cyber knife or proton accelerators. And they're called external radiation, and they can be used internally by using isotopes like iridium and cesium. In general, the choice of treatment which has to be used depends on the localization, size, and type of cancer. Next slide, please. Before we close, let us look into the future and what is for us store in future. The American TV directors and film directors saw this future of radiotherapy many years ago. Next slide. The first thing is automation. Automation and delivery of radiation and reduce human intervention and increase efficiency in various tasks. That is our aim. We know this automation like, the light sensors. When we enter a room, the light is switched on. When we get out of the room, the side light is switched off. When we approach the escalator, it starts. When we get off the escalator, it stops. The contactless payment of credit cards through credit cards. This is everyday part of our life. So why not use automation in radiotherapy processes? Radiotherapy planning and delivery involves a series of processes. It is extensive, complicated, and involves a lot of people in different roles. Automation and robotics could take some of the time-consuming tasks of these out of this pathway, freeing up the people to do other things. And automation is coming in a big way in radiotherapy. And in another 3 to 5 years, I hope we'll see, robotics taking part in a lot of processes in radiotherapy. Next. Next slide. There are certain things which can be very complicated. You must have seen, in your friends and family sometimes, and I see in my clinic many times, there are two patients who have the same disease. They are treated exactly similarly and are treated by the same doctor. When they come for checkup a few months later, you will find that the tumor has disappeared in one patient, but it has not gone at all, or the response to treatment in the other patient is very poor. Why does it happen that all the parameters are the same, but one patient showed excellent result, the other has not? That is the biology of the patient. And therefore, what we should do is that every tumor, every plan, every fraction will be adapted to individual risk and response models. We have to cut the cloth according to the size of the patient, and then only we will have the best results. Our should be fully personalized radiotherapy in which we do not, uh, we do risk profiling of every patient, initial prescription, risk rate, large, target definition, including microscopic spread and dose painting to target with exactly the correct amount of dose. Next slide. The third thing which we are doing, which we are already doing in our clinic, is that all cancer treatment across the board should finish in 1 week. At the present time, there are certain situations where we are, I showed you some of the examples earlier, where the treatment is over in 1 week, but in majority of cases, the radiotherapy treatment is extending to 4, 5, 6, or 7 weeks. All radiotherapy should be delivered in a maximum of 5 fractions is the aim for the future, to provide a new hope, a world where cancer can be cured in less than a week. Today's radiotherapy technologies can deliver dose very precisely because of excellent software and imaging techniques. I showed you a case of trigeminal neuralgia where 70 Gray is delivered in one shot. There can be nothing better than that. Large body of evidence showing that hypofractionation means reducing the number of treatments, is effective and feasible. So we are looking for in future for all cancer treatment coming to 1 to 5 days. Next slide. One or two fraction prostate stereotactic body radiotherapy with MR guided adaptation for all fractions. That is in, clinical trials are going on. Single dose ablative radiotherapy in metastasis, oligometastasis, and primary lung cancer are already being used. A study was done in United Kingdom which showed that if we drop from 20 fractions of radiation to 5 fractions, just in UK and just for prostate cancer, we will save 3.5 million kilograms of carbon dioxide over 1 year. So hypofractionation will not only help the patient, it also will help the planet. Next slide. Again, I said the American film directors can figure out what is going to happen in future in the field of radiotherapy. Next. And what is coming is what we call flash. Flash is defined as radiotherapy delivered extremely fast at ultra high dose rate using electrons, photons, or particles. At the present time, the radiotherapy which is delivered conventionally is 1.8 to 2 Gray per minute. That is the dose rate which we are using. In flash, what we are talking about, instead of 2 Gray per minute, we are talking about 2400 Gray per minute. From 2 Gray to 2400 Gray. You see the difference. And when we do that, flash does not induce classical radiation-induced toxicity patterns on normal tissues, but as a high tumor efficacy. What do we want? We want tumor to be cured without side effects. And that is what flash gives us. It is still in experimental stage. Some of the cancers being treated are skin lymphoma, proton flash for bone metastasis, electron flash for skin metastasis. And I hope in times to come, we will have more evidence for use of this technique. And if it works, it would be a wonder. Next. Cloud computing finally is the final thing which you are looking in future. Treatment decisions will be based on big data and cloud computing. Today, there are numerous new therapies, new biomarkers, several clinical trials, and we have to assimilate everything to decide about the treatment of our patient. With the human brain only able to make optimal decisions when considering up to 5 variables, our brains are already saturated, so we need cloud computing. so that we ultimately assimilate all the information and come out with a protocol which is best for our patient. Next. So finally, these were the some thoughts about the future. We discussed the present and the past. So what do we think in the end? By 2030 or maybe a few years later, it is likely that all radiotherapy will be automated, personalized, and hypofractionated, and that flash will save us. The innovation piloting, all that is going to be treatment decision and cloud computing. Next slide. And my hope is that in future, a few years to come, just like Neo did, to Kung Fu with a single button, we radiation oncologists will be able to treat all our patients with push of a single button. I hope I have been able to pass on the message about radiotherapy, what it can do, what it was, and what is in future. Thank you very much for your attention.
Thank you so much, Dr. Hoku. That was very insightful. Thank you again, sir. Up next, we have a panel of cancer screening and diagnosis from then to now. We have Dr. Shada Jain, founder and chairperson, obstetrician and gynecologist, Life Care Center, Dr. J.B. Sharma, senior consultant and HOD, medical oncology, Balaji Action Cancer Hospital, Dr. Shubham Garg, senior consultant, surgical oncology, Fortis Hospital. This is going to be moderated by Mr. Rohail Amin, senior editor, BW Business World.
Hi, good afternoon, everyone. Am I audible?
Yes.
Thank you so much for joining us. A lot to discuss here, and I have esteemed panelists with me. I want to start with you, Dr. Sharma. My first question to you, in your opinion, how far has the cancer screening advanced since the past few decades? And have we been able to prevent cancer to become malignant at an early stage?
The cancer screening means we are screening a general population which may have or may not have high risk of having a cancer in their lifetime. So the purpose of screening is to detect cancer in asymptomatic patients which do not have any symptoms, which do not have any signs. Signs and symptoms are not there, and we are asymptomatic persons we are checking. So initially we started with doing breast cancer screening and cervical cancer screening. For that we have mammography in breast cancer, and for cervical screening we have pap smear, and we can do now HPV test also. So initially we had pap smear for cervical, and for digital simple mammography was there. Now we have the advancement over last 1 decade. For each and every type of cancer, we have advancement in the screening techniques also. Now, earlier, simple mammography was there. Now we have digital 3D reconstitutive computerized mammography, which can reconstruct and which can very well, the doctor can detect the cancer and can characterize any abnormality very effectively in breast. In the advancement of cervical cancer, we initially had pap smear, where we used to see that morphologically, the cells type, whether it is having any dysplasia, metaplasia, or type of any early chance of development of precancerous cells. Now we have the advancement in that finding that if there is any HPV virus positivity, then there is a high risk of chance of developing cancer. So if you consider other cancers also, there has been various advancement in as compared to the last 1 decade, and we can easily detect few at least where we are doing the screening those cancers early to prevent that death from the cancer.
Can I chip in?
Yes, ma'am.
As far as our country is concerned, we definitely, the experts have the knowledge and have the expertise, but how far we have been able to put it into practice, you also know about it, that as for the cervical cancer screening is concerned, only 3% people have been screened so far. Rest is in paper. 97% people are not screened at all. And this is what we find that, the screening is, look at the Western world. They started their journey about 65 years back, and they have made a tremendous difference that, their mortality has come down by 80% and the incidence has come down by almost 70%. And I think, we have started taking a baby steps. Whatever is the reality is right in front of you.
Totally agree, madam. I think moving forward, we should focus more as a public service for screening, and it has to come from the government that we have to push for screening. We as private players can only play a little part, but it has to come as a public service.
All right. I want to come back to you, Dr. Sharma. Am I audible?
Yeah.
You're audible. You're audible.
Dr. Sharma, do you think increase in awareness aspect of early signs of cancer amongst the oncology fraternity has greatly helped in shaping present screening techniques? And do you have any specific examples on this?
See, in oncology fraternity, we doctors, we are medical oncologists, surgical oncologists, radiation oncologists. They are themselves doing CMEs to update newer techniques among themselves also. Even we are also doing social service where we are doing, educating the people in the societies where they get togethers, and we are doing campings where we do the initial pap smear screening for the people who come for that camps. We are doing free camps, and there we are having a social lecture also to educate the general public for that that we have to do the screening to prevent or to detect the cancer early in those patients who are even asymptomatic. So this type of services and awareness have increased, and I think all doctors who are related with the cancer treatment are doing this service. You are muted.
Sir, you're muted. You're muted still, sir.
Ruhail, can you unmute yourself, please? Salman, can you unmute Ruhail, please?
Yes.
Again.
You're muted, sir. Muted.
Muted.
Am I audible?
Yes.
Okay. I think very technical stuff. Dr. Jain, your thoughts on this?
See, I think, awareness is really needed in public. And I think it is very much possible. Right in front of you is an example of COVID times. The media came so forward that each and every child knew about vaccination, leave aside an adult. So I think, there is less is said about the awareness in public. It can be created. We have the expertise, and the only thing, it has to reach to the people, and then only things are possible. The government of India had made a theoretical plans that, breast screening, cancer cervix screening, and the throat cancer screening has to be done every 5 years, 30 years onwards. But I will say it is still on paper.
still on paper. Uh, right. Am I audible right now?
Yes.
Yes.
Dr. Garg, how do you see this correlation between, increase in the awareness and shaping the present screening techniques? How has it panned out in your opinion and helped doctors?
So I personally believe that the doctors were always aware and they were always willing to share the fact that we want to help patients and detect them earlier. What has now happened with the media getting involved with people, the priorities have changed. Cancer has always taken the backseat because communicable diseases were always on the forte. TB and everything. But now with the non-communicable diseases coming up, the lifestyle diseases coming up, you have more and more jump in these number of cases, and now patients themselves have started to come and ask us, how can we get ourselves screened? And that is where the major difference is. Doctors have already always known that this is a priority, but we had other things on our mind. But yes, it is catching up definitely.
Dr. Sharma, when you talk of cancer, there are a lot of myths associated, especially related to the screening part of it. A lot of there's a lot of hesitancy. Papers are patients are not aware of it. How are you able to clear these for the patients? Give us a sense of that.
Actually, the screening for the cancer means that we are detecting cancer in early stages if there is any cancer in any person. So that first and foremost fear with the persons is that if he is detected with cancer, then he will be blamed and he will be tagged as that. If he is having cancer, then it is a type of death sentence. So people are generally do not want to come forward. Another thing is if they detect, then they will do the biopsy, they will do further tests, they will subject to another staging test and all that. So people are usually afraid of doing biopsy also because they may think that if they found the cancer, then it may spread with the doing biopsy. So these are two types of myths. I think people are usually reluctant for this screening.
Dr. Jain, give me some examples of has it happened, and how did you convince the patients, that it's all fine to go for screening, and in fact that is going to help them rather than, they being very concerned about it. And is it still prevalent, despite we advancing so much and so much of literature around, articles around, cancer awareness? Do you think it still persists?
I think what Dr. J.V. Sharma has said, it is 100% correct. First myth in their mind is, I'm asymptomatic. I don't have anything. I don't have anything. So they know it that I'm okay. Why should get investigations done? The second myth which he has pointed out that कराएंगे तो कुछ निकलेगा ही. So they don't want to come. And third thing they have in mind that they can be an overdiagnosis, they can be underdiagnosis, and if they're I will be subjected to investigation is going to spread. Let me be very frank with you. Slowly and slowly, when they're coming repeatedly in our clinics, we definitely emphasize that, look, we have to get this particular screening done for you in 100% of cases. Because now when the WHO says the screening has to be done to the tune of 90%, then it has to be done. And the target which has been given for cancer cervix and for the breast is that at least 70% should be screened. We are far away from that, the kind of figures which we have that. But I will say that we have not been able to break these inhibitions among doctors and nurses widely beside the public. डॉक्टरों को भी बोलो कि आप आओ अपना चेकअप कराओ, वो भी नहीं कराते सर.
I can totally understand. Dr. Garg, what has your story been? How have patients reacted to it?
So I feel that the kind of screening that we have in our country is an opportunistic screening. People don't come up by themselves, but if a person in the family gets diagnosed with cancer, then everybody starts fearing it, and then they themselves come up that now that my relative or my cousin has been diagnosed with cancer, how can I now prevent myself? So what Dr. Jain mentioned about COVID, it was the perception of fear which was around everybody, that everybody reacted and wanted to get treated. That perception comes only when somebody close to you gets that cancer, and then only do they start seeking medical help, that how can they avoid it amongst themselves. This is unfortunately not percolated into the general public. What we are doing right now is opportunistic screening. The mother gets cancer, the daughter comes up and says, I am worried. She's not worried for herself. She is worried that her daughter will get cancer. So we tell them that, it's not your daughter, you are the one at risk, and this is where the counseling starts. So this is where we have to catch on these patients. And believe me, my job is to tell public the figures and create fear. There's a difference between fear and panic. Panic should not be there, but the fear should be there. बच्चे फेल होने के डर से ही एग्जाम के लिए पढ़ते हैं, तो आपको ये डर लाना होगा कि आप कैंसर से you can fail from cancer. If you don't have that fear, you will not be able to get them to screen.
Yes, I think, one has to be aware, I think, not panic. Of course, I think that's a very important point mentioned there. There are a lot of barriers, as you pointed out. People have a certain perception, which is, of course, doctors help them overcome it. But Dr. Sharma, what are the common barriers associated as far as screening of cancer is concerned, from a doctor's perspective? And in your view, have the regulatory bodies helped in mitigating that?
I think we already have discussed the common barriers because the people, if they are asymptomatic, they are not coming forward. Like Dr. Shubham told, that if any person who has a family history of cancer in their family, they will sometimes come forward, or you can explain that this patient, your mother is having a type of genetic disease which is familial, which can pass in the family. So you should be very aware, and you do some test and screening test for them. They are usually coming forward. I think for government point of view, there are no such guidelines for this screening purpose. Screening is available, I think, all the government hospital, but if the people are not coming for screening, then what the government is going to do. And I think government should frame guidelines, like Dr. Jain told, that only 3% of the population is being screened. So what about for 97%? I think it should make either mandatorily for example, like for renewal of your driving license, you have to do this type of test, and then you can get. So some type of mandatory things should come in the force, so that you can do at least this type of screening in that for that has to be purposefully effective.
Dr. Jain, your thoughts?
See, I feel, not only what Dr. Shubham has said, that when the family members has cancer, then you should come forward. That happens. But I think, every visit of a patient for any other reason, we should make it a point that, they must like a woman comes to me, I will definitely screen her for breast cancer as well as for cervical cancer. It is must as far as I am concerned. But I think similar way, everybody has to be very enthusiastic that every opportunity the patient is there in your clinic, you should make use of every opportunity for this screening thing, and then only things of this kind is possible.
Dr. Garg, your thoughts on this?
So I think one of the very common barrier is the cost and the availability. We are sitting in a metro city, so it's easy for me to talk about getting a CT scan done. But when we talk of a screening program as such at a national level, we have to also look at the availability of the screening test and the cost which is involved. It might be easy to tell somebody in a Delhi that, you need to get a mammography done which costs 2,000 rupees. But to tell a family member whose monthly income is probably 40,000 rupees to get a annual mammography might be difficult. So without putting numbers to it, we need to make it easily available and easily affordable. And we have to somehow rope in the private sector, because government does not have the ability to screen so many people. We have to get this, and the funds are available. It is not. So Ayushman scheme is something which is very useful, and somehow we have to subsidize these screening tests so that all the hospitals which are available in tier 2 cities, tier 1 cities are able to take this up for the patient. So this has to come up.
Right. You know, a lot of people watching us, have this question. This is a very genuine question, and everyone wants to know that what are the risks associated when we go for tests, when patients go for tests, and are there any health hazards of this test over time? Dr. Sharma, starting with you.
Yeah. See, that most important is sometimes we do the overdiagnosis. We suspect and we do the further tests. So this is the hurdle. And other is the radiation exposure. If we do mammography or low dose CT scan, people are afraid of having radiation. But it has been found that radiation exposure is usually of low doses, and it does more, means more better as compared to the more harm. So the life saved is more as compared to the any harm we get while we do mammography or low dose CT scan. So I think these are the two reasons. One is the radiation exposure. Second is the sometimes overdiagnosis, which may lead to that unnecessary biopsies, and
Right.
sometimes that late diagnosis or diagnosis.
Okay. Dr. Jain, your thoughts on what are the risks associated with, yeah, sorry, it's on mute here.
Let me be very frank with you. As far as the females are concerned, uh, the priority things which are put for screening are breast cancers as well as cervical cancer. As far as the ovarian cancer and the uterine cancer is concerned, they have not been good cancers for routine screening, because when the incidence of any cancer is less than 5 per lakh, then probably does not call for a screening. That kind of a thing is there. So I find, as far as the breast screening is concerned and the cervical screening is concerned, there is no method which can in any way harm these people. As for the mammography is concerned, I'm sure when the mammography is done, where it is done, they make it very, very clear that there is a reference sheet is there and you are not pregnant at that particular time, then only this particular thing can be done. So I see no reason, there are no screening tests available today that it calls for any kind of a health hazards per se from the screening. So I think, this assurance has to come to the public by the senior people like this, and they have to time and again come on the media and, reassure the public, because these programs are listened by many, many people. So I think, something like this, cancer awareness program will come at Doordarshan at 2 o'clock every day. So I think, that is the kind of an awareness is required in this particular country.
Absolutely, I think that's our attempt, at business world as well, that we want to raise this awareness, and that's precisely the motto behind this conversation that we're doing. Dr. Garg, give me, what do you think about these health, concerns that are associated with tests, and are there any hazards in the over the long time?
So, like Dr. Jain mentioned, there are very few hazards associated with these tests, and most of the people come to us and they talk about the radiation that they might get associated with the mammography or a CT chest. Believe me, the radiation that you get for a mammography, equivalent amount of radiation you get in every flight that you take from Delhi to Bangalore. So the amount of radiation that you get exposed in mammography is similar to the amount of radiation you get in a long flight. So it is not that there are no risks, there are some risks, but if you explain it to the patient that those risks are worth the benefit that they might have, they will understand. So if a patient gets diagnosed with cancer, for every 220 CT scans which are done for lung screening, I will save one life, and that one life will be thankful vis-a-vis that 219. The number for breast cancer is 1400. So 1400 mammograms you do, you will save one life. The point is that they have to understand the risk to benefit ratio. If the benefit is more than the risk, then it is a risk worth taking. This is what we do all our life, and this is what we have to explain to the patient.
Great. Dr. Sharma, what kind of surgical methods are available to ensure that there is correct detection? And of course, through that, a lot of concerns are addressed as well.
Surgical methods, I could not understand your question. Please repeat it.
What kind of surgical methods are available to ensure correct detection?
I think Shubham, you can take this question.
Yes.
Okay.
So I see any imaging that you do, if you do a mammography, if you do a blood test, if you do a CT scan, they can only point you towards having the risk of having that disease. But doing a biopsy, which I think what Rohil's question is about, can help you ensure whether this is the right suspicion or not, which is what we call as a biopsy, where in case of an oral malignancy, cancer of the head and neck and the mouth, you can take a small biopsy. Similarly, in the case of cervical cancer, if you feel that there is a lesion present, a gynecologist can very comfortably in their office itself, without any major risk, can take a small punch biopsy. It's an office procedure, completely safe. The patient goes home within 15 minutes, and this has to be told to the patient. Similarly, in case of breast cancer, when there is a suspicion of a breast lump, which is again highlighted on the mammography, it is very easy to do an office procedure where you do a cord needle biopsy and take these out. These are not, I will not call them surgeries. These are just small procedures where you can confirm the diagnosis that has arisen because of suspicion that has come out in screening. Because screening, the problem with screening is anxiety. Every lesion that you pick up, you will put a seed of doubt in the patient whether this is cancer or not. So you should also have the next plan ready if you suspect a patient on screening that you need to do a biopsy for that patient.
Yes, I think what Dr. Shubham has said, the screening is meant, if you are suspicious about things, it need to be confirmed, and confirmation is always by biopsy.
Right. Dr. Sharma, there are also cases of false positive / negative results, a lot of cases like that. How do you ensure that such issues don't arise? And what methods do you adopt, to ensure we try to mitigate such results?
So if we find that we suspect any lesion, for example, I'll take the case of breast lesion, which has been detected on mammography. And we have done the FNAC, and the FNAC shows that it is atypical hyperplasia or something like that. So it may be a non-cancer, but patient is likely to have cancer in future. For that, we need to do repeated biopsy at repeated intervals. So first thing, we explain the patient, we counsel the patient, and we reassure the patient that you are not having cancer right now, but you have a lesion which might turn up to a cancer at a later stage. So better if we remove this lesion at this point of time only, so that you are spared of repeated biopsies or repeated examination. One thing that we explain, that if the patient does not agree, we tell that, okay, this may not be cancer right now. We will follow it up maybe after 3 months or maybe after 6 months. We will do repeat mammography, repeat X-ray, and we can do at that time, if it increases, then we can do repeat biopsy also. So first counseling, second patient, whatever is available, if we remove it then and also right now, then we can cure it. And third is, if there is underdiagnosis or sometimes we don't find, then we have to ask the patient that you have to come after 3 months or 6 months.
Dr. Jain, how do you tackle these false positive negative results?
These things are very simple for me. There are two tests available. We can categorize all screening tests into two. One is sensitivity. I have a cancer and this test is positive, which need to be confirmed again. And I do not have a cancer and this test is negative. And this is what is the specificity is very much important. If the cancer is not there and the test is negative, now the public wants to know and reassured by the doctor that, you know, this particular test has got a very high specificity, and that's why you do not have a cancer right away. But at the same time, you must come back for a follow-up on a yearly basis, on a 3-yearly basis, depends upon that. So I see that, you know, whenever there's a suspicion raised, see, I will take an example, which is a very screening positive thing, that's cancer cervix. Now, once we suspect on the cytology or VIA or a Willi, then, you know, that biopsy need to be taken. The biopsy need to be taken under the colposcopy cover, which gives us a magnification of 15 to 20 times. And then you take a biopsy, and if it confirms, then only we go ahead. So I think, you know, no treatment is ever envisaged, whether it is a mammography. Again, and when a mammography is suspicious, then when you are taking a core biopsy, if you do it, if you combine with imaging, the accuracy becomes very, very easy. So I think, you know, now the ways and means are done that when the screening is positive and you are trying to confirm it, you use extra gadgetry. So the chances of missing that particular disease is not there. So I think, you know, things have become very precise, and all cancer specialists and ordinary doctors know about these things, and the public can be easily told about the same.
Right. Dr. Garg, your thoughts on this?
So what Dr. Jain mentioned were the statistics, you know, sensitivity and positivity. For me, false positives are still okay. Believe me, you have to make a patient understand that these are screening tests. We are not telling them that you have cancer. We're just telling them you have the doubt of having cancer. And if that screening test tells me that you have suspicion, I will do a confirmatory test. I am not going to operate you or give you chemotherapy on the basis of this test. I will do another test on the basis of this test, which will confirm whether you have cancer or not. And this is what biopsy is, what we were talking about. The problem is with false negatives. False positives are still okay. False positive means that the patient does not have cancer and was suspected to have cancer. This is false positive. He or she will get a confirmatory test which will confirm whether she did not have cancer. The problem is with false negatives. False negatives gives you the false assurance that you did not have cancer, and for the next 3 months or 6 months or 1 year, you will not get any other test done. So that is why it is very important that, you know, you should not just blindly have a screening test. You should also combine it with consultation with a clinician, whether it's a gynecologist or an oncologist or whichever physician, so that they can corroborate that test and ensure that the false negativity at least comes down.
Right. We have a lot of questions and a lot of questions coming as well, but I think this is going to be my final question because we just have, say, around 4 to 5 minutes left. Dr. Sharma, quickly, do you think genetics play an integral role in diagnosis? What do you think is the ratio of cancer diagnosis of people having cancer, heredity, and first-timers?
Generally, if you see, I'll take the example of breast cancer. In breast cancer, approximately 5 to 8% of the cancers are hereditary. Means this may be related to that there are two genes, BRCA1 genes and BRCA2 genes. So if the mutation in this, either of this gene, if there is mutation that is carried forward to the next generation, so these are germline mutations which are transferred to the progeny, and if the genes is present in that family, they are likely to have the breast cancer, chance of developing breast cancers are like 100% in their lifetime. Other cancers are also associated with the BRCA1 or BRCA2 gene mutations, like the cancers in male breast are also associated with this. Ovarian cancer, pancreatic cancer, in male prostate cancer, colorectal cancer. These are the cancers which have high chance of developing in these patients who have a genetic mutation, BRCA1 and BRCA2 mutations. So this is very important to know the genetic profile of a patient who is having a cancer, so that you can advise or counsel that rest of the family that you have to be aware of the fact that your mother or your father was having this type of cancer with this genetic mutation, which is likely to be forwarded to the progeny, your brother, sister, and other family members also. So you have to be careful, and you have to get screening for such type of cancers, and you should not delay any symptoms or signs related to this.
Dr. Jain, your quick thoughts?
I think the genetics, as Dr. Sharma mentioned about BRCA1 and BRCA2, it has got a lot of significance because it has been seen that once these genetic mutations are positive, there is a significant increase in the breast and in ovarian cancer. So I find, these screenings, previously they were very expensive, but they're not very expensive now at all. And especially people with their family history should definitely get them screening done. And in case if the screen is positive, they should take the corrective measures there. Especially so in cases of ovarian cancer, if there's a family history, then we know it if BRCA1 is positive, and ovarian cancer, all mortality because of ovarian cancer is on one side, and the other mortality by rest of the cancer is on the other side. So I think, if we come to know if BRCA1 is positive, and the chances of ovarian malignancy increases anything between 30 to 60 times. And in case if BRCA2 is positive after 70 years, the risk increases from 1% to something like 20%. I think it is significant. But I think, still in medical fraternity also, this awareness is not there. And even if the awareness is there, they don't wish to get it done. So I think, some barriers has to be broken as far as this thing is concerned. And I think, as Sir has pointed out, that now the genetics in relations to cancer is picking up. And I think we should be creating more doctors' awareness first, and through them, we expect public awareness.
Great. Yes.
One more thing I want to add, that those people who have BRCA1 and BRCA2 mutations, cancers in there is in early ages, for example, 20 to 30 years. Otherwise, the chances of cancer development based on the age is around 50 to 60 years. But those persons who have this type of mutation, BRCA1, they are likely to have cancer at a younger age. For example, 20 to 30 years of the age.
True.
Right. Final thoughts, Dr. Garg?
So I've heard what Dr. Jain and Dr. Sharma mentioned about genetic thing, but this is for the general public, not for the doctors, that, it does not mean that, if somebody had some cancer in your family and you will get any genetic test done for you. There are specific tests for specific organs. We are aware as clinicians that there are many tests there in the market which says that you get this blood test done and we will tell you the risk of you having cancer, which is wrong. So it should not come out that, if you have any family history, you need to get genetic testing. For example, if somebody in your family had a tobacco-related head and neck cancer, you are not at risk of having, because that is not genetically hereditary. So that is why inherited. So we need to really counsel these patients and then weigh in getting the right test done, because believe me, these are double-edged swords. The day these genetic tests lose their credibility because you're getting them done too much and they are not giving you results, even the patients who really deserve them will not be able to get them, or they will get prohibitively expensive. So I feel they should be done judiciously and not everybody should get them done.
Thank you so much. Wonderful conversation. So much to learn from our esteemed speakers and experts. But we're out of time. We hope we will continue this series. And thanks for joining us and sharing your thoughts on this.
Thank you. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you so much, everyone, for your time, knowledge, and inputs. Our next panel is going to be on cancer epidemiology, causes and solutions. Dr. M. Srinivas Reddy, Senior Consultant and HOD Surgical Oncology, Kameni Hospital, Dr. Kanchan Kaur, Associate Director, Breast Cancer Specialist, Medanta, the Medicity, Dr. Rajendra Kumar, Director and HOD, Radiation Oncology, Max Super Specialty Hospital, and this is going to be moderated again by Mr. Rohail Amin, Senior Editor, BW Business World.
Yes. Thank you so much for joining us. A very important discussion on this day, and since morning we've been discussing and touching upon various aspects of oncology. I want to start with you, Dr. Kaur, and I would request other esteemed panelists to switch on the cameras as well. Dr. Kaur, what do you think is the demographic distribution of cancer-related ailments in India, and which cancer is predominant in which demography?
So good afternoon. Thank you for having me on. I managed to catch a few minutes of the previous discussion and it was quite invigorating. So I hope during this session also we'll get to bring up important points, because cancer is the biggest scourge right now, especially in India. And when we talk of, the distribution of cancer and the demographics of cancer, first of all, if we look at what are the commonest cancers that we see in India, so it's lung, breast, oral cancer, esophageal cancer. And amongst women, we know that breast has overtaken cervical cancer as the commonest cancer amongst women, especially in metropolitan cities. And lung cancer continues to be the #1 cancer amongst men. Distribution of cancer, we know, depending on the type of cancer we are looking at, like Northeast has the highest number of cancers, especially oral cancers. And Aizawl actually has the highest number of cancers in the country. So if you look at the demographic distribution of cancer overall in India, we see that oral cancer, especially amongst the tobacco chewers and the use of tobacco is on the rise, along with lung cancer, and breast mainly amongst women.
Dr. Reddy, my question in India, and which cancer is predominant in which demography?
Yeah, if you see, we see almost like 13 lakh cancers annually in our country, of which we are almost seeing 8 lakh cancer deaths. And based on the population-based cancer registries, India has been divided into 6 geographic regions: so north, south, east, west, central, and northeast. And if we see based on these geographic regions, we see that in the north and northeast, the incidence of cancers is very high. So, as told by Ms. Kaur, the incidence is very high in Meghalaya, Mizoram, and Arunachal Pradesh, where we see a lot of oral, oropharyngeal, esophagus, GIT, and breast cancers. So if we see a lot of rise in the incidence of breast cancers, especially in metropolitan cities, but even in rural India, the incidence of breast cancer is increasing, and it has surpassed the cervical cancers. If you see in Kerala, there is an incidence in the thyroid cancers have been noted as a high incidence in Kerala, and a high incidence of gallbladder cancers and upper GI cancers with high incidence in the north. So there is a wide distribution and heterogeneity in these demographic distribution of cancers, and it estimated that we are about to encounter close to 30 million cancer cases by 2025, which is very alarming.
Okay, all right, right. I can totally understand. Dr. Rajendra is here with us. So if you can hear me.
Hello.
Hi. So a quick question. I know you are
Actually, I got
you just
stuck.
came
I
out of
got stuck with one of my
yes.
patient is in ICU. So
I can
sorry. I
totally
just a little late.
understand. No worries, and thank you so much for taking out time. So my first question, I'm on my first question, which was, what do you think is the demographic distribution of cancer-related ailments in India? Which which are predominant in which areas, according to you?
So I belong to Uttar Pradesh, UP state, and in this state, along the belt of Ganga Ji and then other rivers. So there are most of these commercial waste, you can say industrial waste that is sent to these rivers. So most of the GI cancers, gallbladder cancer and liver cancer, they are the most common in these areas. Similarly, if you see this Kashmiri part, Srinagar part, so these people they consume lot of spices. So there also we see lot of GI cancers, intestinal cancer, stomach cancer. Similar is in the southern Indian part where people take lot of spices in their meal. As you go to these states like Bihar, poor people they used to chew khani, and you see a lot of head and neck cancers coming from Bihar belt. So these are the demographic variations which we see in our country.
Right. Dr. Kaur, is there a correlation between the gender and mortality rate? If yes, then in what age group does it cause more mortality?
So we do see a disparity in the mortality with regards to gender. Now, whether these are more strongly related to the etiology of the cancer rather than the prognosis, that depends from cancer to cancer. As a general rule, we know that older the patient, above 80 or above 70s, then obviously the mortality from the cancer is more, part of it also which is contributed by treatments, because patients who are older are likely to suffer from more severe complications of, say, chemotherapy or the anesthesia which we give for surgery and things like that. But we do know, if you look at data, they talk about mortality in men much higher than that in women. Now, a lot of times it could be because of risk factors like smoking and alcohol consumption, which are more prevalent amongst males as compared to females. So these are lifestyle choices that we see, and they could contribute to more disease burden, disease getting detected late because of the behavioral things. So women may be more conscious of their health, although this is more of a Western kind of a perspective, because in India we know that women are likely to put their health on the back burner. And I'll give a little example of breast cancer with regards to this, because in the West women are more active and get screening done regularly. Breast cancer is detected at a very early age. Whereas the commonest cancer amongst men, which is lung cancer, you don't have screening for that, right? So it is not likely to be picked up as early. Breast cancer is likely to be picked up. But sadly in India, because women don't undergo screening, a higher mortality rate. In fact, 1 in 2 women diagnosed with breast cancer in India are likely to lose their life to breast cancer, as opposed to only say 20% or 30% in the Western world. So the attitude of which is gender guided, health related, lifestyle related, does affect the stage at which the cancer is picked and how the patient actually responds to treatment. But we do know that in certain cancers, like in lung and bronchial cancer, women are likely to have a better survival outcome when matched stage for stage. Studies have shown that. Whereas in bladder cancer, women are more likely to have more mortality as compared to men. Now, this could also be because of physician bias, because a man with any early urinary symptoms is more likely to be referred on to cystoscopy than women who generally suffer more from, say, urinary infections. So the threshold of the doctor to refer cystoscopy might be higher as opposed to a man. So there's a very complex interplay of factors, and you cannot, it's not very black and white that men are more likely to die from cancer and women are less likely. But overall studies do show that men might not do as well in some cancers as compared to women.
Right, right. Thanks for sharing this elaborate, point. Dr. Reddy, your thoughts on this?
Yeah, I agree with the same. The men are supposed to have a higher mortality if you see a lot of studies, but as the incidence is supposed to be high in women because of a lot of breast and cervix cancers. But as the tobacco-related cancers take a toll in our country, probably that is the reason why the deaths are more in men. And because of screening facilities, as we see in our country, we have a proper screening facilities for breast and cervix when compared to oral and lung in men. So that may be one of the reasons where more and more cancers are diagnosed in women, and but the mortality rates are more in men.
Sorry, am I audible now? There was
Yeah,
some technical issue,
yeah.
I guess. Yeah. All right, all right. Dr. Rajendra Kumar, if you can hear us, else I'll come back to my question. Yes.
Yes, please.
So we're talking about, our question was, is there a correlation between the gender and mortality rate?
So I don't think it is true directly to the gender. It is basically the type of cancer and the stage of cancer which matters. But absolutely, it's not like a female with early stage, say breast cancer, will have higher mortality. It is not true. But type of cancer with advanced stage is obviously, irrespective of gender, causes higher mortality.
Yeah. Dr. Kaur, we all want to know what are the key factors that increase the cancer risk amongst the working population? Sorry, it's on mute.
Yes, can you hear me now?
Yes.
Yes. So, when we talk about cancers, there is always this discussion on occupational risks associated with cancer, or the risks of cancer in the working population. Now, this can be broadly divided under two headings. One is occupational exposure to carcinogens. Are you being exposed to chemicals that lead to an increased risk of cancer? That is one aspect of it. The other is your lifestyle due to your occupation, because we know that most cancers are lifestyle risk associated, right? So when we talk about occupational exposure to chemicals, so people who work in factories where there's arsenic, cadmium, ethanol, workers who are working on the roads, constantly being exposed to smoke. So those are the kind of people we know who will be directly have a carcinogenic effect of the chemicals that they are exposed to. And I think with the Industries Act now, that is very strictly regulated. A little example also of doctors who work in the hospitals, who work around machines that have radiation exposure for them. They are mandated to wear something called TLD batches, which calculate the amount of radiation that the doctor has received, which could pose health risk. So that is an aspect that may be controllable and understandable to certain extents. But it's the lifestyle changes which are sometimes more difficult to control. So, I'll give you a very simple example of something. So, we know somebody who's working in the city, has say a 12-hour or a 10-hour working day? Are they getting enough sleep? Are they having the right kind of food at the right time? Do they have a sedentary work, where they're sitting in front of a computer for 7, 8, 9 hours at stretch? Are their exercise levels? So, all these things contribute to things like obesity and stress, and all of which we know are interlinked as part of the multifactorial reasons for cancer. In fact, there was this very, very interesting case in the UK where a nurse took the NHS to court because she was on night duties for a long time, and there is some correlation between, a disruption, what is called your circadian rhythm. Don't get enough sleep in the night, that alters your hormonal milieu and can lead to an increased risk of development of, say, breast cancer. So occupational factors definitely pose a risk of cancer, and they have to be understood in the broad spectrum of what I have discussed. And I also know that now corporates are actively looking at healthy lifestyle for their employees, where regular health checks are done, regular health talks are done, so that people are more and more aware about the risk that sometimes even a simple sitting on a chair for 8 hours can pose. So that is how occupational hazards are associated with cancer risk.
Dr. Reddy?
Yeah, we all know that these physical agents in the form of pollutants, the arsenic, asbestos, silica, and cadmium, all these are potential carcinogens. And as we all know, the smoke, which contains a lot of polycyclic aromatic hydrocarbons, as the main cause of lung cancer. And the radiation hazard is very well known. Apart from this, even biologic agents, especially for healthcare workers, where there is a risk of contamination from the infected body fluids, especially by the housekeeping staff, in the laboratory technicians who may get exposed to ethylene oxide, formaldehyde. These are very small things, but they may go a long way if a proper protection protection gear is not followed. So potentially speaking, there is a lot of risk which is probably previously underestimated for healthcare workers. And it is time that all healthcare workers should take care of a proper sleep patterns, proper diet patterns, so that the hormonal milieu in the body is maintained, which may actually have a long-term effect on the cancer. So the study which was done on the breast cancers regarding the stress and long hours and night shifts has shown some correlation, though it is not directly causative. It is time to think that we have further studies and take care of these changes in shift timings, especially because we are facing a high rampant increase in breast cancers.
Right. Dr. Kumar, if it's possible to get your thoughts on it. I'll move to Dr. Kaur with my next question. Dr. Kaur, do you think micronutrient intake and proper vaccination steps can prevent cancer at an early stage? Does it help prevent cancers as well in the long run?
So, two components of your question again. One is vaccination and the other is micronutrient intake. I'll talk about micronutrients first. We as a generation are sadly encased in these food fads about suddenly one day micronutrients become the holy grail of preventing disease, and another day less carbohydrates, and another day more protein. And I think nothing harms the body more than not understanding that we need to have a balanced diet. And if you are having a balanced diet, then micronutrients form a part of your diet. So if we look at our traditional Indian diet, if you are having your wheat, your rice with a vegetable, with yogurt, with salad, that is the healthiest form of meal to have, which takes care of all your micronutrients. Nowadays, you see these fads about, they give microgreens and all sorts of things to be included in diet. But I will honestly tell you that for a healthy person, if you follow the lifestyle advice that your grandmother had and understood seasonal variations of food and eating what is native to your culture and your country, then most of the problems are sorted. we do know certain micronutrients like selenium and vitamin D have been linked to breast cancer and other cancers. But we also know that when you put an information like this out in the community, people start overdosing on supplements of selenium and vitamin D, which is actually detrimental rather than being helpful. So it is very, very important to understand not to get involved in the food, please, not to get involved in the food fads that we are, nowadays sadly getting involved in. Having had said that, I think even as cancer doctors who practice allopathy, sadly, we talk about our medicines, but we also need to understand dietary influences more and more to be able to guide our patients better into recovery from treatments of cancer, and also hopefully reducing risks of further cancers developing. So that's the nutrient bit. Now, coming on to the vaccination bit, vaccination, which is the most successful for preventing cancer, is that the cervical cancer vaccine, which ideally should be given before the first sexual exposure. And that is why girls as young as 9 and 10 are told to take the cervical cancer vaccine. So that definitely reduces the risk significantly of developing cervical cancer. But for other cancers, there are no definite vaccines available, which will reduce the risk of, developing that cancer. When we are talking of risk reduction in patients who are proven to be genetic carriers, mutation carriers, there are other ways of risk reduction, not vaccines, but there are surgical and medical ways of risk reduction. But for vaccination, mainly for cervical cancer, that is where vaccination plays a role in reducing the risk of developing cancer.
Right, right. Dr. Reddy, your thoughts on micronutrient intake and proper vaccination to prevent cancer?
Yeah, actually, there are a lot of formulations which are being advocated every day, like combinations of several vitamins, several minerals, several antioxidants, including like curcumin and so many things which are actually available in our food. So what is important to understand by everybody is that a balanced diet at proper time and having an adequate sleep. So meeting recommended daily allowance of all these nutrients, especially like having fresh fruits and vegetables, and including all types of, it said that like greens, yellows and reds. Having a colorful diet with having adequate quantity of fresh fruits and vegetables is very important. So if we have a balanced diet, we definitely will meet the required dietary allowance, and there is no need to take all these formulations. But this unnecessary propagation of use of micronutrients and antioxidants in the form of drug formulations will not be needed if we take a proper diet. And regarding vaccines, actually, there are the hepatitis B and human papillomavirus. These two vaccines are already in use, and they have documented several studies that hepatitis B vaccine is almost like cuts down the risk of chronic hepatitis B infection to more than 90%, thereby preventing the chance of hepatocellular carcinoma. And at the same time, human papillomavirus vaccine decreases chances of cervical intraepithelial neoplasia as well as carcinoma cervix. And these two have already been included in the national immunization program of several countries. And research is going on to study cancer vaccines for other cancers too. And hope we see that we have other vaccines too for other cancers also.
Right, right. Dr. Kaur, okay, Dr. Rajendra, yes. Good to have you here again with us. So give me a sense of this connect between micronutrient proper vaccination in order to prevent cancer.
So I fully agree with the opinion of Dr. Reddy and Dr. Kaur. We should take a balanced diet. We should focus on a regular exercise, maybe 20-30 minutes. We should do some kind of meditation. We should give as possible as we can do relaxation to our body during our stressful working environment. And if you are taking a balanced diet, you are taking proper vegetable, fruits, carbohydrates, I think additional micronutrients are not required. which Dr. Kaur discussed. So coming to vaccination, I agree with Dr. Reddy. So we should encourage as much possible vaccination to younger girls for this cervical cancer and for hepatitis B and C. So till date, these are the two vaccinations which are preventive and other are under investigations.
Great. Dr. Kaur, I asked this question earlier in the panel, but very relevant one about the correlation between genetics and cancer risk among population. If one has a family history of cancer, what is the possibility of having cancer, by the future generations?
So, the general belief in the public is that if nobody in my family had cancer, I will not get cancer. But the
Right.
statistics tell us that only 5 to 10% cancers are inherited or have a strong family history risk. And even in them, we are able to identify the mutated gene in probably 15 to 20% cases. Okay, so yes, family history does pose an increased risk of developing cancers, especially for cancers like breast cancer and ovarian cancer. There are certain cancers like lung cancers, which are primarily, or oral cancer, which are lifestyle risk associated. Then there are certain cancers that we know which fall under hereditary cancer syndromes, where the patient is at a risk of developing multiple cancers in different parts of the body. Now, what is important is that if somebody has a family history of breast cancer, which is strong, they should definitely visit a cancer clinic where the doctor can guide them about genetic counseling. Now, I'll tell you one sad story about, sadly in India, what happens is that the moment you know that there is a genetic test available which can find out whether you have a risk of cancer, sadly, these tests are available in the market even without proper genetic counseling. And getting these tests done without the guidance of a genetic counselor can open a Pandora's box. So it is very important to understand that if you have a strong family history of any type of cancer, then you must visit the cancer clinic, talk to your oncologist, talk to the genetic counselor, and understand if certain genetic tests can be done to identify the mutated gene which can lead to that cancer. And before you have such a test, you must have a discussion about what will be the action taken once that test is done. Because sometimes patients get this test done and oops, it comes back as positive, and then they are not ready to discuss options like, I'll give an example of, say, if there's a gene called BRCA1 and 2, if that comes positive, you're at a higher risk of developing breast cancer or ovarian cancer. And it is obviously for a healthy female to tell her that you need to remove your breasts and your ovaries to reduce your lifetime risk of developing cancer is a very, very big decision. So all this discussion must be had before the test is recommended and done. Sometimes in some cancers, like in breast cancer, there may be no family history, but we have certain guidelines about certain types of forms of breast cancer in younger women, where we will still do genetic testing to understand whether they have a mutation that led them to develop this cancer. And then we can counsel their family accordingly. Having a genetic mutation does not lead to 100% risk of developing the cancer. It does increase the risk to 80 to 85% lifetime risk. And doing surgical risk reduction, like Angelina Jolie did for her breasts and ovaries, reduces that from 85% to less than 5%. So that is how we counsel patients. And I'll tell you, this is the most difficult discussion in clinic. In fact, only yesterday I was talking to a patient who's BRCA positive, and she was telling me कि आपने मेरा ये test क्यों कराया? अब lifelong I'm going to be worried that I will develop cancer in the other breast and in the ovaries. I did not want to know. I do not want to get my daughter tested. So, you don't want to be in that kind of scenario after the test is done. So these tests have to be done very sensibly after discussion with the genetic counselor, understanding the family tree of cancers, and also understanding, like sometimes if somebody has breast cancer, they may also have other cancers in the family. So just doing the BRCA1, BRCA2 may not be enough. They may need what is called multi-gene testing. And that is why a genetic counselor is the best person to have this discussion.
No, absolutely. I think it's also about dealing with that trauma and finding ways to, help patients deal with it. Of course, under expert advice. Dr. Reddy, your thoughts on this interplay between genetics and the risk among, risk of getting cancer?
Yeah, I would like to add some things. So, as rightly said by Dr. Kaur, there is something like we have a genetic testing, and if a genetic test comes positive, most patients become panicked that they're definitely going to get a cancer. So, it's very important to counsel. That is a part of genetic counseling where it is important to counsel that it is not a definite 100% incidence of breast cancer, and there is an option of a risk reduction surgery. So in routine practice, what we see are two sets of patients. One are with too much of fear and too much of neglect. Patients who are with too much of neglect, they don't come forward for gene testing even after counseling. And patients who are with too much of fear, they are actually they want a surgery. In fact, there are patients who are coming to me at that stage where Angelina Jolie had a risk reduction surgery, even without any genetic risk, even without gene testing. They were asked to ask for both the breast to be removed. So here we are encountering two extremes, which is not correct, and the thought should be in between in a balanced way, and the patients have to be counseled in a proper way. And definitely these risk reduction surgeries in the form of bilateral prophylactic mastectomy, bilateral salping oophorectomy, and in case of Lynch syndromes like prophylactic oophorectomy, and as we see in hereditary non-polyposis colon cancer, in familial adenomatous polyposis, a prophylactic total proctocolectomy, and in red proton, which in positive thyroid cancers, especially medullary thyroid cancers, as a part of Menin syndromes, we go for a prophylactic thyroidectomy. All these are prophylactic cancer surgeries which are done in gene positive and risk where the risk is high. So these risk assessment is done after a genetic testing and by certain computer-aided algorithms where it is calculated based on, for example, in breast where the Gale risk model and class risk model assesses the risk, the lifetime risk to be more than 20%, BRCA positive, and multiple members in the family, first generation, second generation, they are positive. So they are assessed by several criteria, and then we opt for a risk reduction surgery. It is not just like that we have a family member positive and then we are definitely going to get a cancer. So that is very important to educate the patients, and then they have to take it in a proper way.
Yeah. Dr. Kumar, is it possible to switch on the camera?
Yeah, hi.
Okay, I will start my next question with you, Dr. Kumar. Radiation is said to be a major contributing factor in increased cancer risk. Do you think use of radiation as a treatment increases the risk of developing other cancers?
So if I handle your first comment that radiation increases the risk of cancer, it's true. We have seen that after World War, Hiroshima and Nagasaki event, there was huge increase in number of cancers there in next 20, 30, 40 years. But if you see the modern radiation techniques used since last 20, 30, 40 years, where you give targeted radiations to the tumor only, and now we don't use much of the radioactive cobalt source in our external radiation. We use X-ray based radiation therapy. These machines, which are modern linear accelerators, which uses these modern X-rays, so risk of second malignancy after say 20, 30 years is very marginal. If you see the actual incidence of cancer and if you see second malignancy in a patient treated by radiation, is not much of the higher value. So they are almost the similar risk. What happens once a patient got cancer first time? So there are few changes, few lifestyle, or you can say working environment related, or is habitual, that he is prone to have second type of malignancy. as we say in head and neck cancers. So once a patient had first time head and neck cancer treated by surgery or maybe radiation, he or she is tend to have second malignancy, and it is known as a field cancerization. But yes, theoretically speaking, radiation causes little higher risk as compared to a population which has not been exposed to radiation.
Right, right. Dr. Kaur, Dr. Kaur, am I audible?
So Ruhail, you went off. So I think
Yeah,
would you
there was a
would you want
network
to
problem.
repeat?
Yeah,
Yeah, no worries.
yeah,
Would you
yeah,
want to repeat
yeah.
your question, please? Thanks.
Yes. Dr. Kaur, has COVID-19 as a pandemic also contributed in increasing the cancer risks? How much and in what intensity has COVID-19 triggered the cancer, kind of been a trigger as far as prevalence of cancer is concerned?
So I think our generation and for many generations to come can blame COVID for everything wrong that went with the society. So COVID came in 2020. In 2 or 3 years, you cannot talk or even look at increased prevalence of cancer related to COVID. Okay, but what we do know COVID did, sadly, it led to patients not coming in time to seek timely treatments. In a country like India, where already patients, most of them come in stage 3 and 4 after being diagnosed, for diagnosis, we did notice in clinic, and I'm sure all doctors did, that patients are coming once the COVID pandemic slightly settled a bit. Patients came saying they felt the lump a year and a half ago in their breast, but they were too scared to come to hospital, so they've come now. So yes, there will be a stage shift, not change in prevalence, but a stage shift. So a patient who could have had been detected early is being detected late because they were too scared to come to hospital. So that was one aspect. The second aspect was treatment related. We do know a lot of hospitals, and this data came from the West, where a lot of hospitals and centers that were offering screening services for, say, breast cancer shut down their screening services for the time when hospitals became overwhelmed with COVID patients. And that has led to a stage shift in cancer being detected in those cultures, in those countries as well. Also, because of COVID, if somebody, say, had COVID infection and developed lung issues, then the optimum chemotherapy that could have or would have been recommended to them may need to be modulated, and they may not be able to get the definite treatment that they would have had received had they not been infected with COVID. And also during chemo, if a patient was tested positive for COVID, even if they were asymptomatic, their treatments were pushed back by 2 or 3 weeks. So we will only in the next few years understand the full impact that COVID has had on the cancer world, but definitely, prevalence will not change. It is when the patient presented at what stage and whether we were able to optimize their treatments. That is what is the main issue with COVID infection and cancer.
Dr. Reddy, your thoughts on this?
Yeah, if you're talking about the cause of cancer by COVID, nobody can really say right now, because nobody knows about the disease per se for several years, and it took several years for actually finding out some sort of treatment. And we don't know about what changes in the microvasculature, the changes in the lungs, the fibrotic changes in the lungs, the changes in the pancreas, all may cause some problems in the future, but we cannot directly comment right now that it may be one of the causes of cancer. But yes, definitely it has increased the gap in the care, problems in screening, problems in palliative care, problems in access. And as you know, a lot of hospitals, even oncology hospitals, were turned to COVID centers to take care of these patients in need. And there is shortage of oncology personnel also, though we all actually were taking care of oncology patients in fear, they were not coming forward. And that is the reason why after the main lockdowns have come apart, we were seeing more patients at the higher stages. And even to cater the services to these patients, there were some changes in the protocols, like to give neoadjuvant hormone therapy for breast cancers to prevent additional risk if you are going for surgery, especially in elderly women. At the same time, some neoadjuvant radiation in a patient who is bound to have a surgical risk, as it was documented that surgery has an additional risk if we go ahead and then patient has COVID in the perioperative period. So yes, there were definitely a lot of challenges, and the patients had a lot of trouble. And now we are seeing a lot of patients who are coming forward who actually might have cancer at that time, but coming for treatment now. So there is a lot of cancer burden. There is a gap in the screening and gap in the care. Probably things are better now, and then we are able to take care of the patients in a better way.
Right. Thanks, gentlemen. I mean, we are out of time. I really had some more questions, but unfortunately, we just have to stick by the timing. But thank you, Dr. Kaur, Dr. Reddy, and Dr. Kumar, for joining us and taking out time to share your thoughts.
Thank you for having
Thank you.
Thank you.
Thank you,
so much.
everyone. So our next address is by Dr. B.C. Das, Director, Cancer Research, Tumor Virology, Human Genetics and Mutation Research, as he is the Director of Amity Institute of Molecular Medicine and Stem Cell Research. The topic is Cancer Pharmacology, Drugs and Vaccines.
Hello. इसको बंद करो ना. Hello.
Hello.
Am I audible? Yeah. Am I audible?
Sir. Yes, sir.
Just a moment. I'll just sharing the slides, and then I'll.
Sure, sir.
Yeah, is it visible, my slides? Hello? Yes, sir. Yes, yes.
Yes, sir.
Okay. So, good afternoon, everybody, and I thank the organizer of this Healthcare World Oncology Summit, the organizers of this meeting. And today I would be talking on this topic of that screening HPV vaccine, and innovative therapy of cervical cancer, the opportunity and challenges. So I have many slides, but I will try to complete it in time. So let me proceed. So as you all know, all the cancer specialists is a cancer meeting, and everybody knows that the cancer is now it has become the leading cause of death worldwide. And it has been in the Lancet, it has been shown in 21 countries, accumulated data by the WHO, and accounting for nearly 10 million deaths in 2020, and nearly 1 in 6 deaths. So you can see from this picture, it is that it has become the graph on the left side, that you can see that the cancer is the leading cause of death as compared to the cardiovascular, which was in top, but now cancer has become top in the rich countries. But then the middle income countries where India comes in, so there also it is catching up, and very soon it will be the top medical journal Lancet, their global survey along with WHO projected that by 2030, every second person around the world will suffer from one or the other form of the cancer. According to Globocan and the WHO, India's cancer burden will be also double in next 20 years' times. It indicates that the cancer will be epidemic in India, which will be soon maybe the cancer capital of the world. It has already become the diabetic capital of the world. So globally, cancer also looks to be an epidemic. So why should India be a cancer capital of the world? So because cancer becoming epidemic in this due to the uncontrolled pollution, rampant adulteration, contamination of air, water, soil, and so what we eat from morning to evening, and what we do, and what we breathe, and what we use in our daily life, cause heavy exposure to all of us to harmful chemicals, adulterated foodstuffs, lifestyle, smoking, radiation, pesticides, antibiotics, including pathogenic bacteria and viruses, and that affect not only our health, but that is through the health of the plants, animals, and environment. This is how the three healths, the plant health, which from where we take our food and all, many of the vegetables and many of the things, they are heavily exposed to the pesticides and all environmental. This is, I need not to explain the environmental pollutions and the animal health. We take the animal food and all from those, and it affects our human genome or human health, and that's why we develop the various diseases. But then cancer is a genetic disease, not that it is hereditary, but in the sense that the most cancer arise due to the abnormalities in the expression of a specific genes associated with the cell proliferations and growth and their cell differentiation, because the cancer is nothing but the uncontrolled cell proliferation. So this cell proliferation or cell division is controlled by certain genes, which are, if at all, affected by these agents, then it will be a mutations or alterations, and that leads to the abnormal growth. But about 20% of the cancers, also human cancers, are caused by infectious agents. And that there are many, hepatitis B virus, herpes virus, and Helicobacter pylori, even bacteria. But what is today I'll be discussing the human papillomavirus. I think earlier session, many people have just talked about the cervical cancer and SPV. So this is my area, and I am the person who introduced or the pioneered this work in India, and I worked with the pioneer who got the Nobel Prize. He is my guru, Professor Joausen from German Cancer Institute. So I have spent almost 10 years there, and then I started this research in India. And then it is now well established that the infection of human papillomavirus causes cervical cancer in women, and pathogenesis of this cervical cancer closely linked with the SPV infections. It is its interaction with the cervical epithelial cells or the reserve cells, specifically at the transformation zone, which is the squamocolumnar junction, which is mentioned. You can see it in the middle, which is colored, that the upper is the endocervix, there is the ectocervix below, but then it is the squamous colonization. It is called transformation zone. The new cells or the reserve cells are being produced there, and there is also stem cells. So this is I'll come with the end of the stem cells, that why these innovative drugs that we have developed. So that is against the cancer stem cells. So this is if there is infection, so the SPV infection occurs in this squamous junctions. So preferential physical interaction with the squamous with the T zones with stem cell properties, they are affected, and that leads to the tumorigenesis. But just infection doesn't mean that it will cause cancer. SPV research, that persistent infection of the SPV is important. That about almost 100% of the cancer we have shown through national mapping of the SPV and several publications, that the cancer lesions occur due to the HPV, HR-HPV infection, the high-risk HPV infection. There is around 15 high-risk types of HPVs and 10 to 12 low-risk HPVs, which are mainly cause the cervical lesion, condylomata acuminata, or the genital warts and all these warts. So cervical cancer, the statistics, 1,30,000, 30,000 or 35,000 new cases every year, and death about 73,000 deaths occurs. So that is the picture, that every one out of every two women die of cervical cancer in India. Still, though it has become the third or fourth position after the breast cancer, which has taken over the cervical cancer. More than 70 or 80% of the women certainly will get infections in their lifetime. But 90% of these cases, this SPV infection clears within 2 to 3 months' time because of their own immunity. But it takes about 10 to 15 years or 20 years to develop this malignancy, and it has well-defined precancerous and cancerous stages. So it's given a unique opportunity to understand and to screen and identify these early lesions and dysplasia or dysplastic or early precancerous lesions, and they can be well treated. So cervical cancer could be the cure if it is detected early. So these are the classification, Bethesda classification, CIN classification, and WHO classification. So LCL, HCLs, and then severe, mild dysplasia, moderate dysplasia, severe dysplasia, carcinosity, and CIN 1, 2. They have a similarity, just to show that everybody knows, those who are clinicians. And this is a cervical cancer epithelium, that the SPV infection, then it comes to precancer, then to the early cancer, then precancer. And it takes almost 10 to 15 years or 20 years even. So there is ample time to identify that. But since in spite of that, we don't have a very poor screening program, and because of the trained personnel and the government initiative or the public initiative or political will, the SPV is a necessary cause of cervical cancer. That is 99%. We have shown that 100% of the cancers. But this is a genome, not to talk about anything going at the molecular, but it has a genome that is E6 and E7 are the early genes which are responsible for the tumorigenesis, called the cancer viral oncogenes, and the L1 and L2 are the capsid proteins, the principal and the major capsid proteins. But major of the vaccines are produced from L1 region. It is important that we have the first vaccine, though HBV vaccine was there, but then against the cancer, that is against the HBV, hepatitis B virus, but then it is against cervical cancer, against the HPV 16 and 18, which is the major agent that 80% of the cancer are caused by due to HPV 16 and 18 high risk HPV, while the 6 and 11 cause the warts and Papillomavirus acuminata. So this is that the E6 and E7 are genes which are generally it reacts with the two tumor suppressor genes. So this is repeat of the things what are other low risk types in detail, and high risk type 16 and 18 is mainly counts for the almost 80% of the cervical cancer, but then others 31, 33, 45, 39, 35, 52, and there are several others, 13 types are there. But it is just not to bother about whole the cartoon. But what is that E6 and E7 are the viral oncogene. E6 binds with the P53 tumor suppressor gene, which and it gets degraded through ubiquitin pathways, and the E7 the P53 is degraded, whereas another tumor suppressor gene RB, retinoblastoma susceptibility gene, which causes the retinal cancer or the eye cancer in the children. But then this protein binds with the E7, and E7 is degraded. So RB is degraded. So two major tumor suppressor gene, which particularly RB helps in the uncontrolled cell proliferation. So that's is degraded. So there is no the RB is available or the two tumor substance absent. So that's why it leads to the carcinogenesis. So this is I don't go into the detail of this. This is a description of this what I just now described about the genome. But the presence of HPV, high risk HPV, indicates susceptibility to the development of cancer. But it is not that it will immediately develop the cancer. It has to persist for a year or two, and then it gets incorporated into the host cell genome. That's why persistence of high risk HPV infection and its integration into is the critical step in the development of the cervical cancer. So there is a tumor disease transformation only occurs when there is integration. So cervical cancer can be prevented by cervical cancer that already some speakers have already talked, the screening and prophylactic vaccination. But the lack of adequate health infrastructure and implementation of these programs, as I told, the political will and the government initiative is not there. So there is no screening yet, except some few organizations or few medical hospitals, medical colleges and hospitals where this facility is available and restricted. And though pap smear is very easy and the visual inspection is easy, but it is not available elsewhere. But most of the infection is generally automatically cleared by the immune system, but 10 to 12% persist and they develop the cancer. So human papillomavirus cancer, it is curable. So this is the biological behavior or the natural history of the disease. So initially it can be given before infection. You can give the prophylactic vaccines. So these two vaccines and 3 vaccines are available rather. The Gardasil, the quadrivalent and the nonavalent, 9-valent Gardasil, and the bivalent Cervarix. And that can be given in the early 9 to 26 years or 9 to 19 to 26, or it may be going to 46 years, but you need to test like SBSE, you get the hepatitis B virus infections. So vaccine, so you have to get tested. If you are negative, then it can be given the vaccines. So this is, I will not go into the detail. And you know that this is several factors, particularly the earliest marriage in India. The measure of this the cancer is the poor women's cancer, those who are in the village side or the countryside. So this 18 years, now it has become marriages is 21 years, but it was earlier 18 years. That was because of our study. I was in ICMR in 35 years. So there when in director, I became director. So that time, this I published and shown in the Lancet that the 18 years is the earliest marriage. The below 18 years, they are more susceptible for HPV infection and high incidence of cervical cancer. So that is there. There are 12-year study, and we showed that in the HPV detection. So after that, it was introduced in the health ministry that it will be 18 years, and later on it has become 20 years. Then multiple partners, poor genital hygiene, pregnancy, number of pregnancy, and many of the smoking and all these factors, ethnicity and religious dietary factors. So what happened is these Lancets and the WHO has answered that there is a paper in the Lancet, and there we said that towards global elimination of cervical cancer in all groups of women, particularly in the North and Southeast Asia, Asian countries, that the there is a formula: 90%, 70%, and 90%. 90% the vaccination, the girls, the adolescent girls can be vaccinated 90%, and at least 70% to 80% can be screening can be done at the age of at least 35 years. At least one time screening. That is the Shankar Narayan has already shown in the Tata Memorial study in the Barsi, the rural registry, that one-time screening can bring down the 50% of the cancer downstaging can be done. So that's why the one-time screening or 2 times at 45 years can be screening, so that by 2030, the goal of WHO that whole world can be eliminated with the cervical cancer, and those who are positive, they can be 90% of them can be treated. So these are the diagnostic, early detection, pap test, cytology, colposcopy, and BELI, visual inspections, and SPB DNA test. That is the most reliable, and hybrid capture 2 or CARE HPV. But there are also opportunity. That's because this takes almost 1 to 2 decades to appear the cancer. So any type of elimination, the preventive measures can be taken. There are herbal, there have been clinical trials. We have introduced several clinical trials which have been done, and these are references have been given. So like Artho Basu, and then the Shukla et al. These are International Journal of Cancer Research and Clinical Cancer Research. So there are several the herbal products can be used for 4 weeks plus minus the menstruation period, and topically, and that can when the HPV infection occurs, that can be easily removed or eliminated before they get integrated and persist for a longer time. So early detection by pap test, these are simple the cytology that it shows that the right side picture, you can say the LCL, but as HPV infection showing the coilocytes. That is a specific structure. It is because of HPV infection. Left side is the HCL, which is showing the precancerous lesions of the nuclear deformations. The HPV DNA testing technique is important and essential for the early detection of the high-risk populations for triaging the CIN lesions. So the dry papers are there. For this easy techniques we have introduced for HPV, that is published in the Lancet in the urine. You can take from home, you can send the urine, and HPV detection can be done. This is 100% correlated, and there are easy method of just need not to extract DNA, just boil the cell pellet, and then in that tube itself, you can use the PCR mix, and then you can have the PCR data within a 1 hour time. Or it can be collected in dry paper smear. So these are all published things, but urine method is a very excellent method and easily non-invasive method. The women against gender, the HPV vaccine was introduced in 2006, and that is Gardasil, the quadrivalent, nonavalent later on, and it has been done also a study. We have done that the Tata Memorial study has shown that with the Shankar Narayan that one time the 2 doses can be sufficient instead of 3 doses of these vaccines, the 0 to 1 month or 2 months and 6 months doses, the booster doses, Cervarix, bivalent, and these are the dose schedule, but it has come to 2 doses, and target population is 9 to 14 years initially, but it can go to 9 to 26 years before marriage, or it can go to 46 years still if you are not infected, if you are found to be tested non-positive, HPV negative, you can take this vaccine. Acceptance by the parents, there are a lot of ethical issues, the religious issues, cultural issues, but HPV vaccine in this scenario. So I'll take just 2-3 minutes. So total, this is a study done in AIMS by Nirja Bhatla. So she said that this is a Cervarix, and it has been 330 populations they did it, and she showed that this is very well tolerated and immunogenic, highly immunogenic, and compliance was 97%. So, but the problem came when it was in 2009 9 to 10, and when this path from it introduced that the HPV vaccine, the immunogenicity testing in two places, Khammam district of the Andhra Pradesh and the Vadodara district in Gujarat. And that time it had, there are 6 girls, there was given to the school girls the travel area, but then 6 girls died of this, but they are unrelated to, proved to be later, they're unrelated to the vaccination. But all the people, all the women activists and other activists, they said that there are irregularities in the conducting the vaccine trial, and so this matter is to the court, and this is hanging in the court still date. But that's why there are more than 100 countries has introduced the vaccine, and in UK and US, but in India, which is the top cervical cancer incidence, but we have not yet been able to put in our national vaccine immunization program yet. That is very safe, and there is no political will now. Government attempt, or there is no. Everybody is very silent. But though the WHO has called for the elimination of cervical cancer, it is more appropriate for the India. But WHO has supported the government of Punjab and for HPV vaccination program in district of Bhatinda and Mansa in 2016. And Delhi has taken this HPV vaccine program introduced, and in the public health program in the school children. So this has the 2 states has taken, but it has not become the, one can get privately in the private clinics. You can have the vaccination. Those who are educated parents, they generally go and get their daughters vaccinated. So this is available, and there are new 2nd generation vaccine, the DNA vaccine, 9-valent vaccine. I told you there are Serum Institutes of India, Pune, but this has not come into the vaccine cost. Though we have come into Mark, and the GSK has bring down the price, but the Bharat Biotech, we don't have our indigenous vaccines till they are under productions. We have also, when I was director of ICPO, which is an ICPR now of the ICMR, I started the vaccine chimeric DNA vaccines. This was vaccine construct has been prepared. The time is less. I will not just go into the detail. We made the vaccine construct, and we have seen the serological test developed to detection of the HPV, anti-HPV 16 antibody, because we have had the Indian variant HPV 16 vaccines construct, and that is the beauty of that. And it was observed in the that they found that the V16 the variants was the most immunogenic, and they are so it seems to be 2-fold higher immunogenic than other vaccine the variants. So it is in the animal trial, but if it is expected, because of COVID, it is delayed too much. So it may be 2-3 years time. It will be going to the human trial, and we will be able to bring that vaccine. This is a chimeric vaccine, both 16 and 18, and it is a DNA vaccine. So once given, 1 dose is sufficient. So just 2 minutes. So there are all these horrible products are there. So curcumin and this is the clearance. But novel drug discovery, that is the last point. That is 2-3 slides. The folate receptor mediated targeted delivery, the curcumin, and the drugs, the chemotherapy drugs to the cancer cell, along with the cancer drugs, developing a triple conjugate. It's called triple conjugate. The drug, there is no drug available to target the cancer stem cell, which are responsible for the relapse or recurrence of the cancer, all types of cancer. We are doing in other cancers also, breast cancer also, but I am presenting here the target that delivery the curcumin to cancer and cancer stem cell by triple conjugate drugs, where we have the curcumin and the triple conjugate, where we have the drugs as well as folate receptor. So what we have shown, that we have not much time, that why these cancer stem cells are resistant to the radiotherapy and chemotherapy, because ABCG2, that they have the protein product, they produce this protein, ABCG2 protein. That protein reflects out these cytotoxic drugs and radiations, and that's why they are protected and they remain in one corner, 1 or 2%, and after 5 years, 3 years, 5 years, they repopulate and they become aggressive. So this is the triple conjugate. We have the doxorubicin, and we have made the linker with the curcumin, with the doxorubicin, and the folate receptor. It is delivery. So we'll not go into detail. It is delivery because it is well-established system for the targeted delivery, the university drug to the through siRNA, protein toxins, and anything. So the folate uptake follows a natural vitamin uptake, endocytosis pathways. The folic acid being used as a targeting ligand. Folic acid can retain. So it is the folic acid can be conjugated with the carboxyl group, with the hydroxyl group of the curcumin, with the ester bond, and the ligand that goes to the inside, like this picture, the vitamin uptake procedure. So you have the high receptor expression in the cell membrane, and from there the invasion is the caveoli or the clathrin pits. It gets into the cell cytosol, and then in the cytosol pH, this will break down, and the bond will break down, ester bond, and they will release the curcumin and the doxorubicin, and the curcumin will sensitize the cancer stem cells. So that has been already been shown by us and published, and then the doxorubicin can kill those cancer cells, cancer stem cells. So we have shown that it is known that the folate receptor is not normal cell expressed. So it is only expressed by the cancer cells and cancer stem cell, barring these few lung, placenta, and thyroid, and fetal lungs, and trachea, and kidney. Besides that, other cells do not express folate receptor. So it will go to only to the cancer cell. So we have the non-toxic small molecular weight curcumin folic drug conjugate, which can especially go to the taken up by the cancer cells via receptor mediated internalization due to overexpression of the high affinity folate receptor, will yield the curcumin, and upon enzymatic cleavage of the ester bond. This approach will improve the bioavailability of the, we have made the little modification to bioavailability of the curcumin and targeted delivery of the curcumin along with the anti-cancer drug, also prevent the non-specific metabolic inactivation. So identification and of therapeutic target and development of the conjugate drugs for cervical cancer for relapse-free survival of the targeting cancer stem cell, which has the major principle, the main principle of the factor of the cancer recurrence. So this is the concluding slide, last slide. The novel curcumin folate drug conjugate may open the excellent, because we have already in clinical trial in animals, the possibility, and it has been patented for a medical innovation and targeted delivery of drugs on the chemo-radio-resistant cancer stem cell in order to make the cancer treatment most effective and relapse-free. Together, HPV vaccine and screening, and above this triple conjugate drug for the relapse-free survival, if we go ahead with that, and that will make the our cancer treatment most effective, and we can expect by 2030, if not 2030, by 2050, the India should be cancer-free, cervical cancer-free, like our polio and smallpox. But screening must be done, and the HPV vaccination should be 70 to 80% to 90% should be done, and if detected, they should be treated 90%. So this is all about I wanted to share with you.
Thank you so much,
So this
Dr.
is
Das.
Thank you so much.
Thank you so much, sir, for your time. We're very grateful. Thank you so much.
If there is any questions, I would be allowed to answer, though I have overstepped little 10 minutes or so, 5 minutes, 5-7 minutes.
No
Dr.
problem.
Das, it was extremely useful. It was a very, very good session, very insightful. And very elaborate. Thank you so much for taking out time to share that knowledge with us. We'd love to also invite you again for a session which is dedicated on this, because this is something which is very, very important. Thank you so much. So Kavi, can we have the next panel, please?
Yes, sir.
Thank you. Thank you very much. Thank you.
Thank you, sir. So our next panel is on different cancer treatments and therapies across the globe, hits and misses. The panel chair and moderator is Dr. Indu Bansal Agarwal, Director, Radiation Oncology, Narayana Health Super Speciality Hospital. We have Dr. Mandeep Singh Malhotra, Senior Consultant and HOD Oncology Services, C.K. Birla Hospital. Dr. Rajat Bajaj, Senior Consultant Medical Oncology, Fortis Hospital, and Dr. Dinesh M.G., HOD Surgical Oncology, Altius Hospitals. Welcome.
Good afternoon, everyone. And at the outset, I would like to really thank Business World for having me here. And Smriti has been really kind, and she has been in constant touch with me. And it was a very, very elaborate presentation by Dr. Das, and I really had great learnings from it. So now looking forward to my session. Am I allowed to share my screen, please? Give me a second.
Yes, ma'am, now you can share your screen.
Yeah. Just give me a second. Just a second. I'm not able to share my screen.
Salman, can you guide Dr. Bansal?
Are my slides visible now?
No, ma'am, we can't see the slides.
Okay. Just a second. I'll reshare them. I'm not able to go to my desktop.
Salman, are you there? Can you please guide Dr.
Yes, ma'am. You have to share. You can.
No, actually, I'm not able to go to my desktop to share the screen.
Ma'am, you are co-host now, and you can share your screen.
Just a second. So the problem is when I'm trying to share, it's on my desktop, but it's not showing my desktop. Should I mail in a minute?
Yes, please.
I'll mail it to Smriti in a minute, and I'll start the conversation side by side.
Sure, ma'am, no problems.
Yeah. Sorry for the inconvenience. I've just sent it across.
No problem, ma'am. Thank you.
Okay. So we have the topic which has been given to me is different therapies, cancer treatment therapies across the globe. And I have the privilege to have a very, very illustrious panel with me. And we have Dr. Dinesh MG, who is a very senior HOD and senior surgical oncologist from LTS Hospital, Bangalore. Welcome you, sir. And I have Dr. Mandeep Singh, and I've worked with him. He's the HOD and Director of Surgical Oncology, CK Birla Hospital, Gurugram. So it's a privilege to see him again. And at the same time, I have Dr. Rajat, who is a very dear friend. He's a medical oncologist working at Fortis Hospital, Noida. So let's proceed further. So I would just want to understand from Dr. Dinesh. Dr. Dinesh, we are talking about very hi-fi things today, and we are talking about different therapies. But I just want to have a basic question, like why do we think that at this point of time, even after so many years of treatments and so much advancements in oncology, we have not been able to control tobacco, I mean, which is the main cause of cancer death. And 30% of cancers, they are caused by tobacco. 80% of lung cancer deaths happen due to tobacco. So what do you think is the basic reason? And in the meantime, if someone can tell me, the slides have slides for me.
See, speaking about tobacco, hi, I'm Dr. Dinesh. I'm a surgical oncologist from Bangalore, working in Altis Hospital. Speaking about tobacco, like, I think past 2-3 days I've been speaking about tobacco because it was a no tobacco day yesterday, 31st May. And we know that this gutka is banned, at least in Karnataka it is banned since 2013. But still people get all the ingredients, they try to mix it and they form their own gutka. And some packed gutkas also they're selling without any advertisement, they are doing it. So I don't think so they're strict about this gutka ban. So we see a lot of oral cases, oral cancer cases here. Especially in northern Karnataka, we see a lot of oral cancer cases, and that too, they are all not so affordable. According to me, for tobacco, I don't think so. We are strict about this ban and whatever banning of gutka, and also the smoking in public places is not banned. I think they are not so very strict in Bangalore, at least.
So we have such strict regulations for drug abuse. I mean, we all heard about Shah Rukh Khan's sons also. And in spite of that, tobacco and alcohol, I mean, there is not much ban on this. So we have people from business world. And so I would really request you people to put an emphasis, because whatever we might say, we might move, step up the ladder, do robotic surgeries and whatever. But if we are not able to curb the basic problem, the root cause of the problem, I think whatever advancements we may do, we will not succeed. Has someone shared my slides, please? Is someone helping me with the slides, please?
Yes, ma'am. Smriti is getting it done.
Okay. Okay. So now coming to Dr. Mandeep. Dr. Mandeep, again, a very, very basic question that I'm coming to, because we are talking about hits and misses. So I think in my 25 years of practice, I've been facing this issue every day of telling the patients to get a biopsy done. But that's a very, very big problem. Even people from very educated families, they come to us and they say, कुछ भी करा लेंगे, biopsy नहीं कराएंगे. कुछ भी करा लेंगे, आप डॉक्टर साहब बिना उसके ट्रीटमेंट चालू कर दो. Although we know it's an era of personalized medicine, but how often do you come across this situation? And do you think we can do something concrete? This is the biggest miss I feel in development of oncology services. So what is your take on that?
Thank you, Dr. Indu. And I really agree. 200 times I agree with this, with you on that there's a big myth around the concept that biopsy कराई चीरा लगाया तो बढ़ जाएगा. मतलब एक इतना ज्यादा एक पूरा myth इसके अराउंड बना हुआ है कि चीरा नहीं लगवाना है, और चीरा नहीं लगवाएंगे और तब तक वो डायग्नोसिस नहीं होगा तो especially Dr. Dinesh was talking about oral cancer, and North India also is more or less the same as South India about the incidence of oral cancer. So we also see a lot of oral cancers, breast cancers, everywhere. The concept is that okay, you do anything, you diagnose it without a biopsy. And because of this very reason, that we don't want to get a biopsy, a chira nahi lagwana, the cancer actually, when it is a smaller cancer, they would not get a biopsy done. A small lesion, they would not get a biopsy done, and that is not diagnosed. And then when it comes to advanced stages, at that point of time, obviously we are getting all the investigations from a biopsy to PET CT. And again, through you and business world, I would really request that this myth of not getting a biopsy done and biopsy से cancer बढ़ जाता है, वो एक बहुत ही बड़ी myth है. इसको please आप address करो. If I do a biopsy, I don't treat, definitely cancer will increase. The problem is that whatever has happened is that people get a biopsy done, the cancer is diagnosed, and majority of time the cancer is being diagnosed at advanced stages, and obviously the patient then succumbs to the disease, and everything is attributed towards the biopsy. इसने biopsy कराई थी इसलिए इनकी death हो गई. अगर biopsy नहीं कराई होती तो शायद वो कुछ नहीं होता. So please, we have to address this.
So Dr. Dinesh, you must also be coming across this situation. So is there any particular situation when you proceed with surgery, even without a diagnosis? And or if you proceed directly with surgery, so suppose so many patients come to us with a breast lump, where we get where the patients get an excision biopsy done straight away rather than getting a true cut biopsy, ultrasound guided true cut biopsy, and then they have to undergo a repeat surgery because of the first incomplete surgery first time. Or so many times we come across females who have undergone a hysterectomy straight away on an ultrasound report which showed a fibroid and it turns out to be malignant. And then patients, they have to undergo a repeat surgery, or it's an incomplete surgery. Sometimes we have to offer radiation as well. So how many times do you come across this situation where people have been, because fortunately we are sitting in big corporate hospitals where things are systematic, but most of the patients are being treated at smaller centers or in standalone clinics or in small nursing homes, and we come across such patients. So is there any message which you want to give to the audience who is there for the benefit of the patients, please?
Yes, like you told, I think first we should educate our own colleagues, not oncologists, I'm telling, the others who are any GPs, any other surgeons. So I think instead of doing surgery directly for any breast lump, it's better they do some true cut biopsy, or they send them to an oncologist who does the true cut, and if they can send them back. If it is benign, obviously we will send them back. So most of the, even, I don't know, I'm not blaming any other doctor, any surgeon. So many times we do get cases where hysterectomies have been done, and that's when they come to know that it is CA cervix or CA endometrium, something like that. Or many times it is the ovarian cyst where they rupture and they send. So all these cases we have seen, but like you told, sitting in corporate, we get such cases only. So I don't know how do we educate our colleagues. That I think we should address.
Smriti, can I see my slides now? Smriti, please share the PPT, please.
Yes, Salman will be sharing.
Yeah. Is my PPT visible now?
Yes.
And thanks for this help. So someone will have to move it. Okay. So next slide, please. Next slide, please. So we talked about some basic problems, but there is some good news also along the way, because over the years, what we have seen is that since 1991, there is a 29% decline in death rate, which is a good news. 150 plus new drugs have been introduced for treating cancer since 2006. And as per one data, ASCO 2020, 2.9 plus million deaths have been averted in US. We don't have the Indian data, but this is a this is a thing to smile about. And this is because a lot of developments are happening, not just on prevention of cancers. We had a very elaborate presentation from Dr. Das just a few minutes back. We are diagnosing cancers early. Now we are seeing many patients with CA prostate who are coming to us and in stage 1, and we are able to treat them very nicely. The advancements have happened not just in the field of radiation oncology, medical oncology, surgical oncology, but in molecular oncology field as well. So we are able to cure many patients, and in fact, what we can say now is that 2 out of 3 people are able to live for 5 years, which is a very good news. And because of all these advancements, we are able to now give a very good quality of life to our patients. And I don't know why we don't have a radiation oncologist in the panel, because we know that I think I'll have to do the job myself. So 50% patients are cured by surgery, 40% patients are cured by radiation alone or combined with surgery and chemotherapy, and 10% by chemotherapy alone. But of course, this figure goes very much high if we combine radiation and surgery. I think Dr. Rajat is not able to join in. Someone will have to let him in. I think he has joined now. So next slide, please. Welcome, Dr. Rajat, to the panel. Next slide, please.
Now I am there. Yes.
So thanks. So I was just talking about tobacco-controlled cancers, and we know that this is the most preventable cause of cancer. It causes cancer of 18 body sites, and in spite of that, we are just struggling. This is the biggest miss, I think, in field of oncology. Next slide, please. So we all know that cancer is a hungry, money-seeking disease. So we have to use all these modalities, radiation, surgery, and chemotherapy. And we have seen very, very beautiful advancements in the field of radiation. When I was doing my MD way back in 1996, at that time, we used to do 2D radiation planning, but now we have moved to three-dimensional conformal, IMRT, IGRT. And in fact, now we are able to treat left-sided breast cancers with deep inspiration breath hold technique. So which leads to very much decreased doses to the lung and heart. And we have stereotactic body radiotherapy for lung tumors, liver tumors, for adrenal mets, for brain metastasis. We are doing SRS. And of course, we do brachytherapy. And Dr. Hoku was talking about flash radiation, which is the most in thing or the new kid on the block. So, but the problem is that all these techniques are not available all across India. So some smaller centers, they don't have just cobalt machines, and we are not able to treat these patients with the best technologies. Similarly, we have moved from simple biopsy to open surgery to laparoscopic surgeries and to robotic surgeries. We will talk about that. And chemotherapy, Dr. Rajat is here. He would agree with me that we have oral pills, we have hormonal treatments, we have chemotherapy, targeted therapy, immunotherapy, and cancer vaccines. Next slide, please. But the problem is that we don't have an equitable distribution of these services. So, Dr. Rajat, I would like to understand from you, do you think we have equitable provision of personalized cancer care for everyone? Do you think we have reached that stage after 50 years of independence?
No, certainly not. Certainly not. So if we talk about personalized cancer care is a very new concept in medical oncology, and it is still evolving. It has come up in the last 3 to 4 years only, and we have certain tests available that we are doing for individual patients, which tell us as to which treatment modality should be used, and they guide us about the treatment. But then if you talk about the cancer care in general, even that is not available to the masses or to each and every part of our country as of now. I was listening to your discussion about the cessation of tobacco, and the other panelists seem to agree that also we've not been able to really hit the root cause. And same is the case with the cancer care, which is there. So it is not available to everybody, and the quality of cancer care is certainly not available to everybody. So this is something that we really have to look at and work towards it. Personalized cancer care, even in the metros, even in the big cities, is something which is still evolving, and the cost remains an issue because the tests which are done for personalized cancer care are expensive, and not everybody is able to really do those. So certainly bringing the cost down, making the clinicians more aware are really two stems that will help us in bringing more and more personalized cancer care to each and every patient.
Very rightly said. Smriti, I can't see the slides again. Yeah. So if you see this slide, we sometimes we say that cancer doesn't discriminate, but I think cancer does not affect all people equally. But there are a lot of cancer disparities all across the globe. So if all the patients, we have different treatments for children. They don't get the right treatment at so many times. Female sex, LGBT, we don't have any specific treatments for them. People with minor minorities and African Americans, we see they are not included in the clinical trials. Poor people, they cannot afford the treatment, or they're staying so far from the cities that they're not able to get the proper treatment that they should be getting. There is this huge population of adolescent and young adults. In fact, there is a new branch which is coming up, that is tired. We don't have proper recruitment of people from these groups in the clinical trials. Similarly, geriatric population, we don't even know what is an exact geriatric population. Does it more than 60 years of age? Is it more than 65? Is it more than 70? And these are not equally representative in the clinical trials. The technology is not available everywhere. We don't have emotional and psychological support. This is a very big disparity. In spite of, I'm sitting in Narayana Hospital, we don't have a psycho counselor available every day to counsel the patients. Patients don't have access to clinical trials, and more so these numbers have gone down after the COVID. And as I said, we have so many international patients who are coming to treatment for us just because they don't have good treatment facilities in their own country. So we have to move the needle in cancer care for less privileged. Next slide, please. So I would just like to show you, next slide, please. So these are the distribution of radiation machines across India. This is a paper which was presented in 2019. And if we can see from here, then North, it represents 24% of the population. And we have 85 linacs in North, and in South, we have 190. But if you see in Central India, there is just 12, or in the Northeast, we have only 6 radiation machines. So how do we treat these patients well? This is very, very difficult. If we see about CyberKnife, we have 3 machines in North, we have 4 machines in South, and we have no machines in Central, East, or Northeast, or Western part of the world. So this is when we have, if we see, so South is comparatively better placed in terms of access to good radiation facilities. Next slide, please. And although a number of new centers are opening up, but if we still see, we still have a shortage of close to 4,550 radiation machines in India. And I'm not talking about brachytherapy machines. The ideally required for whole country is 1,250. And we have only 250 brachytherapy machines all across India. We have shortage of 1,000 machines. So this is what we are talking about after 50 years. And this is the disparity. These are the misses in radiation treatment all across the globe, all across India. Next slide, please. So what are the hits and misses of radiation? I had to make this slide because I don't have any radiation oncologists in the panel. So hits, I would say, is development of IMRT, IGRT, deep inspiratory breath hold, stereotactic body radiotherapy, stereotactic radiosurgery. And I think a very, very good advancement has been the development of hypofractionation, because of which even the patients with prostate cancer early stage, they're able to complete treatment in just 5 sittings. Early lung cancer, we are able to treat in just 5 sittings. Now we have MRI guided linacs. So the soft tissue delineation is much better. We are able to treat the patients much better. And recently Reflection 11 machine has been installed, not in India, but with which we can do PET based radiation planning. So these are the hits, but things which could not stand the test of time are accelerated fractionation and hyperfractionation. We are talking about protons. We don't know exactly what would be the results in long term, and carbon ions, we don't know. Dr. Dinesh, what is your take on protons? This is the most advanced radiation technology. Do you ever send any patients to protons? We have Dr. D. Cruz, who has also joined here, who does a lot of head and neck work. So Dr. Dinesh, your viewpoint on protons and these latest radiation technologies. Do you think they are hits or do you think they are misses? We can't hear you. Please unmute yourself. Dr. Dinesh, please unmute yourself.
Yes. Sorry. Proton, we have not recommended anybody from our hospital as such now. Anyway, it's only in Chennai now. And it is, once we recommend, it's quite expensive. And I don't think so. 1 or 2 patients, they were not willing to go there to Chennai. One thing is they have to travel there, and it's quite expensive. So I don't think so. Proton, we have not yet sent any patient as such now.
Okay. Can I have my slides back, please? Smriti, don't remove the slides. Okay. So now coming to, I feel, is this the golden era of cancer treatment? Because we know that every tumor has a unique signature and personalized therapies are crafted for each patient. Next slide, please. So as per 2010 data, 12 new drugs were approved by FDA. 348 phase 3 oncology trials were ongoing, 861 cancer drugs in trials, 2,000 plus clinical trials which were accepting children and young adults, 200 plus prevention trials, and 100 plus screening trials. Next slide, please. So are there a lot of missile drugs or molecular tsunamis of site-specific cancers? Dr. Rajat, next slide, please. I want to ask you one question. So, Dr. Rajat, I know I'm asking a very controversial question, but I think all of us need this answer. So, are these really personalized therapies or precision medicine or targeted therapies just fashionable and lucrative, or do you think they really work? Do these postpone death sentence for a few months of remission, or do you really feel that we should go more and more for immunotherapies or targeted therapies, and they'll make a big difference in the lives of cancer patients, and we will be able to not just extend their life by years, but also improve the quality of life? And because these are very expensive drugs, we just talked about proton treatment and 30 lakhs per treatment. So what is your take on these personalized therapies or immunotherapies? Yeah.
Yes. So when I say personalized therapies, I don't really limit myself to immunotherapies, but there are many targeted therapies also which are there, which I would like to include in the answer that I'll give to this question. So I certainly believe and I strongly feel this, and I do that in my daily practice in my OPD also, that I tell my patients that these medicines, they generally work better than chemotherapies, and this is supported by evidence as well as my experience. The response rates are definitely better because you have chosen these therapies after checking the genetic makeup of that particular patient by taking that sample and doing that somatic mutation testing. Also, the evidence says that most of these therapies have been approved by either an improvement in the progression-free survival, or if we are lucky enough, the improvement in overall survival as well. But then, yes, at the end of the day, the clinical trial will never tell you that this is the particular cost. The cost is definitely huge for some therapies. The cost is a little moderate for many of them, and the cost is quite less for some of them. Now, this cost is definitely a relative issue for many patients. So, there will be people who will be able to afford it. There will be people who will not be able to afford it at all, and people who will be able to probably afford it, but with some difficulty. So the cost benefit ratio is something that I really discuss in detail with all my patients. And the cost not only for the next 2 months, 3 months, or 5 months, but they should know that these medicines, because most of them are used in a stage 4 disease, will continue for quite some time. So they have to really weigh their pocket in terms of the monthly cost multiplied by what is the approximate months or the years this medicine is going to work for them. Now, when they take the cost benefit ratio into their mind and they really weigh it, only then I tell them to start these medications. So we have many medicines which have come up in the last decade or so, and some of them have actually been very wonderful. There is no doubt about it. I can give some examples. There was a time when hormone therapy in breast cancer used to be the way to go for a stage 4 hormone receptor positive disease. And before that, chemotherapy used to be given. Then came tamoxifen. Tamoxifen just had a PFS of 8 to 9 months. Now we are looking at CDK4/6 inhibitors, which give us a PFS and a very good quality of life, mind you, very good quality of life for approximate duration of say about 24 months. So we had 9 months on one hand and 24 months on the other hand is a huge difference with a good quality of life. And of course, I would like certainly to have the cost down a bit, maybe 50% of what it is right now. And time is going to come. So when you said that it is a golden era for cancer treatment, I would say certainly yes, because we have certain medications and it is going to be some time later going to be these medications coming into the ambit of many patients. For example, palbociclib, the patent is going to expire in another 3-4 months. The cost will be around 15,000-20,000 a month, which is much less than chemotherapy as well, and much more beneficial than chemotherapy. Another example, lung cancer. I'm sure you know very well that how things have changed in the last decade or so, with the overall survival just being 9 to 10 months, and now overall survival we are looking at 4 years. So certainly they so-called fashionable or lucrative they may look, but certainly they work. But yes, not for everybody. cost benefit ratio has to be seen. And of course, as a medical oncologist, one would feel that yes, cost should come down, but maybe it cannot happen overnight, but over a period of time this will certainly happen. And once the cost come down even more, this cost benefit ratio, which looks a little skewed at times, will become better, and we'll be able to benefit more and more patients.
Very, very nicely put, Dr. Rajat. I think you nailed it. So I think Gleevec is a very good example. Molecular drugs, imatinib, which really worked well, and it changed how the way we treat CML these days. And in fact, immunotherapy drugs for melanoma, they have done wonders. They are now being used in renal cell carcinomas for patients with sunitinib. Like earlier, every patient with surgery would go for nephrectomy first, but now we are able to debulk the disease by giving sunitinib or things like that. And immunotherapy, they are really working well. So we have to choose the patient well. Certain times, combination of drugs, combination of immunotherapy may not work, but we have to see what is working on the patient and what is not working. And it has to be a very, very detailed discussion with the patient so that we are able to improve the quality of life of the patient and extend their life as well. Next slide, please. Next slide, please. Now coming to Dr. Mandeep. Dr. Mandeep, we are here. This is the era of robotic surgeries, and this is the era of robotic surgery. So next slide, please. So we have come a long way from radical mastectomies or extended mastectomies where the whole of the breast would be chopped. And now we have come up to an era where we are doing only breast conservation surgeries, or we are doing sentinel lymph node biopsies, or we are doing for laryngeal preservation, we are giving chemotherapy. So nowadays surgery is changing, and with the appropriate use of radiation and appropriate use of neoadjuvant chemotherapy, we are able to improve the survivals of the patients. We are able to preserve the voice. So organ preservation has come a long way, not just for laryngeal cancers, but for bladder cancers and even for rectal cancers. Now we are coming for wait and watch policy for certain number of patients. So I think these are some of the hits which have come up in the field of surgical oncology, which have made the lives of people better. So we talked about this initially, that the biggest miss ever in oncology was, can a biopsy make my cancer spread? And if you Google it, you will get these many results for just this question. Next slide, please. So Dr. Mandeep, according to me, these are some of the hits like MRM to BCS, sentinel lymph node biopsy, oncoplasty, organ preservation by NACT, and I think total mesorectal excision for rectal cancer is a game changer in rectal surgery. D2 dissection for stomach cancers, use of indocyanine dyes, robotic surgery for prostatic and gynecological cancers. So Dr. Mandeep, you do a lot of oncoplasties, and you are an expert in head and neck cancers and other cancers. So according to you, what are the biggest hits and what are the misses in the field of surgical oncology? What is your take on that?
Yeah, Dr. Indu, it's a very appropriate thing that you have raised. So surgery over the time, like last 50 years of our journey in cancer treatment, definitely it has become, I would say, it has become more. There are aspects which it has become more radical also, and there are certain aspects which it has become more appropriate or less intensive also, where morbidity is less, mutilation is less. Specifically, when I come to breast surgery, so in appropriate cases, early stage breast cancer, those patients who have a very good response to neoadjuvant therapy, so these patients are now amenable to breast conservations. Those without any lymph nodal mets or early breast cancer are now amenable to sentinel lymph node biopsies and all. So definitely we have decreased the mutilation, and more than that, now the research is there which says that those patients, like there was a recent paper which was last in 2018 in San Antonio, it was presented that those patients who had underwent breast conservation, early stage breast cancer, they tend to live longer. Obviously, radiation has played a role in that, but yes, when we say a breast conservation at an early stage, we do include surgery with radiation. So even the survival is better, the quality of life is better, the organ preservation is better, and obviously the female body habitus is preserved. Whereas if I look into the other aspects of surgery, like HIPEC has come into a picture, in which obviously with more radical intent and peritoneal malignancies which are not amenable to chemotherapy and all. So with HIPEC, definitely the survivalist benefit has improved. Secondly, even for if I say head and neck cancers, so yes, TOS for early oral cancer is a very good option, and TOS for advanced oropharyngeal cancer is definitely not a good option. So there's no debate upon that. But yes, selective patients, selective for specifically those patients in which early oropharyngeal cancers are there, TOS can be considered. So yes, like if you have a early prostate, early oropharynx, so it is a robotic surgery versus radiation, and both of them have their own benefits and own other aspects also. So yes, that can be selected by the patient and the treating doctor, and both of them are equally good. But if I also look into other stages of head and neck cancer, like even now with intent of ITF clearance, advanced salvage resections, so we are now able to have a better survival in advanced oral cancers, in post-CTRT, laryngopharyngeal cancers. So all these aspects have also included. And yes, the surgery over the time in selected cases has become less morbid. Surgery over the time, as we have grown in our experience and our learning curve has also become better. So we have become more radical, where survival is much, much better. And other aspects like TME, D2 dissection, definitely it has, so what it is there, okay, appropriate surgery for appropriate stage of disease.
So I think that's a very, very important point raised here, that the importance of tumor boards, I think it comes there, because now we are having more number of patients who are being diagnosed earlier, and even patients with metastatic disease, they are living longer. Earlier, we would never see patients with metastatic disease surviving more than say 8 to 9 months, but now we have patients living metastatic CA breast cancer surviving for 5 years, 7 years, even with lung mets, bone mets, or small soft tissue diseases. And there's this concept of oligometastasis, where you treat the patients with a more radical intent rather than a patient with a polymetastatic disease. And because of the combination of immunotherapy, because of the combination of neoadjuvant and appropriate sequencing of treatments, now we are able to do more radical surgeries, but which have become much better. And at the same time, we are able to preserve the organ function, which is a very, very important aspect, and the quality of life we are able to maintain with these patients. Like for pancreatic cancers, if we talk about earlier, the first step would be surgery, but now we are incorporating more of, say, FOLFIRINOX combination before radiation, before surgery, or in fact, adding a little bit of SBRT, FOLFIRINOX plus radiation, to make the tumor resectable. So the patients who were not operable earlier are now getting more operable. Similarly, for patients, say, as we talked about renal cell carcinoma, with incorporation of sunitinib and immunotherapy, now we are able to do more nephrectomies. For patients with brain metastasis, we are able to do hippocampal sparing, we are able to preserve their memory, we are able to preserve scalp sparing treatments, and so we are able to do re-radiation and in fact re-surgeries, as we talked about, which were earlier not possible. So because patients are living longer, so we definitely are seeing more recurrences. We are seeing patients with second primary tumors, we are seeing patients with oligometastasis, oligoprogression, and all these have totally changed the landscape of cancer treatments. Dr. Dinesh, do you think surgeons will ever be out because we are doing a lot of SBRTs, we are doing immunotherapy, targeted therapy? So do you think that surgeons, anything can replace surgery? Wrong question to ask a surgeon,
Yes.
but still I want your answer.
So I hope that shouldn't be that scenario doesn't occur any day. But I don't think so, because like you told, most of the cancers nowadays, we know that when they come early, surgery might be the only treatment. And as such, we don't have any issues with the people coming for surgery, but many people miss out on chemotherapy. So radiotherapy also is not a problem here. Surgery, they come, but chemotherapy, somehow they don't accept for chemotherapy. Main thing is they know that they will have hair fall and other side effects. So which has to be counseled properly. I don't think so. We are missing anything for surgery, and I don't think so. surgeon will be out-fashioned for cancers at least.
Yeah, I'm glad to hear that. So all of us have to work in unison, then only we can make lives better of these patients. Next slide, please. I think that would be my last slide because we have other sessions also. Smriti, my next slide, please. So I think some solutions are that knowledge conquers cancer. So we have to have more knowledge, we have to read more, we have to understand the interplay of different modalities. Like as a radiation oncologist, I must know how does a surgeon play with his knife and understand the natural history of the diseases, and then understand which patient would need neoadjuvant treatment, which patient would need neoadjuvant chemotherapy, and then proceed further. We have to educate people about cancer, and more work has to be done on prevention and early detection of cancers. We have to provide more healthcare budget for cancer control. We have to create more healthcare facilities and state-of-the-art facilities in every city. And I think this is very, very important that we have to make the treatment affordable and easily accessible to every patient everywhere. And it's very, very important to provide evidence-based, ethical, high-quality cancer care, not just because I have the best of LINAC or we have the best of robotic facility, we should go and operate on the patient or give immunotherapy to every patient. We have to enroll more patients in clinical trials, including children and minority communities. So let's help turn science into a sign of relief for patients around the world so that we have more and more of hits on cancer treatments across the globe in each and every nook and corner of the city, and we have less of misses. We don't cause any comorbidities to the patients because of treatment. Idiopathic toxicities should be minimized. Every patient should be discussed in the tumor board, and the patient should be the captain of the ship. We should lay down all the treatment plans across on the table, and then in a multidisciplinary team, the treatment should be decided for the patient so that we can give a good quality of life to each and every patient. Next slide, please. So that's what I have to say from this side. This is my team, TrueBeam STX Narayana Super Speciality Hospital. Thank you so much for having me here. And I hand over the mic to our illustrious speaker, Dr. Anil D. Cruz. Thanks for having me here.
Thank you so much, ma'am. So thank you, everyone. Next, we have the topic is Innovation in Cancer Research, Different Approaches. Dr. Anil D. Cruz, Director, Oncology Services, Apollo Cancer Centers.
Good afternoon, everybody. Indu, wonderful panel. I enjoyed listening to you, Mandeep, Rajat. Some great thoughts, great discussions. And you discussed equity, which is something very dear to my heart. Can I have my slides up, or would you permit me to do? Okay, lovely. So I looked at the program. There is some disturbance, I guess, from someone's microphone. If you can mute yourself. I looked at the program and I noticed that I was one of the few people who had a topic which is very, very broad. It's something that is very exciting, but I was unsure. Hello? Am I heard?
Yes, Dr. De Cruz, you are audible.
Yeah, okay. Okay, and I was unsure how I would cover this broad topic within 20 minutes. But I'll try to give you an overview of my perspective of innovations. Basically, I have to look at the various approaches. Again, that's a very, very big and wide topic. Unable to finish in 20 minutes, but some key points I would share to you. I bring you all greetings from the Apollo Group of Hospitals, my new home after 30 years at the Tata Memorial Hospital. The motto at the Apollo and of our chairman has been to give the best care to people from the country at an affordable price. And that is adopting whatever is latest in innovation. And there are many firsts in the technology that has been adopted by Apollo. Can I have my next slide? Now we know that cancer, the incidence is increasing. And if it's currently standing at 19.3 million per year and 10 million cancer deaths, it was 12 million in 2012, 18 million in 2018. So it's something that's increasing. 1 in 5 people develop cancer during their lifetime. 1 in 8 men and 1 in 11 women die from this disease. And at any given point, we have 50 million people living within 5 years of a cancer diagnosis. And this is latest Globocan data. So with a rising incidence and a very severe mortality, we need to have innovation to help us conquer or tame this beast. Can I have the next slide, please? Now, the war against cancer is not new. In 1971, Richard Nixon, the then president of the US, declared a war against cancer. 40 years later, this war against cancer continues because there is a major cause of death caused by cancer. In 2017, 1,650 people would die of disease every day, and 168,000 new cases would be diagnosed. The war continued for 40 years, and then in 2016, Joe Biden, the then vice president, declared a new war, something that they wanted to innovate that could help us control this cancer disease. The next slide. Now, generally a common myth about cancer, I think we missed one. Can you go back up? Okay, no, sorry. Go ahead. So, generally, the common myth is that innovations are all technology and technique driven. It is true to an extent, but all these technology and technique driven innovations, they lack a significant change in control rates and survival. In Indu's panel, they discussed about robot, they discussed about SBRT, other things. They do improve to some extent, but at best, they help us improve the quality of life and decrease morbidity. Yet most of us believe that it is the hottest and most sought after treatment. And I think there was also a discussion on the proton. And again, there was discussions that the proton may not, some people said they would not send patients. So I think we need to titrate which patients of ours would go for which kind of innovation and which patients would benefit from that treatment. Can I have the next slide? So then in 2016, as I said, Joe Biden, who was then the vice president, declared a new war against cancer, subsequently got elected as president, and he reignited what we call the cancer moonshot with the White House leadership in its effort again to innovate and set a target of reducing cancer deaths by 50% over the next 25 years. As signed in December 2016, the US has authorized a staggering $1.8 billion to fund the cancer moonshot over a 7-year period. Can I have the next slide? Now, if you look at the cancer moonshot, the NCA had what is called a blue ribbon panel to give thrust on where we should innovate to help conquer cancer. I've listed these in bullet points on the slide, but if you see, I've highlighted them in different colors, basically to drive a point home that to have innovation, you have to have a holistic approach to cancer. Now look at the reds. The reds say establish a network of direct patient involvement minimize cancer treatment's debilitating side effects, and expand the use of cancer prevention and early detection. You have to innovate in this sphere. Look at the greens. Create a translational science network devoted exclusively to immunotherapy. Develop ways to overcome cancer resistance to therapy. Mine past data and develop a 3D cancer atlas. So not only are we targeting treatment, we are also looking at data. That's also huge innovation, big data in cancer control. And then the greens, develop ways, intensify research on major drivers of childhood cancer, and so on and so forth. Can I have the next slide, please? But to me, if you ask what is most important in innovation, it is understanding the biology. And those of you all who are radiation oncologists listening to this, understanding the biology, innovative on how we would give radiotherapy to our patients. And here is a RAM. If the RAM had to be sterilized, and this is an old teaching, it's basically on the 4 R's of radiobiology. If you gave one shot to sterilize the RAM, you would burn the scrotal skin as well as sterilize the RAM. But then if you fractionated your radiotherapy, you could sterilize the RAM as well as save back the scrotal skin. So understanding the biology taught us about the 4 R's of repair, redistribution, reoxygenation, and repopulation. And innovation looking at biology that revolutionized how standard radiotherapy would be given. Can I have the next slide, please? But I think the biggest winner when you look at biology was the story of Glivec and chronic myelogenous leukemia. It started in the 60s when people noticed the Philadelphia chromosome in the bone marrow cells of CML patients. Subsequently, in 1973, researchers at Chicago found that chromosome 22 and 9 and exchanged bits of DNA. Work continued in 1980. They found that there was a translocation resulted in the fusion of 2 genes that created a new gene called BCR-ABL. Can I have the next slide, please? 86, we found that there was an abnormally active form of an enzyme called tyrosine kinase. Subsequently, at the Oregon Health Science Center, tyrosine kinase as possible targets was identified, and there was born in 1993 Glivec, which today has totally revolutionized the way CML is treated. So the biggest inventions, the biggest innovations don't come out of machinery. They come out of understanding the biology, and literature is replete with number of such cases of biology changing how we treat cancers. Can I have the next slide? Advancing the biology, one of the most ambitious projects looking at innovations in cancer research is the International Cancer Genome Consortium. Basically, looking at massively parallel DNA sequencing of tumor and blood of the same patient to discover germline and somatic mutations. So different countries had to look at these kind of mutations in 50 different tumors. And we in India were tasked with the force of looking at it for buccal cancers. As we get more genomic data, we will have more data to help us target better treatment, prognosticate and treat our patients wisely. Can I have the next slide? So towards this, it has been developed now towards precision medicine in medical oncology. Many drugs that are approved by the FDA and the EMA it reveals that just a certain percentage of population change the entire study and get benefit of the drug. But really, it's a minority of the entire study population. If you look at all innovations in medical oncology, the number to treat for one to get benefit is normally about 10. So basically, precision medicine is a new innovation intended to tailor treatment personally for single patients. In the broader concept, they're looking at precisely tailoring therapies to subcategories of disease. This is possible because today genomics have become widely available and cheaper. And a classical example in innovations in this kind of precision medicine is lung cancer, where you look at different mutations of EGFR, ALK, ROS, etc. And this has happened now in various other things. Further expanding this genomic molecular is cancer immunoediting and gene editing. We know we've got two types of immunity, innate and acquired, and there are a number of targets, the macrophages, dendritic, phagocytes, neutrophils, NK cells, the T and B lymphocytes. So immunoediting and gene editing with the CRISPR technology is something that is being worked on, and hopefully in time to come would help us target many more cancers. I think the classical example of this gene editing is at present in cystic fibrosis of the lung. There have been advances in cancer as well, but the immunoediting probably, can I have the next slide, has translated into our journey on immunotherapy. If you hit, it will show the timelines, but I'm not sure in this PDF version whether it will happen. Can you hit on that and just show us the timelines of immunotherapy? I'm not sure it's not showing up. Ideally, the slide should have been advanced by the speaker because it's a little distracting. But I had various timelines to tell you how the immunotherapy journey came up to 2000 when we found the new immunotherapy drugs that showed benefit in melanoma and subsequently are now used for many, many solid tumors. Can I have the next slide? Another approach to innovations is drug repurposing. Basically, this is looking at drugs that are already developed, repurposing them to use cancer. And the idea of this is that you can avoid the preclinical and probably phase 1 studies as well. In any drug development, $2.3 billion is required from bench to bedside, and this is an average. So if you do drug repurposing, you probably would cut down on the phase 1 and the preclinical studies, decreasing the costs and the time taken to get it to the clinic. Can I have the next slide? And again, in innovation, there are multiple targets that people use for drug repurposing, and they are all listed here in the slide. There are various targets. Hot off the press now, last week, is the JAMA article on metformin for breast cancer, using this oral anti-diabetic drug, presumably having number of functions, but probably the mechanism of action through the insulin pathway was what was postulated, but did not find benefit. But there are various others, and I've listed so many of them up there, looking at vascularization and other targets in drug repurposing. Can I have the next slide? Again, this may not play, but this is a surgical innovation looking at both the laser as well as the microlaryngoscope with the laser and the robot, both cutting on the supraglottic larynx. I don't think these videos will play, but could I have the next slide? Showing that robot has proven in many cancers to be useful and beneficial. And here I have put this endoscopic approaches to a cancer that I treat, and that is head and neck cancer. We look at the first column of microlaryngoscopy, the second column of nasal endoscopy, The third column of TORS, which is transoral robotic surgery and robotic thyroid across 4 functions of oncological safety, functional cosmetic benefit, complications, and cost effectiveness. And you can see there's a yes for most of it. Again, showing you that this minimal surgery, remote access surgery, not only in head and neck, but across the board has proven to be very beneficial. Can I have the next slide? Innovations in radiotherapy, there have been multiple, the way we fractionate, the way we do other things. But here I'm just showing you proton. I don't have to discuss with this audience the benefit of proton. Basically, it's a heavy ion. It goes into the tumor, decays at once. Unlike conventional radiotherapy, where there's a long entry and exit beam causing a lot of side effects. Can I have the next slide, please? And here again, this may not play because it's basically to show you the pencil beam technique on how the proton beam can act on the tumor, literally hitting each of these black dots in this pink cartoon that you can see at the bottom, and spray paint or dose paint the disease without causing side effects. Can I have the next slide? Or minimizing side effects. And multiple cancers, there are multiple benefits across various cancers. And again, a very, very busy slide. But if you look at the top box of pediatric cancers, you can see it has minimal effect on growing tissues and minimal or less radiation to normal tissues and across the various spectrums of cancer. So innovation with machinery, both for surgery and for radiotherapy, is something that helps us treat our patients more efficiently. Next slide. Protons also cause a significantly lower incidence of second primary cancer. And here is data looking at 558 patients with proton compared to photons from the Massachusetts General Hospital, showing a significantly, statistically significant lower incidence of second primary cancers. Next slide, please. But I think innovation should be something that best suits our need. And here is the Jaipur foot. There were various type of prostheses, but Dr. Sethi then did this Jaipur foot. And that's the kind of innovation that we need in countries such as ours. Can I have the next slide? Here is a study that we did when I was at Tata's, basically using a simple form of chemotherapy called metronomic chemotherapy, which was low dose chemotherapy. Case in point, a farmer, left panel showing an advanced piriform cancer, given low dose metronomic chemotherapy. Look at the 4 photographs on the right panel showing near complete resolution of tumor. What is this metronomic chemotherapy? Next slide. It's low dose chemotherapy. Metronome is an instrument that a musician uses to keep time to the music. You keep giving low dose chemotherapy. It does not kill the cells directly, but it affects the blood supply. And again, this was a cartoon that would very nicely demonstrate this tumor getting killed with the blood supply slowly turning to black with each dose of chemotherapy. Can I have the next slide? So we did do a study when I was at Tata. I've just put the phase 2 study. And now can I have the next slide, please? We looked at a phase 2 study looking at conventional chemotherapy with cisplatin and combination chemotherapy with low dose methotrexate and celecoxib. Can I have the next slide? And here is arm A and arm B, more or less equally balanced for site and patient characteristics. Can I have the next slide? And if you look at the efficacy parameters, you can see that they're more or less the same, the progression-free survival and the overall survival. Can I have the next slide? The toxicity is much less when you give your patient low dose metronomic chemotherapy as opposed to standard chemotherapy. You can see that the side effects are much lower in the arm. Can I have the next slide? But most importantly, the cost varies between a few hundred rupees to thousands of more costly. Again, you can innovate with traditional medicine. An example that I've shown you with a Nobel Prize medicine winner in 2015, looking at a novel indigenous drug in China called artemisinin, which is used for malaria. Exactly the same, and DBT is funding a lot in innovation using local products such as haldi or curcumin, green tea, and antioxidants. Can I have the next slide? But we know that cancer, the incidence is rising and the mortality is rising. Innovations has really not impacted in a big way when it's only focused on the machinery and various other things that I have shown you. You can see the projections of WHO going all the way to 2013, saying that the incidence of cancer mortality will increase. Can I have the next slide? So I think we need to have a holistic approach in innovations and not only look at only machinery, not only look at fancy equipment, but focus on prevention. And we have innovations for tobacco control, for infections, which is the HPV vaccine, various diet modifications that we need to think of. We need to detect our cancer earlier, screening, strengthen our healthcare systems. And we've got a lot of studies from our country looking at low-cost screening for cervical and oral cancer with mortality as an endpoint being reduced. And I think most important, we have to innovate to make our patients have equity and accessibility to treatment. And it's not unusual that we have innovations, but really it widens the care gap because it makes treatment more costly and therefore does not help all patients to benefit from the innovation that we have. So while we innovate, we must keep in mind costs and see that patients all over the world can benefit from that. Thank you very much for your attention.
Thank you so much, Dr. De Cruz. So now, next up is Dr. A.S. Soin, Chairman, Liver Transplant Surgery, Medanta, the Medicity. He's going to talk about liver cancer, the causes and solutions. Dr. Soin? Good afternoon, sir.
Yeah, hi, good afternoon. So shall we get started?
Sure, sir.
Okay, thanks very much, Kavi. Good afternoon, everyone. Thank you very much, Business World, for inviting me to talk about liver cancer. Bear with me, my medical colleagues, because I've actually prepared this presentation for lay public. So I'm going to talk about liver cancer as non-doctor community should understand it. Am I allowed to share my screen? Yes. Can you enable screen sharing, please?
Just a second, sir.
So you are co-host and you can share your screen.
So
Yeah,
you
but
can
I mean,
share the screen.
okay.
Yes.
So, okay, that's fine. You can see my presentation now, right?
Absolutely, sir.
Right. Fine. So today we're going to talk about liver cancer, specifically primary liver cancer, which is hepatocellular carcinoma, or HCC, as it is referred to in medical terms. We're going to look at what causes HCC or liver cancer and its treatment, and also prevention. We all have heard of the terms jigar ka tukda, jigari dost, jigar rakh. So obviously, since time immemorial, the importance and especially the importance of liver in emotional well-being has been understood right through the Vedas and the Sushruta times and in modern medicine. So jigar is liver, and a healthy liver is supposed to be really the pinnacle of emotional well-being. And of course, emotional well-being depends on physical well-being. So that's how important the liver is. The liver actually has nearly 500 important functions in the body. And what it does is it basically takes the food from the intestines, whatever comes to it through the blood, that means the toxic products or absorbed food substances like proteins and fatty acids, drugs, infective organisms, anything that comes through the blood eventually passes through the liver. And of course, whatever we inhale also passes through the liver. So liver is really the processing area for everything that the body, that enters the body. So you have food, chemicals, raw materials, everything coming in, and then liver is responsible for the secretion of bile, which helps in digestion of fats. It also makes glycogen, which is the form in which the fuel of the body is stored, and this is converted to glucose, which is then the body fuel, which is used by the entire body, all the organs, all the muscles, and so on. And it processes the food particles absorbed into usable forms. It manufactures proteins, so liver is a factory. It manufactures or converts inactive hormones to inactive forms of hormones to active form of hormones, and it also functions as the organ that secretes the proteins that serve as carriers of everything that moves in our blood. It detoxifies alcohol, drugs, viruses, bacteria, and it stores nutrients. And what it does is, after all the processing, the substances are poured back into the blood, and of course, the organs, muscles, bones use this fuel, and whatever is the waste is excreted through the kidneys and back through the breath. So that's how liver is really central to how our body works. And now straight away we'll jump to some anatomy. And I know that those of you who are not doctors may not understand this very well, but this is the liver broken down into the right side and the left side. The right side has 4 segments and the left side has 4 segments, segments 1 through 4, and the right side has segments 5 through 8. So a liver is a privileged organ in that it has 2 blood supplies, the arterial blood supply. This is the arterial blood supply. This is the venous blood supply. So liver receives blood from 2 kinds of blood vessels, the artery and the vein, And then, like it happens in all organs, it receives blood and then it drains blood out towards the heart through what's called the hepatic veins, the right, middle, and the left. And this is the inferior vena cava into which it pours the blood. And the green part is the biliary tree. It's like a tree which has several small branches in the liver, which eventually pour its bile into the big bile duct, which eventually leads to the intestine. This is important to understand when we are treating these patients who have liver cancer. So let's straight away now jump to liver cancer. Liver cancer is the 3rd most important cause of cancer death in the entire world and also in India. There are more than 50,000 new cases of liver cancer happening in India. But here's the thing. Here it is very different from any other cancer in the rest of the body. For example, cancer in the kidney or cancer in the brain or cancer in the breast can arise in a previously healthy organ, but not so in the liver. Almost all the cases of liver cancer happen in a previously diseased liver. Diseased liver means it's affected by some disease, and I'll talk about which diseases. And therefore, 90% of liver cancer is actually preventable. And what's not commonly known is that 70% of liver cancers can actually be treated successfully with normal life expectancy or significant prolongation of survival if timely help is sought and given to these patients. Now, let's now get into what causes liver cancer. I told you it happens in a liver which is previously diseased. And what are those diseases which result in liver cancer? Well, most of the liver cancer arises in what's called a cirrhotic liver, which means a scarred liver. So this is normal liver. This becomes scarred or cirrhotic. And then with the cirrhosis, cancer can develop. So that can happen because of four main diseases. One is non-alcoholic fatty liver disease. Second is excessive alcohol or alcoholic liver disease. And the third is hepatitis B, and the fourth is hepatitis C. So non-alcoholic fatty liver disease is now the cause of 30% of serious liver disease. Put it another way, 1/3 of us have a fatty liver. 10 to 20% of those will go on to develop serious liver disease. And out of the ones that develop serious liver disease, 20 to 25% will have liver cancer. So fatty liver is not a benign problem. And this can happen to people who are not taking alcohol. And the prime causes are uncontrolled diabetes, obesity, abnormal lipids or cholesterol, sedentary lifestyle, and some genetic predispositions. And of course, everyone knows that excess alcohol causes liver disease, hepatitis B and hepatitis C. These B and C spread exactly like AIDS. That means through infected needles, through sexual contact, through infected blood, dialysis machines, and so on. And through basically blood and infected body secretions. So their prevention can also be done in exactly the same way. Now, the diagnosis of liver cancer is established with an ultrasound of the abdomen and some blood markers of cancer called AFP and PIVCA2. And a CT scan of the abdomen then basically confirms the cancer. In some cases, in which it is not able to be diagnosed by a CT scan, we can do a MRI scan. Or in cases where people have kidney dysfunction, they will have a MRI to diagnose this problem. And then a PET CT scan is usually done on these patients, which means there's a whole body scan to understand where all the cancer is spread. And interestingly, this cancer usually does not require a fine needle aspiration or a biopsy to diagnose. Usually the features are characteristic enough on imaging or the CT scan and MRI for them not to need biopsy in most of the cases. But in cases where there is a diagnostic dilemma with the surgeon or the hepatologist treating the patient is not sure of the diagnosis, then they might do a biopsy. So how do you actually catch cancer? Well, you have to, it's quite simple in liver cancer because, like I said, it happens to people who already have a liver disease. So anybody who is high risk, that means they have one of the four diseases that I spelled out on the previous slide. Such people should have regular ultrasound of the abdomen and alpha-fetoprotein done. It's only a blood test every 3 months. And a CT scan should be done every year in such high-risk patients. So that's how you pick it up early. There are no specific symptoms or signs of liver cancer, except when it is very advanced and it grows really big and you get pain and you get a big mass in the tummy, but that's not really a stage that can be helped much. That's a very advanced stage. Now, treatment. Again, now I'll resort to a little bit of literature here. We've had in the last nearly 25 years, two major publications about how to first of all stage cancer and how to treat liver cancer. And the conventional teaching is that if there is a single cancer less than 5 centimeter or 6.5 centimeter, depending on which criteria you use, and 3 or less cancers, then a transplant is possible, and transplant is curative. As you can see, 85 to 90% patients will survive long-term after transplant for liver cancer, as long as there is no involvement of the blood vessels and there is no presence of cancer outside of the liver. That's conventional teaching. That's practiced in majority of the parts of the world where liver transplants are done using cadaveric or deceased donor organs, because they are a societal resource, so there have to be rules on who can have it. But in the living donor liver transplant scenario, which is what we do in India, patients with more advanced cancer can also benefit with liver transplant. I just wanted to touch upon this, but now let's go to simpler things. So when there is a single lump, which is less than 2.5 to 3 centimeter, then you can simply burn the cancer under ultrasound guidance. And that is called radiofrequency ablation. When the cancer is a bit bigger, then what you do is you enter the artery of the liver. I told you there is an artery and a vein, portal vein and a hepatic artery that supplies the liver. So you enter that through one of the blood vessels, either in the wrist or in the groin. You access them just like an angioplasty of the heart. You put in a little tube, which is called a catheter, and through this catheter, you inject chemotherapy, and that's called trans-arterial chemoembolization. So that's treatment for cancers which are less than 5 centimeters. But that's not the ideal treatment. That's treatment done for people who cannot or will not have liver surgery or transplantation. Details are obviously beyond the scope of this talk, but just for you to understand, there is a way of burning it. There are other methods of burning it, but RFA is the most common. And there is a method of putting chemotherapy into the liver tumor so that the body does not suffer the side effects of this chemotherapy. It's localized chemotherapy. Then if you have cancer restricted to an area, then that part can be removed. That's called liver resection. And then, like I said, liver transplantation can be done for cancers which are there in a cirrhotic liver, which are restricted to the liver, which haven't involved the blood vessels of the liver. So this is just a representation of a liver transplant. A donor liver is split into two, and this part is then transplanted into the patient. And of course, the patient's bad liver with the entire cancer, with the entire liver with the cancer is removed in liver transplantation. So these are options of treatment. A word about CyberKnife. Now, CyberKnife is a pointed beam of radiation that goes only to the point that we want it to go. And this, along with another form of radiotherapy called TER or CERT, can't explain details here, is good for treating patients who have either cancer beyond, is good for treating patients who have cancer beyond transplant or beyond liver resection, but they're also good for treating patients who have cancer in the liver plus cancer in the portal vein. So the cancer has invaded the blood vessels of the liver, but there is no cancer spread outside of the liver. So the portal vein cancer is then treated with radiotherapy of this type and the TER type. And after these two kinds of radiotherapy, we are then able to transplant these patients once the portal vein tumor is resolved in about 70% cases. Now, these are all published data, but I will spare the non-doctors from citing any real scientific literature here because they won't be able to understand it. But just to say that we at Medanta Hospital have evolved a treatment for advanced liver cancer, which is involving the portal vein of the liver, by first treating it with radiotherapy and then doing a transplant. Now, obviously, prevention is important. So the trick in preventing liver cancer is to prevent liver disease altogether, because only people who have liver disease will get liver cancer. So you have to control your obesity. Obviously, the weight should not be more than 10% over what is allowed for your height and gender. So control obesity, diabetes, and lipid levels, and of course, lifestyle, regular exercise, and avoidance of fatty foods and sweet foods. Also, you have to have a balanced diet, you have to have good sleep, you have to avoid excess alcohol, and everyone must have hepatitis B vaccination. And of course, Hep B and hepatitis C and hepatitis B can be prevented just the way AIDS prevention is done, in terms of using disposable needles in hospitals, cleaning your machines, and regular and strict monitoring in blood banks for donor blood, testing such blood if they are from hepatitis B or C infected patients. Now, this cannot be used for transfusion. And of course, avoiding risky sexual behavior. So these are the methods of preventing liver disease. And that's what should be done to avoid getting liver cancer. Now, already talked about fatty liver. Just to again reiterate that overeating, overdrinking, and overweight, they all are bad for the liver, eventually can cause liver cancer. And in terms of alcohol, the safe limit of alcohol for men is up to 14 units a week, and for women, up to 10 a week. And if you take more than this for 8 years plus, then cirrhosis and cancer can happen. So eventually, you are what you eat. So green leafy vegetables, citrus fruits, garlic, ginger, olive oil, berries, beet, eggs, fish, nuts, coffee, these are all good. And excessive alcohol, sugar, trans fat, processed foods, and red meats are bad. Thank you very much.
Thank you so much, Dr. Soin. That was very insightful, sir.
I'm very happy to take questions if that is how the program is being conducted.
So we're just going over to our next speaker right now.
Okay.
Yes, sir.
Okay. Thank you so much.
Thank you so much, sir. I'm very grateful for your time.
Thank you so much, Dr. Soin. The format does not allow for questions, but we'd look to get you over for a live session where we can have you and our audience can ask questions. That's a promise.
Okay, that'll be a pleasure. Thank you.
Look forward to it. Thank you so much, sir. Bye. Yeah, Kavi, go ahead, please.
Sure, sir. So next up, we have Dr. Piyush Bajpai, Senior Consultant and HOD Medical Oncology, Manipal Hospital. He's going to talk about cancer and genetics.
Yeah, very good afternoon to all. And
Good afternoon.
I hope my slides are visible over there.
Yes, sir.
So I just tweaked the topic a little, and I thought I would speak on cancer and precision medicine, though it's almost aligned to the previous topic. So this is how it is translating into our current practice, how genetics is translating into our current practice. Just wanted to give an insight on that. Of course, I would be touching upon the basics of it as well. So the basics of it is like when we talk about gene, and when we look at the place where all this come from is the chromosome, and we see that in the chromosome of each cell, and we know that this particular chromosome has DNA as the basic material. So this DNA is basically having these particular genes which are there, and these are in the form of multiple pairs of nucleotides which are there. So as we can see it over here, so the genetic material in another term is the software of the cell. So however the software would be while the cell is growing, proliferating, it can actually direct how the cell would eventually behave. So if there is an aberration coming, and that's what we call that, if there is a virus coming in the software, there could be, shutting down of the system. Likewise, if there is a mutation coming up, and if this mutation happens to actually cause the cell go haywire, this could actually lead into cancerous formation, and that's what happens. At the normal cell division, as we can see, is pretty much regulated. So the normal cell division is happening. The cells would proliferate, and it would eventually die as well. So they would undergo apoptosis. That's called the cell death. However, unlike the normal cell, there is no regulation. These cancer cells, which are a part of our body, which are the part of the normal cells rather, and they have gone anarchic, and then they start actually dividing in a very haphazard manner and produce multiple clones or multiple cells like them. So this is what is going to give rise to cancer. And why does it happen is because of a lot of factors, and heredity is one of them. And fortunately, most of the cancer's heredity component is usually 5 to 10%. But there are other more common factors, and that's environmental factors, exposure to chemicals, UV radiation, viruses, smoke, tobacco smoke, and this all can actually affect the DNA of the cell and can actually cause the cell to go anarchic. When we talk about this, actually we see on the two extremes the age group, and this is the child where the body is growing, the cells are multiplying in a lot in number, and a senior citizen where we see that the cell would actually have to age, and the cells would actually have apoptosis, that is cell death would happen. Now, in either of the extremes of the age, if the control, the fine balance goes haywire, that is in a child, if there is excessive production of cells, this could lead to cancer, or eventually in the other extreme, if there is because of multiple toxin exposure that the DNA goes aberrant, then we see that such a cell would again turn into cancerous cell. This can happen in elderly age group. So most of the times the cancer happens in the extremes of the age, though we do get to see middle-aged individuals having malignancy, but most common prevalence is in the extremes of the age. When we see that what is eventually a tumor, it's just a accumulation of these cancer cells, as we can see over here in the cartoon on the right, that these cells, aberrant cells, keep on accumulating and form a mass, and this is what is called as a tumor. Now, again, how does this all happen? We see that the normal cell would have the death cues, it would have growth inhibition cues, it would have on these two formats a cell death happening or no cell division happening. Then there would be the survival cues as well as proliferation cues. So on the basis of which the cell would survive or proliferate accordingly. But what happens in a cancer cell, as I told, that these cues are actually, these signals are actually, they form a loop, and then they keep on inciting upon the cell, and which leads to uncontrolled survival and proliferation of this particular cell. Now, oncogene is basically a part of the normal gene, and this oncogene is supposed to actually lead to normal proliferation of the cell, but sometimes these genes, they get amplified, and therefore they've been called oncogene because they were identified in certain subset of cancers. These genes were drivers of cell growth, and therefore these are called oncogene. So these are basically normal genes which have gone mutated, or they have got rather amplified, and they start regulating the cell division very rapidly. Then what are basically anti tumor suppressors genes. So these are genes which are supposed to be the watchmen or the guards for such anarchic cells. And if they take a hit, actually, because our body is good in actually correcting things, but if these guards take a hit, they actually result in the normal cells again going haywire, and the anarchic cells are not controlled, and the replication keeps on happening. So this is how a normal cell would turn into anarchic cells and not inhibited by these tumor suppressor genes, which would be absent in certain individuals. Then it could lead to a rapid growth. And this what actually results, it's accumulation of cells, which is called a tumor, as you can see over here. And then what you can see is for the cancer cell, the body tries to actually inhibit these cancer cells by actually inciting an immune response. So there are all these white blood cells, the T cells, the macrophage, the NK killer cells, they all try to actually kill the cancer cells, inhibit the cancer cells, cause apoptosis. But sometimes these cancer cells learn to evade, and they learn to evade, and that's how they learn to survive. So there is always immune cells next to the cancer cells. They're trying to overcome, but then eventually they also get exhausted, and the cancer cells learn how to evade these particular cells. So this could actually result in, evasion could result in spreading eventually through the bloodstream. So the cancer cells can then spread through the bloodstream and go to other organs. So for example, as you can see in the cartoon over here, that the bowel, that is the large bowel over here, if the cancer cell arises, then it can actually, if unchecked, go to the liver and also go to the lung. So this happens through the spread through the bloodstream. Also, it can happen spread through the lymphatics. So the green channel over here, what you see is the lymph node. This is the parallel sort of pathway along the bloodstream, the lymph node where the plasma or the lymph actually travels. That's the white part of the blood. So talking about what has happened, traditional medicine versus precision medicine, we have got to know, we have now known how the chromosome is, how many genes are there, we know the details of it. So now we can actually harness the power of it, and what we are now using is genetics, immunotherapy, and targeted therapy. Just to give you a glimpse of it, well, how it is done, personalized cancer therapy. Well, earlier it was a bunch of, a number of people all together where one used to actually give some therapy. Now, we are now able to identify, okay, who are the particular individuals with one particular mutation, let's say the yellow mutation. And the yellow mutation, they are all grouped upon, and they get one particular yellow capsule, let's say. Let's say that the yellow mutation is the target gene to be hit. So there is a capsule for these particular mutations once they are all grouped. And this is what is called personalized cancer therapy. This therapy is meant for this particular individual. This therapy is meant for this particular cancer. So this is how one can actually look into better treatment plan. This all started when this publication came in Time magazine, and we know that in year 2001, targeted therapy started trickling in because of the information on the cancer genome. The human genome got completed, and therefore we could identify certain genes where this was one particular medicine, Gleevec, that is imatinib, which was used for chronic myeloid leukemia, and still till now, till date, actually this has caused a magnificent control of the disease over the past 2-3 decades, and the disease now is actually very controllable and is almost reaching near cure rates. So how to detect these mutations? There are ways. to detect these mutations is all starts with getting the tissue sample from the cancer cell, from the tumor. So as you can see in this particular video, in this particular cartoon over here, that the needle is passed through this particular tumor lump in the lung, and this is what is the tissue which is taken. So biopsy is a very important starting point of all investigations. If the biopsy is not feasible, then one can actually consider blood sample, and this is what we call as a liquid biopsy. A liquid biopsy means a blood sample where these cancer cells, the DNA of these cancer cells, as you can see the green spiral, these circulating free DNA are the DNA of the cancer cells. The cancer cell death take place and the DNA is released in the bloodstream. This sample is taken and is sent for analysis, and one can then find the genomic print of the cancer cells. So one particular technology, what we see is NGS, and this platform has helped us in actually laying down the details of every genes, and it helps us eventually, after giving a lot of data, helps us in eventually identifying the available therapies. So how all these targeted medicines act, and what we can see is an example of EGFR mutation which happens in lung cancer cells. And what we see is when these two oval-shaped structures, they bind to each other, they cause across the cell membrane, these two receptors, they come along and a cell cycle starts, and these cells then start proliferating very rapidly. But if in case you can block these this particular binding over here, and that is what is happening, that these particular tablets stop the binding of these particular antigens or these particular proteins over here, then the cell cycle actually stops, the proliferation does not take place. What you can see over here is just an example. Huge mass in the lung. As you can see, this all gray area was a huge mass in the lung, and this patient was nearly on ventilator. After just taking a pill nearly for 7 days, a lot of resolution happened, a lot of clearing of lung took place. So this targeted therapy can act very nicely and can control the disease pattern very nicely. This is also called the Lazarus effect. That is, the patients who are absolutely bedridden can actually rise, get better. So this is what is called Lazarus effect. You need to identify such genes if they are there in these patients. Just some background of evidence. What is the scientific evidence over here? I just wanted to show you this particular medicine in the purple box over here, Tarseva, 150 milligram. This is given compared to chemotherapy. And this is used in stage 4 lung cancer. And you can see that this particular oral pill has actually brought down the death rates nearly 66% as compared to chemotherapy. So it is working much better than chemotherapy is. So it not only improves the quality of life because it's a tablet. So taking a tablet versus chemotherapy is always easier, but it is also improving the survival over here. It is improving the overall outcome, the longevity. So that is what is very important. Another example, a very glaring example of a genetic mutation. If BRCA mutation is present over here in high-grade ovarian cancer, again you see that giving this particular drug, which is called the PARP inhibitor, can actually lift the particular curve, the survival curve, and improve the longevity of the patients starkly as compared to not giving this targeted therapy. This is just a figure, which is a cartoon, which is showing a lot of evolution which has taken place in terms of targeted therapies in various cancers. It's just a snapshot of some medicines. There are a lot more medicines than this, and a lot more in pipeline are coming. So, having said that,
Bajpayee sir, sorry I interrupted you.
So I just
Okay,
Finish my
okay,
talk over
great.
there. Thank you.
Yes, sir.
Yeah.
Thank you so much, sir. So that is Dr. Bajpai. And up next, we have Dr. Rakesh Jalali, Medical Director and Lead Neuro-Oncology, Apollo Proton Cancer Center. He's going to talk about cancer management and prevention, the role of technology in safeguarding lives. Dr. Jalali? Sir, you're...
Yes, can you hear me now?
Yes, sir, you're audible.
All right. So I like to begin by thanking Business World, Mr. Narula Smriti, for giving this opportunity. I was asked to speak something along the lines from technology in terms of cancer management and prevention. So we decided to talk today in this session about proton therapy in the management of cancer, in particular about the impact of technology, primarily because now we have this facility in the country, and I'll share what is the rationale of this therapy and also share with our preliminary experience from our country. As you may have heard from morning by various speakers, that although there continues to be lots of challenges in cancer with its presentation and so on and so forth, but also we are realizing that many of them can actually cure cancer, be cured, and it's been estimated that about 50%, if not more, could survive for more than 10 years. It is, however, tempered with the fact that although they get cured, many of these patients do have some issues long-term, either primarily because of the disease per se, but also disconcertingly because of the treatment. One of the very famous studies came from the US, what is called the Childhood Cancer Survivor Study. And now this has been expanded to 20,000 odd patients, because childhood cancers have very high level of surviving cancer, more than 70 to 80%. So while they were surviving very well, but a significant proportion of them, unfortunately, had a chronic medical issue, and about a quarter, in fact, had severe or life-threatening issue, which impacted on their education, their employment, their day-to-day activities of daily living, and so on and so forth. Now, how to address it? We have seen already enhanced surgical skill and technology. You just heard a fascinating talk on molecular signature-driven personalized therapy, whether it is systemic therapies, targeted therapy, or immunotherapy, high precision radiation, particularly in terms of protons, which I'll be speaking in the next few minutes. And ultimately, the aim is to achieve this fine optimal balance between achieving long-term survival and cure, which is, of course, absolutely paramount for our cancer patients, but also equally, if not more important, to ensure they lead very high quality of life into their day-to-day cavities, what's called. So it's not only the cure, but it's also the quality of cure. Among the various three principal modalities of cancer treatment being surgery, systemic therapy, and radiation. So radiation therapy was started about 120, 130 years old. It was very preliminary and very basic and archaic that time. Over a period of time, we have seen the development of radiation from relatively very simple technology of orthovoltage therapy to megavoltage therapy. In about 20, 25 years ago, there was an era of conformal therapy. And now the current standard of treatment is anywhere between stereotactic radiotherapy, intensity modulated radiotherapy, guided by image guidance, where the delivery of radiation is done under imaging parameters such that you plan very high precision form of radiation, but we also image on a daily basis whether this has been delivered precisely where you want to target the tumor. And then I will, of course, talk about the current, which is taken many people by a lot of enthusiasm, is the current interest in proton therapy or particle beam therapy. India, fortunately, has adopted new radiation technology readily over the years. And because the session is on technology, and I'm just talking for whether it is gamma knife, whether it is local radiation therapy called brachytherapy, stereotactic radiation, cyber knife, tomotherapy, we were among the first ones to adopt as soon as it came in other parts of the world, and of course now the proton therapy as well. The concept of proton therapy, of course, is not very new. It was many, many years ago, Robert Wilson was the first one to demonstrate to us that there could be a potential benefit of proton therapy. And this is typically seen in this very famous cartoon that we show, that the conventional radiation that we use on a daily basis in routine practice, whether it is cobalt therapy machines or the linear accelerators, which is currently the standard of care, use conventional X-rays, which are electromagnetic radiation. They travel with the speed of the light. They have a certain entrance dose. They treat a certain amount of normal tissue, and then there's a significant exit dose. Proton therapy would have, it's a positive charge, a light ion, as compared to neutral charge in a conventional X-ray. They may have a little bit of an entrance dose, but because of their unique physical properties, they dissipate all the ionizing radiation is at the peak, at the end of the beam, what we call, and that is called a Bragg peak. And it was a Nobel Prize was given to William Bragg when he discovered that. And after that, we have this dramatic fall off of the dose, where literally the exit dose is practically nil. So as compared to the conventional X-rays, where the radiation will be given, they will treat a certain amount of tissue, but there will be invariably some exit and collateral damage to the surrounding tissues. While the proton therapy, while there will be entrance dose also will be relatively less, but then if you can define the target near the Bragg peak, they will receive very high dose of radiation, but practically there is no dose whatsoever beyond it. So this was an amazing physical technological prowess which the proton therapy world had. Although it was a relatively old concept, but it was limited primarily to research facilities, which was very, very tedious and very technological demanding. And you couldn't really do it except in physics laboratories or some centers. Although Loma Linda in Berkeley in California did start a small proton unit in 1990, although some of the others were also in Mass General and Loma Linda, as I mentioned, in the US. The erstwhile technology, unfortunately, was very cumbersome. It was called passive scanning. If I have to explain, that was like a torch. The beam used to go like a torch, but the tumors are not like a round, tumors are different shapes. So while this gave a certain amount of radiation dose, was very precise, but the rest of the tissue to spare, we had to use additional material, for example, these collimators and apertures, which was very time consuming, too much hardware. There was a neutron contamination. So basically it was very, very difficult to accomplish in a hospital-based system. Although there was a clear-cut dosimetric advantage. If you look at this conventional X-rays to treat this tumor here, the red part being the tumor, as the technology evolved, it became more and more conformal, shaping around the tumor, but giving some dose to the surrounding structures. And proton, if you see, is beautifully conforming to the shape of the tumor and completely sparing the rest of the normal tissue. And that was the advantage. The significant jump in technology took place about 10 to 15 years ago, what is called evolution of modern contemporary proton beam therapy. And therefore, we always say there is a proton and there is a proton. So proton beam therapy in the current era does not use like a big torch-like material. It uses a small pencil beam, like a laser pointer. And instead of the whole target, it slices the target into several slices, such that, and the energy also has increased from 70 MeV to 230 MeV. We use sophisticated physics algorithms like Monte Carlo algorithms, such that you can literally, what we call, you can slice the tumor in different slices, and this pinpoint goes spot by spot, line by line, layer by layer. So you treat several layers in few minutes, so that you achieve ultra high precision conformal, what is called literally dose painting around the target. And because there is no exit dose, so physical and biological advantages there, it will just remain where the tumor is. There'll be a little bit of entrance dose, but there'll be no exit dose, and you can shape the target very well. The advantage is that you don't have the passive scatter, you don't have any neutron contamination, you don't have any extra material that you have to put in the gantries like the collimators and the brass material. It's just a small pencil beam can do the job. Therefore, there has been a renaissance in the application of this technology. In our country, you have seen these figures since morning, the incidence of cancers and how many people do need radiation per year. So Apollo hospitals were among the first ones in the entire region, not only in the South Asia. It's still in Chennai is the only proton therapy facility in the country, and along the entire Southeast Asia, including Africa. The nearest one, and there are 3 or 4 coming up in the rest part of the world, and the nearest ones are in Japan and Korea. The American Society of Radiation Oncology have this group model policies based on insurance and the level of evidence, and has been seen in that many sites, whether these are base of the skull tumors, very challenging cancer sites where the regular radiation cannot do the job. In liver cancers, we just heard a very good talk from Dr. Soin from liver cancers, spinal tumors, all childhood cancer tumors, because children, the cure rates are very high. It is very critical to spare every single centimeter of the normal tissue, whether it's the brain or the other parts of the body, because you want to preserve their normal function when they grow up. So development point of view, very, very important. So central nervous system tumors, head and neck cancer, sinuses, retroperitoneal tumors, and whenever you have to have re-radiation. That doesn't mean every single case should have proton. It has been estimated that in the next 10 to 15 years, while the evidence accumulates, about 20-25% of the patients would be eligible for proton therapy. And also group 2 indications are where there is ongoing research in other forms of head and neck cancers, for lung cancer, esophagus cancers, abdominal malignancies, pelvic malignancies, and fascinating data coming in prostate cancers and breast cancer. As I mentioned, the work started, it takes about 5 to 6 years, not easy to design a proton facility, was started to the Atomic Energy Regulatory Board. For them also, it was relatively new because it was the first time the country had this kind of facility available. It took several years. These are just some of the timeline and milestones. Eventually, Vice President of India, along with our senior leadership, we could manage to get the clearance from the AERB in December 2018. And 2nd January 2019, we did the first ever patient. We have published 2 very important physics-related papers, basically to characterize the evaluation of the first proton therapy facility in our country. We also have other aids.
Otherwise, at home or maybe during the weekend, Croson is something that can be. Yeah.
You may probably have to mute.
Salman, can we mute? Yeah, thank you.
So there are other technical details to just make advantage of the technology. So while we were among the first ones, of course, all over the country, but we also, because there are only about 120 to 130 proton facilities in the world, although every year we are adding about 10 to 20. There will be a very soon another facility in our country, maybe in the next few months operation as well. Fortunately, we have catered to people from all over the world, from all over the continents, including one patient from South America who came for the brain tumor a few months ago. Our first series of proton therapy was published 2 years ago in a very important journal, which basically characterized that it can be implemented in, this was primarily for children and young adults who are a prime candidates for proton beam therapy. And we have also justified in a recent article in, again, JCO's Global Oncology, that why it is needed in lower middle income countries as well, because of the cost and investment. So there's always this debate whether we should use it in our countries as well. We have already crossed 700 patients in the last 3 years or so. We treat close to anywhere between 35 to 45 patients per day, starting at 7:30 till 10:30. It is a very rigorously calculated protocol that we have. These are the case mix, from brain tumors to prostate to head and neck, gynecological cancers, breast cancer. A good proportion of the patients belong to the pediatric population. And the youngest child we have treated is 10 months, and the oldest person we have treated is 88 years. We did have some challenge on COVID-19, but we managed to get a green zone for the proton therapy patients, so they did not have any much problems in spite of the pandemic. Some of the examples I like to give, this is a very common pediatric brain tumor, craniopharyngioma, has a very good survival. But the important part is that you have to avoid very important structures when they grow, particularly the memory area. And the memory area is done by what is called hippocampus. So you could significantly spare the hippocampi, such that not only is the tumor control and the cure rate is more than 95%, more than 10-year cure rates are available so far. And so far, whatever we have done, although the relative follow-up is only about 2 years, but all the children are doing extremely well, and they are also maintaining their cognition and memory, which is an important endpoint for these type of brain tumors. One of the very complex forms of radiation is called CSI, called craniospinal radiation, where the entire brain and the entire spine has to be treated. In the conventional radiation, when you treat it, you swathe literally the whole body with low dose radiation. Here, what happens with the proton therapy, because there is no exit dose, you can completely spare the thyroid, the liver, the lungs, the kidney, the other abdominal organs, and the gonads, which is again very important in children and young adults. So far, again, very encouraging data. This paper is actually under review at the moment, is likely to get published in, again, a very major important international journal. One of the case examples is very interesting. It's called intracranial germ cell tumors. This is an example with permission of this child who received chemotherapy and went on to have proton therapy. One of the challenges for these children are, although they get cured, they have significant issues in memory and other cognitive and developmental areas because of the collateral damage to the brain, as I was just mentioning. This child really surpassed our expectations. Not only she became very tall because of the endocrine deficits were not there, but she went on to score exceedingly high in her 12th exam. We always joke, how did you miss those 7 marks? And this was again a very encouraging sign for this particular patient. One of the important issues in childhood cancers in general is, as I mentioned, the excess dose, which can actually reduce significant doses from the proton therapy as compared to conventional, to the cochlea, to the heart. Significant reduction of second cancers. About 2% to 20% of the cancer survivors unfortunately develop second cancers in future, partly genetic, partly because of radiation and chemotherapy. If at all there is one indication where significant reduction of second cancer instances, it is because of the proton as compared to conventional radiation. And there is tons of data available out there in the literature to support this plan. Finally, 2 or 3 slides on other sites. My colleague, Dr. Nangia, is responsible for head and neck cancer management team. I see Dr. Deepak Sareen talking after that. He will appreciate that oral cavity actually is one of the commonest cancer in our country. And what we have demonstrated is both in young patients, but also increasing in elderly patients, where the tolerance of radiation and chemotherapy, either upfront or post-operative, is always a challenge. Because you can limit the dose to the surrounding normal oral structures, they are able to tolerate the treatment extremely well without any interruption, without any break, without any other issues that is otherwise a problem in head and neck cancer. So we have a very interesting experience so far in head and neck cancer treatment. And for the elderly people, we are running a prospective study called a senior study for geriatric patient population, because this patient population always has issues. In the thorax, because the lung moves, so becomes more difficult. So we are doing again a very technological demanding proton therapy for moving targets as part of a protocol called PROMO, both in the free breathing and breath hold protocol. It's too technical to explain to this in this audience, but suffice to say that again, after several technological innovations, we have now launched proton therapy for moving targets as well. Prostate cancer becoming very common. Dr. Srinivas is the expert with me here. Again, part of a study where we are able to reduce the doses of radiation significantly to the rectum and the bladder, which otherwise is an issue with conventional radiation therapy. And again, very encouraging data for prostate cancers. And so is in GI cancers, whether it is to bridge therapy before transplant or per primum in the liver cancers, challenging esophagus and pancreatic cancers. And again, this is an encouraging endpoint. One of the most encouraging parts throughout the world is an increasing focus on left-sided breast cancer, because when you give conventional radiation, although they can cure many of these breast cancers that preserve the breast also, unfortunately, there's a significant dose to the heart. And with the proton therapy, you can, APCC is our Proton Cancer Center, Apollo, you can literally reduce the doses to the heart and all the major vessels, literally to really, really very low levels. And this again is a part of ongoing study where we'll collect the data meticulously and try to come up with the guidelines for future. Finally, although there is an investment in the beginning, there is always this debate throughout the world. Business world is perfect and ideal platform to explain about this. There are several economic models. For example, Marco model, where they see the initial investment, but also see the survivorship. What is the probability of the patient surviving the cancer, but also returning to work? What is his cognitive parameters? What is his growth parameters? Are there any side effects of radiation? It has been estimated that while the investment is more, whosoever invests, whether it is government, private, whosoever, eventually it becomes actually cost effective in childhood cancers, in breast cancer, in some of the lung cancers, and some of the head and neck cancers. And more data is being accumulated for this. As I mentioned, we are very conscious of this technology, and so putting up a lot of research studies such that precious data is collected prospectively and shared with the rest of the world. We recently did an educational exercise of proton practicum, which we do every year. 700 participants from 21 countries participated in it, and we will do every May on this technology. So this was just to give you a snapshot of the technological advances in radiation therapy, in particular proton therapy, and how it is impacting the cancer survival and also importantly cancer survivorship. With that, I thank you very much for your attention.
Thank you so much, Dr. Jalali. Thank you, sir. So that was Dr. Jalali. And up next we have, the topic is oral cancer screening, causes and prevention. For this, we have Dr. Deepak Sareen, Director, Head and Neck Oncology, Medanta, the Medicity, Dr. Shubham Jain, Senior Consultant and HOD, Surgical Oncology, Manipal Hospital, and we have Dr. Anadi Pachori, Consultant Surgical Oncology, Manipal Hospital.
So Kavi, I'll take over
Sure, sir.
for this particular panel. Yeah. We've had discussions around cervical cancer in the morning where Dr. Shada Jain spoke about it. We had Dr. Kanchan Kaur talking about breast cancer. We had Dr. Soin talking about liver cancer. And we heard Dr. Jalali talking about various therapies, proton therapy, etc. But something that we just celebrated yesterday was a No Tobacco Day. And one of the things that people do not take it seriously until they actually face it is the oral cancer. And I think, which is why we created this specific panel where specialists and experts could speak about oral cancer in their own, based on their own experience and knowledge. So we have with us Dr. Deepak Sareen, who's the Director of Head and Neck Oncology at the Cancer Institute at Medanta. He has an experience of over 20 years in this field. In fact, he's been instrumental in setting up this Cancer Institute for Head and Neck department. And his expertise has been in oral cancer, throat cancer, and thyroid surgery, if I'm correct. Dr. Sareen, we want you to speak about the oral cancer screening. And how we've created this panel is where all the three panelists will get about 10 minutes each to speak about cancer screening, causes, and then cancer management. So over to you, Dr. Sareen, to speak about the cancer screening.
Hi, good afternoon. I think it's a pertinent topic for our country because the incidence of oral cancer is the highest in our country. We can be looked at the mouth cancer capital of the world, and about 50% of all mouth cancer patients are actually Indians. So the question now is whether we should screen for it at a public level, or whether we should just spread awareness and have people approach us when they feel they might have mouth cancer. When we institute any screening program, and like there are well-established screening programs for breast cancer, cervical cancer, colon cancer, you do have to think of a program that's easy to administer to the population at risk. And your intervention should clearly prove that there is a benefit by getting better outcomes when you pick up cancers by screening. You also have to do all of this in a cost-effective manner. There aren't that much data available around the world for how oral cancer screening can be cost-effectively done. But one of the important trials that gets discussed a lot was a study done in India and Kerala. And there what they did is they screened populations at 3-year intervals and they tried to see if their screening made a difference in improving the cure of cancer. When they screened the whole population as such, they didn't really find screening made a significant difference because the incidence of cancer is not that high in a general population. So you're really looking for needles in a haystack. But when they restricted the screening to people who were high risk, such as those who take tobacco or alcohol, now you could clearly find that your screening makes a difference and you could improve outcomes by screening. This is a good model that proves the concept. I mean, there is proof of concept that by screening, you can pick up cancers early and you can hopefully improve the results by picking these patients up early. But to implement it at a national stage or to institute a national screening program, that's a totally different level of decision making, because we are, after all, still a developing country and we have resource constraints. And before we deploy any resource anywhere, we need to know that it's being done in a cost-efficient manner. I think we're also looking at a lot of development in technology. So we are harnessing the power of mobiles, and we are harnessing the power of the internet for quickly transmitting data from one mobile to a central repository. And we're also harnessing the power of already prevalent healthcare workers in India, like Anganwadis and people who already have a deep penetration down into our villages. And a lot of development on mobile apps are now there. Effectively, the concept being that a health worker in a village can take a photograph of a lesion in the mouth, send it to a central repository where experts can look at that picture and decide, does this person need to visit a bigger center, or can this be just kept under watch? So I think once we put this technology in, it will really drop down the cost of surveillance, and we might reach a reasonable balance between cost and efficiency of looking for mouth cancer. Anyway, that's looking forward. I think for the time being, what the people of India must understand, and the people who might be viewing in or tuning into this program must understand, is that if you have a warning sign of mouth cancer, you must go see a doctor. And there are a couple of warning signs that are fairly well known. I think from a public information perspective, a lot of good has been done by the ads that have been widely seen. Almost everybody has seen ads that come up before the movies or on the cases of cigarette packets, where everybody now at least is aware that tobacco consumption causes mouth cancer. So that awareness, I think, is fairly wide in our country now. But the next step would be now to make people aware of what are the early signs of mouth cancer when you should seek at least an examination or an evaluation by an expert. So the cardinal sign for mouth cancer would be a ulcer, a sore, or a wound or a lump in the mouth which doesn't heal. And for doesn't heal, we could define it by a period of, let's say, 3 weeks. Because most trivial mouth problems like an accidental bite or injury by food or tooth should fix itself within 2 weeks. So anything that doesn't seem to heal over a period of 3 weeks should need an evaluation with an expert. And this would help pick up many, many people in early stage, which is unfortunately rare in our country. The majority of people present with advanced stages. There are other warning signs as well. You can have loose teeth. You can have dentures that don't fit very well, unexplained bleeding in the mouth, some difficulty or pain in swallowing, and sometimes ear pain. So there are other features also mouth cancer patients can have, but by far the cardinal sign is a wound, ulcer, growth, or lump in the mouth that doesn't go away. One of the reasons people often present late is because pain is not seen early in mouth cancer. And because it doesn't cause pain early in its growth period, the lack of pain doesn't alarm patients. And they think because there wasn't pain, we didn't have anything serious going on. But unfortunately, with mouth cancer, pain is generally a late sign. It generally happens when the cancer's grown, invaded deep. And that's the time a lot of patients will seek help. And unfortunately, at that point, the cancer's already moved beyond stages 1 and 2. The last thing that I've seen in my experience, and after this, I'll be happy to hear from the other panelists, is sometimes patients do reach a doctor who takes a look, suspects cancer, and advises what's called a biopsy. So a biopsy is a process by which we take a small amount of tissue from what looks like the cancer. That tissue is normally the size of, dal ka dana, adha matar. It's a very small piece that is then sent to the lab, and the laboratory will then confirm for us whether this is cancer or not. But there is a widely prevalent fear in our country that doing a biopsy causes spread of cancer. And many patients run from getting a biopsy done because of this fear. I think it's important to be clear that this is a myth. A biopsy is an essential test to diagnose cancer. It's done pretty much all over the world as the gold standard diagnostic test. And doing a biopsy does not spread the cancer. If a cancer is suspected, it is the correct and the first step to do is to do a biopsy. I think that's another reason why I've seen people often will go from doctor to doctor over 2 to 3 months till the biopsy, till they really get symptomatic, they really have bad pain or bleeding, and then they agree for a biopsy, but they try and avoid it at all costs before that. These were my thoughts. I was happy to share them with everybody, and I would be keen to hear what the other panelists have to add to this.
Thank you so much, Dr. Serene. I think that was very insightful because, but I have one question before I move to the next speaker. When you started speaking, you mentioned that the incidence is higher among people who are consuming tobacco and alcohol. So does that mean that people who are taking alcohol may not be taking tobacco, or also have a higher, incidence in getting oral cancer?
Yeah, absolutely correct. So there is plenty data that has come from population-based analysis that both tobacco and alcohol are independent risk factors for mouth cancer. Both together work synergistically. So it's even worse. It's a bit like ek aur ek 11 ho jate hain instead of do. But either of them independently is a risk factor for mouth cancer. In our country, we have a form of smokeless tobacco. We all know gutka, pan with tobacco, which is a chewed form of tobacco, not smoked. Very different than the Western world. Majority of the Western world tobacco intake is smoked, whether it be cigarette, pipes, cigars, all of which predispose to mouth cancer. But our country is unique with having this smokeless tobacco as the most prevalent form of tobacco intake. And an excellent paper from, I think 3 years ago, 2019, showed that this form of smokeless tobacco also increases the cancer risk by 7 to 9-fold. So a very, very high risk of cancer comes with smokeless tobacco. And it's understandable because we take the tobacco, you put it in your mouth, and the carcinogenic chemicals are in contact with your mouth lining for hours and hours and hours in a day. And in our experience, as compared to the West, where the average patient with mouth cancer is in the 60s or 70s, which is a smoking-induced cancer generally, the chewed tobacco-induced cancer often happens in people who are much younger. 40, 45, 50 years of age is the average age coming in our practice. So not only does chewed tobacco cause mouth cancer, it probably causes it earlier and faster than the smoked. And not to suggest that smoking is safe, but it's just to highlight that chewed tobacco is a very, very potent carcinogen. And unfortunately, very prevalent in India, very prevalent in the lower socioeconomic strata who either don't have the awareness or the logistics to reach an institute of expertise in time, and often present with very high volume disease, which is always a challenge to cure.
Right. Thank you so much, Dr. Serene, for your time and very insightful information. I mean, I wasn't aware that alcohol is equally, people who are consuming alcohol are predisposed to cancer. Thank you so much for sharing that. Now I'm going to welcome Dr. Shubham Jain. Dr. Shubham Jain, thank you so much for waiting. Dr. Shubham is the HOD and consultant for surgical oncology at the Manipal Hospitals, Delhi. And his field of expertise has been breast oncology, thoracic oncology, vascular access, sarcomas, and melanoma. Am I correct in pronouncing these words?
Yes, Mr. Harvinder.
And one thing that I also see in your profile is that you have focused on hereditary cancers.
Yes.
That's something which is just gets my attention, and also you have been focusing on robotic cancer surgeries, and in fact you are certified in Da Vinci robotic surgeries, among many other things. So welcome to you, Dr. Shubham Jain. We would be very, very keen to understand your knowledge on from where Dr. Sareen left, the causes of oral cancer. Right?
So,
I'll hand it over to you. You have your own 10 minutes now.
Yes. So, Mr. Narula, first of all, thank you for inviting me over here to speak on this topic. I couldn't have agreed more with Dr. Sareen in stating that awareness is probably the only factor which can help us in fighting this pandemic of head and neck cancers. Would be surprised to know that it is the second most common cancer that affects Indians, and it is the most common cancer that affect Indian men. The causes, as Dr. Sareen was saying, actually appropriately, are these, but just for the sake of our audience, I've captured it on a slide so as to make it more resounding. If I can just share my slide, is that possible?
Absolutely, absolutely. Salman, can you make him a co-host, please? Oh, awesome, you're there.
Is my slide visible?
Absolutely.
Okay. So, brief introduction about myself. I'm Dr. Shubham Jain. I've previously worked at Tata Memorial Hospital in Max Saket, and I'm presently heading the Department of Surgical Oncology at Manipal. Today, I will be discussing with the audience about the causes of oral cancer. And Dr. Deepak Sareen has already started elucidating on that, that most of the oral cancer, the cancers of the mouth that we see, especially amongst Indians, is because of the smokeless form of tobacco that we consume as Indians. It could be gutka, it could be kheni, zarda, pan masala, masheri. What happens actually is because of the constant contact that the cheek tissue or the mouth tissue is in with these carcinogens, and because the mixture with saliva of these carcinogens makes it slightly more potent, slightly more invasive. It's not just the area that comes in contact directly with the smokeless form of tobacco that's put at risk, but also what we call in our medical terminology is a field cancerization, where the entire mucosa or the inner lining of the mouth becomes a probable site or comes at risk for developing any cancers in the future. Not just that, because the consumption of such form of tobacco is so prevalent that nearly 1/3 of Indians are consuming some form of tobacco or the other. That is why these cancers we see are in actually hordes. And because of the awareness or access to the healthcare facilities is not very approachable to people who are in the lower socioeconomic strata, unfortunately, most of the cancers that we see are relatively in advanced stages where there are eroding the bone of the jaw, or it is affecting the skin, or the neck nodes are involved as well, because of which our results are slightly compromised despite the best of efforts. So smokeless tobacco does contribute as a major proportion of patients that are at risk for oral cancers. The second, obviously, is smoking. Smoking in any form, be it cigarettes, cigars, or BD, does also increase the chances of developing mouth cancers, in addition to other forms of cancer such as the lung or the pancreatic cancers. What Dr. Sareen was also telling about was the consumption of alcohol, and he very rightly pointed out that in fact, if somebody is consuming tobacco either in smokeless form or as smoking and with alcohol, it actually has a multiplicative effect. That is just what Sir said is ek aur ek 11. The consumption of alcohol with any form of tobacco increases the chances of somebody developing oral cancer. What it does not definitely mean is that if somebody has not had developed cancer despite having a heavy use of tobacco or heavy consumption of alcohol is that some person is in any way immune to it. It can happen at a later point also. It happens to people who are much younger or have not had an exposure to this as well. Even today morning, I have operated on an 80-year-old lady who developed a sore in the tongue, and on biopsy that was identified as cancer. Now, a reason to that is friction with the sharp tooth as well. So what has happened to her was that a part of her dentition was lost because of age, and a rear tooth placed in the backside of the jawbone was hitting against the tongue. Now that friction caused a chronic ulcer. These abnormal cells gradually developed over time into cancer. And so having sharp teeth as well can be a risk factor for developing oral cancers. In addition to that, heavy use of spices or diet rich in spices has also been noticed as a risk factor for causing mouth cancers. In addition to that, what we are now seeing is sexually transmitted diseases such as human papillomaviruses can also cause cancers of the throat or the mouth. Excessive sun exposure also can be quite a reason in patients who have lip cancers or certain oral cancers as well. So traditionally, these and syphilis as an infection that was previously noted when it was more prevalent in the society to be causing oral cancers, these are called the 7 S's, which are known to increase the chances of developing oral cancer for any individual. So I've tried to capture all these in a single slide so that it can stress upon the audience. It obviously makes it easier for anybody to prevent oral cancers as long as they know what increases their risk or increases their chances. And that is why it is so much more important to understand these risk factors and to be aware about them. Awareness is the key in being able to fight any cancer, so that if the patient knows by themselves that they are at high risk because of these certain factors and they develop the signs or symptoms that Dr. Deepak was talking about, they should immediately seek attention and should not shy away from the suggested line of treatment. Thanks, Mr. Harvinder. I'll be happy to take any questions from you or from the audience.
Dr. Jain, I think that was so insightful because, I'm actually very, very surprised because a lot of this information getting shared by Dr. Sareen and now by you is something that, is not so commonly known because, the first thing is that tobacco can cause cancer, that smoking can cause cancer, but people who don't smoke or they don't chew tobacco, they feel that, they are not prone to this. But that the 7 S's that you've shared have a few things that actually surprised me. For example, I didn't know sharp teeth could be the reason where, cancer could be initiated or spices or sun exposure. It's thank you so much for sharing these 7 S's with us. I think it's going to be really, really useful to everyone who's listening to this or will listen to this when it is uploaded online.
Absolutely. And what we could agree is that all of us have some certain level of exposure to these factors. None of us are immune entirely. So what it effectively says is that anybody can develop an oral cancer and that you should be aware about the symptoms and should not hesitate in approaching a doctor to seek opinion of some sore is not healing or there is some abnormal swelling somewhere.
Right. So I have one question to you before I move to Dr. Anadi. People who chew, because a very large population I see, forget about tier 2, tier 3, even the large metropolitan cities in the upmarket society, we see a lot of people chewing pan, and they feel that, hum pan kha rahe hain, it's without a tobacco. So is that also a cause or a cause of concern for oral cancer?
Absolutely. So the mechanism of any cancer developing is a constant trauma or repeated trauma to a particular area. What any pan masala or any smokeless tobacco form does is it causes micro abrasions in the inner lining of the mouth at multiple levels. And because these are habit forming substances, a person inadvertently tends to consume these products over a long period of time. Now, when this cycle of repair and healing happens more frequently in the body, it increases the chances of any cell developing some abnormality. And then when that abnormal cell starts multiplying at a rapid pace, that is when the cancer starts happening. So it's not a one-day thing that an exposure happened a day and probably a month down the line somebody will develop cancer. Rather, it's some exposure which has happened for years and a long period of time that a person gradually develops such a problem. And even that, it's not an overnight development of a problem. It wouldn't just spread overnight. There will be warning signs, there will be symptoms. It's just that we not being aware of the potential causes tend to ignore the subtle signs. And that is where the problem starts.
Got it. One more question, because it's very important. I take up this question. You said that it causes anything that causes abrasions in the mouth can be a cause for a future cancer, right? So from a personal hygiene point of view, is there something that you recommend people to do as a personal care for their mouth from hygiene point of view so that you can protect yourself from such abrasions?
So, for example, for elderlies, if they're ill-fitting dentures, they should definitely get that checked and the denture should be evaluated. Personally, if you examine your oral cavity thoroughly, even once a month, that makes you conscious to a great level of any recent or new abnormality developing in the mouth. So you can probably seek medical attention earlier. As far as any other abrasion is concerned, if there are sharp teeth that is constantly eating, you should definitely see a dentist at the earliest to get that thing sorted out, because sharp teeth, as I was discussing, can be a starting point for cancer as well. Apart from that, just abstaining from tobacco in any form is helpful. Abstaining from alcohol will be helpful. And it's not that people who are not getting exposed are immune. Even they don't have the option of being ignorant about these warning signs and symptoms. It's better if you know about them, and basically it will probably help you seek an opinion earlier.
Got it. Thank you so much, Dr. Jain, for your time and these insights. I think this is going to be super useful for everyone who's watching this. I'm now going to move on to Dr. Anadi Pachori. Dr. Anadi, would you want to switch on your camera? Dr. Pachori, are you there? Thank you so much, Dr. Pachori, for joining in. Let me introduce Dr. Anadi Pachori. He's a consultant for surgical oncology at the Manipal Hospital. And what I understand is that he specializes in upper gastrointestinal, colorectal, hepatobiliary, pancreatic malignancies, and robotic surgeries. Am I correct, Dr. Pachori?
Yes, yes.
Absolutely. It's such a pleasure to have you with us today. And we have in the last 20 minutes, heard Dr. Sareen talking about screening of oral cancer, and then we had Dr. Shubham Jain talking to us about what are the things that could cause cancer. He spoke about the 7 S's. Now, what I would want you to shed your light on is the oral cancer management. So over to you, Dr. Pachori.
So as it's already been discussed by Dr. Sareen and Dr. Shubham, that what are the causes for what are the factors which can lead to the cancer. Also, they have discussed what the preventions need to be taken to just prevent these things. So what now the scenario when the patient recognize that there is some lesion in the oral cavity, so how they should tackle with that situation. So most of the time, patients have ulcers in the oral cavity. The presenting sign of oral cavity malignancies may be either the ulcer in the oral cavity, or there may be like loosening of tooth. There may be presentation by the neck nodes. So like patient may present there is some lump in the neck which is recently noticed by the patient or the relative. There may be the change in the voice sometimes. So these are all the warning signs when the patient should visit to the clinicians for the evaluation. So as Dr. Shubham and Dr. Sarin already discussed that all these things, whatever the causal factors may lead to the trauma to the oral cavity, mucosa of the oral cavity, and which may progress to the ulcer, and that ulcer may develop into, may show the signs of the malignancy sometimes. So for the evaluation point of view, these patients need a CT scan as well as biopsy. So as Dr. Sarin already discussed, that biopsy is, though it is like there is a lot of fear in the community that biopsy may lead to the spread of the disease, but this is like a very essential and preliminary investigation for establishing the diagnosis of the cancer. Then we have to look for the extent of the disease, that how much it is spread, whether the bones are involved, what are the actual extent. So there is definitely some imaging modality. Most of the time, either a contrast enhanced CT scan or a PET CT scan is recommended at the time. Sometimes for like tongue and for larynx, patient may need a MRI scan as well. And depending on then the next step of the management of the patient is, once you establish the diagnosis, most of the oral cavity malignancies are the squamous cell carcinoma. And once you establish the diagnosis, then next step is to stage the disease. So like, as we know that most of the experts know that the oral cavity malignancies have grossly 4 stages. So like we grossly divide the cancers into 2 parts. One is the early stage oral cancers and the advanced stage oral cancers. So like early stage oral cancers are usually like initial lesions without significant neck node. They are the small lesions which can be treated either as most of the time by single modality, while advanced lesions, when there is a more of one subsite of the oral cavity are involved, let's suppose the bones are involved along with the mucosa, or the skin is involved, tongue is involved with the other part of the body. So, and also depending on the size, other part of the oral cavity, and also on the size and the depth of the tumor, how much is there. So once we, and then after on depending on the CT scan finding and MRI findings, there's radiology findings, then we decide that what is the definitive stage. So like for early stage, so I just want to go a bit brief in this, because otherwise the management of oral cavity cancers stage specific and the site specific is a very long topic. So like for the grossly management of the oral cavity cancers are like for early tumors, we need to go for single modality is usually sufficient, and that modality is either in the form of the radiotherapy or in the form of the surgery. So then different factors come just to establish, just to decide for the patient that what type of, because the radiotherapy is the some 42 month to 40 days to a month, 2 months treatment, while surgery is like quick procedure. You go you will go for the procedure, then recovery will take some 6-7 days, and then patients will like move on. So most of the time for early tumors, only surgery is usually beneficial, but at the subsides where the cosmetic reasons are there, like on the lips, sometimes the radiotherapy is equally good. The important thing is that all the oral cavity malignancies, once they start metastasizing to the other parts of the body, the neck is the first side where the nodes get involved. So we have to take care of the neck nodes as well, and we have to either we have to, like for very small lesions, we can sometimes just can observe the neck nodes, or for the like rest of the most of the lesions, we need to remove the neck nodes. We have to do the staging. That staging can be recently the sentinel lymph nodes is also like being tried for the neck as well. But standard is the type of the selective neck dissection or the radical neck dissection we can go ahead with. And for the advanced tumor, then which means like at least T3, T4 lesions. T3, T4 lesions means which are including more than 2 subsites involving the bones, presence of the neck nodes. So these all lesions are advanced diseases, and the chances of the recurrence having the tumor again after the once it is being cured is very high in this type of tumors. So like we have to add multiple modalities of the treatment. So the three basic modalities for treatment of these cancers are like, along with the surgery, you have to add the chemotherapy sometimes and the radiotherapy most of the times. So like for after the, so surgery is definitely most of the time is required, but only in the conditions where the disease is like involving some great vessels and it's not considered resectable by the surgeons. So in that conditions, only chemoradiotherapy is sometimes advisable. Stage 4B, 4C type of tumors where like it's unresectable and sometimes 4C when it is spread to the other parts of the body, the chemotherapy is, I think, is the only treatment. Sometimes it gives some survival advantage, but as such in trials not like proven for giving some significant survival advantage. So like so grossly for the patient purview, these are the primary management of the oral cavity tumors.
Thank you so much, Dr. Anari. I think this has been super useful. You know, what I understand from your conversation is that you know, the proper management of oral cancer can actually help you delay moving from a stage 1 to a stage 4, and I think that is a key to longevity.
Yes.
Thank you so much for taking our time, all of you. I mean, you know, it has been such a super session by Dr. Deepak Sareen, Dr. Shubham Jain, and for you, Dr. Anari Pachauri. Thank you so much for taking our time.
Thank you.
Thank you. You know, I think Kavi, I'll take it on from here. So we have with us Dr. B.S. Ajay Kumar from HCG. Dr. Ajay Kumar. Dr. Ajay Kumar, can you switch on your camera, please?
Okay.
Awesome.
Hello.
Dr. Ajay Kumar. Good evening, sir. How are you? Sorry to keep you waiting. We took little more time, 5 minutes more than the scheduled time. I really, really appreciate you, you know, being there waiting for us. Before I move forward with our conversation, I want to give a brief introduction about you. So allow me a minute. I think people merit to know about your background. Dr. Ajay Kumar is the executive chairperson of Healthcare Global Enterprises, the company that we better know as HCG. He was in the US and he came back to India to set up HCG. And he says he did that to realize his vision for making advanced cancer care accessible to all. Now, running a healthcare institution not only requires medical knowledge, but also requires certain kind of a entrepreneurial acumen to manage a sustainable venture. Because, you know, a lot of us have a lot of a vision and wish list, but we are not able to manage in a manner that is sustainable for a longer period of time. And he has proven both his medical knowledge and also that he has the business acumen. Now, apart from various accolades, he is also a recipient of the prestigious BC Roy Award. He did his MBBS from St. John's College in Bangalore, followed by a residency in radiotherapy at MD Anderson Hospital and Tumor Institute. And then he also did a residency in oncology from University of Virginia Hospital. Now, what little bit I studied about him online, the two things I figured out what he personally enjoys doing is, one, he's a voracious reader. And second is he enjoys running. So am I correct, Dr. Ajay Kumar?
Yeah, true.
Absolutely. It's such a pleasure, and thank you so much for taking our time to be with us on this panel.
Thank you very much
Dr.
for
Ajay,
having me. Thank you.
Dr. Ajay Kumar, my first question to you is that you took up oncology as a specialization way back in the 70s. You know, what I want to know is what prompted you to choose oncology over other specializations?
See, one of the things for me all along, I've always fought for the underdog, even in my medical college, otherwise. And, at that time in 1970s, there were other non-medical issues. We looked at zamindars taking over farms and all. It always made me look at people who were deprived of certain things. And while I went through the medical college, understanding the normal things in medicine, usual things, cardiology, nephrology, a lot of things were attractive. I always wanted to be cardiologist. But when I saw some patients in my final year of medical college in Bangalore, some of the impressions I carried when I went to University of Virginia had a great impact, saying, what is this about cancer? Because in medical college, you don't study that much about cancer. Cancer at that time was considered pretty much gone, terminal patients, nothing can be done. We all saw patients in advanced cases. Out of curiosity, we used to study them knowing that there is no hope. So I took upon it as a challenge because when I saw people with pain, even in US, Virginia, and people I asked my professor once, why is it we are not able to come up with any answers to these? He said, cancer is such an enigma. That word really impressed me. It's an enigma. There's something we can really do. It's like a mystery. Let us do something. So it was more challenging to me to unravel that mystery. That is when I decided, let me go to MD Anderson. And the way I saw MD Anderson was a game changer for me because I truly believe if cancer is treated the proper way, right, first time, we don't need all this, so-called palliative care, so-called, hospice care, so-called using terminologies like, terminal and all. So with that kind of passion, I started looking cancer into the depth. And over the years, what I learned is whatever I had envisioned at that time, whatever I thought cancer accessible, treat it right time first, all of that has become a reality with HCG. That is what I can say very clearly.
Got it. Now, Dr. Ajay Kumar, you were in the US. You were well established in your profession there. Your family was there with you. Your children were born there. What prompted you to move back to India?
See, what prompted me was all along when I saw in MD Anderson what I did. I had a great opportunity to stay in MD Anderson in charge of a lung program. By now, I would have become one of the authorities on lung cancer staying there. But I decided I want to learn the ropes of how to do a cancer center. Because I always thought I should go back and do something in India. But what really cemented that after starting a center outside of Chicago, I became well-known, 100-mile radius, people started coming out to get partners. But I put one condition, I want to be away for 3 months a year in India. So I started traveling across. And one of the things is I saw cobalt therapy still being done in India. We are a poor country, we can't afford linear accelerator. Then I saw people waiting for hours together in the Madhya Pradesh government hospital. I remember seeing for 12 hours one kid was waiting with a big sarcoma of the abdomen. And this left a huge impression on me. Look, I have to come back and do something. And fortunately, whatever I started, I somehow was able to convince the family. Obviously, being in US, affluent society, doctor means, affluence, lot of comfort. It is very difficult. A lot of people tell me, to leave US and come back is difficult, particularly when the children also grow up, the children prefer US. In my case, somehow maybe the way I had impacted my passion on my children and all my 4 kids have moved back to India. Even the one who married an American moved back and said, we will be with you. In fact, Anjali works with me. She's on our board. So it all depends on, family. We say it's how we bring up. I always made them come to India every year, study. And I have a lot of hospital NGOs. They also work, taught in the school as little kids. So that passion, once you create, India is very attractive for a lot of even people who are born there. All my children were born there. And I also had a green card for 40 years. I never became a US citizen, but I even gave up my green card in 2015. I said, I don't need it anymore. So I know my wife and kids are, of course, US citizens. But for me, once I make up my mind, I am like a focus factory approach. People tell me, why are you in oncology? Why don't you go to others? As you know, other hospitals started with cardiology, they become everything. I never did that. We said we are oncology focused, be oncology. So ours 85% is 90% oncology. So I am like a focus factory approach. So I decided, come to India, work in oncology, see how we can change the way people approach oncology treatment. And that was my vision, to change that perception. And what people thought they cannot happen, like linear accelerator, we can bring. Doesn't matter rich or poor, we can. Because cancer knows only one, right treatment. Cancer doesn't know, this guy is rich, so let him have the high technology. This guy is poor, it's okay, cobalt, I will still give. No, cancer doesn't know that. Cancer knows only one way. Cancer is relentless and we have to be relentless. That's all it is.
So you brought up a very important aspect about the cancer does not differentiate between the rich or the poor. Now, I remember, a few decades ago, there used to be a scenario where if somebody had cancer and the person belonged to an affluent family, and we've seen a lot of celebrity cancer cases brought to light, where they would travel to the US specifically to get the best cancer treatment. Yeah. Has that changed? Does India provide a similar standard, if not better, cancer treatment, and how did this happen?
I can tell you categorically, because I was in US for 28 years, practiced, and I trained in MD Anderson. Today, in India, we have dedicated cancer centers which can provide the same, actually better treatment, because we are more personalized. And with that, I think we are getting better outcome than best of centers. We have done studies on that. We are very big in data collection. And we have published it, even Harvard Business School has published, where breast cancer outcome is equal or better than best of centers. So I can tell with pride that categorically, the way we do our patient care, research, academics, data collection, which was lacking in India for a long time. As we know, we are lacking in research. Where we are leapfrogging today using technology, we are becoming leaders. And the West is so actually worried about it, in a way, because we can compete now. We have the intellectual mind, and we have IQ. A lot of Indian doctors are leading centers in US, as you know, not only doctors, but software companies, big companies like IBM, Microsoft, Google, all. We have the intellectual capacity. What was really choking us, certain things were not happening in India, which was preventing us, like maybe infrastructure, cost. This perception of cost is what was killing us. See, India is different countries, as you know. We have 350 million Indians who are middle class, moving up the ladder, demanding the highest care of healthcare possible. 350 million, maybe only 25, 30%, but it is equal to United States population. It is equal to Europe. Huge population demanding highest, and we are providing today. But somewhere along the line, we get caught in this cost business, because we have nowhere in the world we provide the type of treatment at this low cost. The people come from Africa, Middle East because of the cost difference. And we have the same technology. How can you take a PET scan and do for $300? Whereas I know recently one of my friends got a PET scan in US for $3,000. 300 to same equipment. So we don't pat ourselves on the back as doctors or others, because the media, the political thing always says the cost is too high. Cost, because there is 900 million population who require help. There is no doubt. But who is the responsibility it is? We say, let the government be a monitoring agency. Let them give us challenge and say, look, I will pay what is required, make sure they get the good outcome. We can do it. But problem is bureaucracy, certain political consideration prevent this from happening. We all are fighting for universal healthcare, as you know. When universal healthcare is doable, we have proposed, if that can be done, India will be one of the best countries in healthcare in the world. I can tell you that because we have all the infrastructure, we have entrepreneurs, innovators, we can, and we are great in pharma. We are good. We know, even though we don't make new drugs, we copycat drugs very well, So we have produced at low cost. So all of that we have the means. But certain things are coming in the way. But what we have shown in HCG, where we have gone to tier 2, tier 3 cities, imagine going to Ranchi, Cuttack, putting in linear accelerator, Rangol, so Chumaga, and we showed to the world what everybody thought we can't do. We showed. And once we showed, others are following, which is very good. So it means the linear accelerators are completely replacing cobalt now. High-end quality care, outcomes are getting better. Fear of cancer is becoming less because people know you can live with cancer. It is a chronic disease. It's only chronic disease which can be cured, by the way. It's only chronic disease which can be cured. So when you look at it like that, and when we stop using languages like terminal care, cancer victim, palliative care, we do right treatment. Like diabetologists don't say, I'm giving you palliative care. Do they say that? Nobody says that. Why in cancer we are using? So these kind of terminologies, lingos should stop. And as oncologists, we should start using the right word and give the right staging to the people. They explain to them. For example, stage 4. If you tell I'm a stage 4, people will think they're gone. Not so. If a stage 4, there are different stage 4. If cancer has gone to the bone, breast cancer, they can live for 10 years, even lung cancer. But if it has gone to the brain, liver, everywhere, maybe a year. So there are different types. What does a patient know about it? So we have to communicate properly. This is where you are proper communication, proper technology, using genomics, everything else. I think it will change. And we all follow the Western standards. Indian genomics, nobody has done. So we are started doing. We have done 10,000 patients. 38% of the time, the genomics is different. We are never seen in other Caucasians. So why are we treating the same way? So this mystery of cancer is being unraveled in our country. And with this, I think we are definitely in the forefront of achieving our goals of bringing in, we're already there. We can even improve on the type of quality outcome, not just for the 350 million, but for the entire population. We can do.
It's super, the way you explained it. So, but I'm going to take a cue from what your last answer. You used two words. One is affordability and second is government. So, when you're running an institution, you need land, you need equipment, you need diagnostics, and you need people. And, so all of this costs a lot of money. So when you're talking of providing quality access to healthcare, to access to quality healthcare, it costs a lot of money. What do you think that the policy makers in this country, along with the private institutions, need to do to make not just cancer care accessible, but affordable too?
See, it's a very good question. Let me answer this in a way. HCG, I experimented with HCG by not taking 1 rupee from the government, not 1 inch of land from the government. People said, why don't you write? You're doing a great job. Government can. I said, no, I don't want anything. Now, HCG today is a listed company, viable. But the important point to remember is we have penetrated tier 2, tier 3 cities where we have made all the centers viable. Imagine going to Angol, Ranchi, anywhere, and Nasik. Even 60-70% of our patients may be in government schemes. Maybe whatever we do. So we have come to a decision that it is possible only if government kind of understands this and brings in the universal healthcare. Now, another point I want to talk to you today. I did this at Harvard Business School. Now, what is the difference between for-profit and not-for-profit? Not-for-profit also charges. Not-for-profit also has to pay doctors and nurses, everybody. Only difference always been for-profit will distribute the profits when you make to the investors. HCG has never done that. We have never distributed any yields, any dividends. We create value for investors, but the most important thing is when private equity or companies invest with HCG, they are actually contributing to good cancer care in this country. It's an impact factor. They may not understand that, but because we are not giving dividends, we are using the funds, whatever we make, to bring in better technology, penetrate tier 2, 3, 3 cities. This is the model which can be taken by government and everyone. How did HCG do? How did these two? Can we create such models across where government involvement is less? Government can be only monitoring. But government is not like that. I will also do. I will, because it is not possible. Government cannot be monitoring and also running cancer institutes or any healthcare institutes. It is high time government thinks of what should be the role of government. I am here telling there is a patient who is below poverty. Please give him the best of treatment. I will monitor that. You go and do the treatment. And this is what, you put the technology. I want a good return, good outcome for this patient. That is where the government role. But government, because of certain vested interests, other things, politically, whatever, government wants to run institutions. They want to monitor and it's not possible. So this is a point we have made repeatedly, but unfortunately, the people are not willing to listen. All these people, you take Niti Aayog, all these people, we call them for meetings, we ask them to come and talk and all, nothing happens. It is 76% of healthcare in India is done by private. We have penetrated to small hospitals. Imagine nursing homes, all of that in small cities. They are the ones who have given healthcare to India. Instead of being pride, we put them down. It is not so. Yes, there are issues. There are some people who are not ethical. There are some who might have done certain things to squeeze profits. But there are always like that. Which system doesn't have? But we can eradicate that, provided you make transparency. Now, today with technology, we can make everything transparent. We are already there. So I think time has come for this kind of paradigm shift to happen, and it is happening. Whether anybody likes or not, HCG has shown without any government help, we are servicing people. The amount of free care we give is unbelievable, but we don't talk about it. No patient is refused treatment in HCG. No patient is refused. We know how to manage. If somebody wants to have a cyber knife, which normally costs 4 lakhs, a child or somebody with brain tumor come at 11 o'clock in the night, take a free care and go. Why not? That is our model. And that is how I think cancer has to be treated. Only don't compromise because they can't afford. Make sure you do the right treatment, or don't even do. Once you take on, do the right treatment.
I think that's a very powerful statement. Do the right thing. If you have that intent in your mind, your actions will follow. So I think that's a very beautiful thing. So how many patients does HCG manage? How many cancer patients does HCG manage every year? And how many of these actually come from overseas?
Yeah. We manage about 120,000 new patients a year. Wow. It is one of the largest globally in the network. And one of the things I want to say, there is no network like HCG. See, there are clinics, there are outpatient, but we have comprehensive cancer centers across India, 23 cancer centers across and one in Nairobi. Number of international patients is about 5%. And it is growing, it is increasing, mostly from Africa. But if you look at centers of excellence in Bangalore, it is almost 20%.
Got it. But did the pandemic, when the lockdown was there, how did it impact HCG? Because I'm sure the overseas patients would have dropped considerably. Has it gone back to pre-pandemic levels?
Yeah. During the COVID time, you're absolutely right. Almost patients become near zero because of the lockdown and all. But we have gone now beyond pre-COVID. Things have improved. And there may be a reason. Now people are more concerned about healthcare. They are paying more attention to healthcare. COVID has given them a little bit insight. And even in India, we are seeing the number of people seeking help at dedicated centers of excellence, and from abroad, the number of people seeking help in India has increased. We are back to pre-COVID and actually better than that at this point. And we are also making it, because our Nairobi center is a cancer center, we are also making efforts to make sure patients don't have to come. I don't like this medical tourism word, honestly. I want to make sure it's a destination. They come, they take treatment and go back, and we can continue the treatment there in their own country. Because they need to be, in their own country, particularly with a disease like cancer. We can't ask them to stay here for months together. So my philosophy has always been, take the treatment to their beds, to their homeland, and do it. That is why we started Nairobi. We want to expand further as we go in the future.
So I wanted to wear a doctor's hat now for the next question. Cancer as a word, the moment you tell somebody that, we have detected cancer, they get scared. So they're very fearful, because the one thing that people have believed is that cancer, there is no cure. And you are now going to be dead, if not now, in some time. So this fear has been at the back of the mind. And has the technological advancement happened in this space that makes cancer a better managed disease, so that people can live longer and healthier for whatever time they have? What is your view on this?
You are absolutely right. My whole experience in cancer in the 45 years has been to change this perception. Because cancer word has been used not only for cancer. If there is corruption in the society, we hear people using that is cancer of the society. So cancer has been used in a very demeaning way. So the perception people get is cancer means I'm gone. But the reality actually nowadays is different. Because I will explain to you why it is, but because 67 to 68% of the people with cancer today die of other causes, not of cancer. So it's very important to remember, cancer today is a chronic disease and is a lifestyle disease. Now, technology, not only technology, but the most important thing is the knowledge. The knowledge about cancer has significantly changed our perception of how to manage. Along with the knowledge, precision medicine, what we call as, and the reason cancer occurs, the reason some in cancer occurs, why they don't respond to treatment is now being answered through genomics and molecular diagnostics. And we are leaders in that today because we believe that genomic-driven treatment is the future. For example, nearly 50% of treatment we give by traditional way don't work. 50% of the people are getting unnecessarily. We don't know who, because we used to do randomized trials. Oh, we use this drug, 50% responded, let us give, 30% responded. What about the other 70? That is why cancer got a bad name. But now, precision medicine, I can do genomics. I can analyze which patient will respond to what drug. And we are now talking about targeted treatment. We are now talking about radiosurgery. We are talking about robotic surgery. We used to do big surgeries, remove organs like breast, remove organs like colon. Nowadays, we hardly do any mastectomy. We hardly do any laryngectomy. So organ preservation, quality of life, no need for any hospice care. Can I manage pain by treating the exact cause where the pain is coming from? These are added to what we call as quality of life. That is why HCG has a logo, adding life to years. We add life to years. With that kind of quality, people are living longer with less pain, no suffering. So, Bing Cope group, because they have become advocates talking about how they are living. So it is undergoing a big change. So that is why, today HCG sees 120,000 cancer patients who seek HCG and come. I want to go to dedicated because they don't have fear. They know once they come in there, they get the right treatment. That is why going back, right treatment first time will dissipate this misconception. If you don't do, cancer is unforgiving. When it comes back, that is why you get a bad name, because you're not planned and treated. That is one last word I want to say. Cancer cannot be given by 15-minute prescription. It requires multidisciplinary clinic, experts together, and we have to analyze and say what is the right treatment can be given at that point. This is the big change in cancer care.
Right. Dr. Ajay Kumar, my last question to you before I let you go. I know you have to rush for a meeting, but my last question to you is, you mentioned that, there are demographic that play a role. Does not mean that we treat Indian patients the same way as we would treat the Western world. And so are certain races or demographic populations that are more prone to certain cancers than the others? And second is, what will be the role of genomics, not only just to find this out, but to make cancer care better in the future?
Yeah, race definitely, there is associated, but this is just a Pandora's box we are just opening, because all the trials in the past has been done based on Caucasians. So when you look at Indian population, why do we see no more head and neck cancer? Even cervix cancer, it may be related to human papillomavirus, but is it more in Indian population? Why is certain esophageal cancer more? And why prostate cancer is more in African population? It's very high in African population. So these are some of the myths we don't know. We are working on that. The answer lies in your second question, genomics. See, as we study more population-based genomics, we will identify certain genes which are today called not actionable, but they are actionable. As we identify these genes, in head and neck, we have identified 38 genes which have never been reported in Indian population. So as we do this journey, collect more and more data, we are going to find out for each type of cancer, each individual, there is a reason. Because inflammation is the cause for cancer. Obesity, inflammation, whatever, it is the cause of cancer. So what inflammation triggers these genes to undergo mutation and cause cancer is the myth, is the enigma. As we open that in Pandora's box, I think we will have answers in terms of drugs, which drug we are already seeing, which drugs will work for what targeted therapy. And we will have answers to prevent cancer, where, for example, DNA editing, other things will actually prevent cancer. So ultimately, in my view, every patient with cancer should undergo genomic thing. Actually, overall, their cost will come down because right treatment will be treated the right way. Once they undergo genomics, we should be genomic-driven treatment. This will revolutionize the outcome of cancer patients. This is where we are headed. And since the cost of gene genomics has come down significantly, it is continuing to come down. My target is, can we do it for like $100, some 7,000 rupees, can we do a complete gene sequencing? That is what we are headed for. As the volume increases, the cost will come down. So that is where we are. What used to cost, lakhs of rupees, at one time it was, 20 lakhs, 30 lakhs, it's come down to 1 lakh. So 1 lakh, can we take it down to 10,000? That is what we are working on.
That's really wonderful. So what is it that HC is going to do in the next 2 years, which is going to redefine the industry?
Now we are actually working on making sure that with 120,000 patients, quality is important. We can't compromise. So we are in the consolidation phase, 23 centers, consolidate, focus on quality, outcome, tumor boards. We do tumor boards. We have 450 oncologists. We do tumor boards, focusing on outcomes. My time is now spent on understanding recurrence cancers. Why does a cancer come back which place it is coming? Mortality review, where it is post-op, what a patient mortality, why it should happen. So I want to bring the standards of quality to a different level. And which doctor should perform what surgery, multidisciplinary clinic. Then we go to expanding further. So the next year at least, we are focusing on that consolidation. We are doing very good. As you know, the results we published were very good, and we'll continue to give good results. I'm pretty sure on that. But meanwhile, financial results are one, quality results are one. So both of them has to be good in order for us to meet our dream of making sure cancer is treated the right way first time.
Awesome. Dr. Ajay Kumar, it has been such a pleasure talking to you. I thoroughly enjoyed this conversation. And I think it is, really nice of you to take out time to be with us.
Oh, it's my
live on
pleasure.
this session today. Thank you so much, sir.
Thank you. Thanks a lot. Great interview.
Thank you, sir.
Thank you.
Thank you, sir. Kavi, I'd like to hand over to you now.
Sure, sir.
Yeah, thank you so much, Kavi, for bearing with me.
No problem, sir. Thank you. So up next is a panel discussion on surgical oncology innovations, latest developments. We have Dr. Sameer Kaul, Senior Consultant and HOD Surgical Oncology, Indraprastha Apollo Hospitals, Dr. Kanika Gupta, Senior Director Robotic Surgery, Max Super Speciality Hospital, and the panel chair and moderator is Dr. Vishal Rao, Program Director, Head and Neck Oncology and Robotic Oncology, HCG Cancer Center. Welcome, please. Dr. Kaul, Dr. Gupta.
Yeah, I'm there. Good afternoon.
Good afternoon, ma'am. Dr. Gupta, Dr. Rao.
Kavi, we have Dr. Anand Subhash, who will be doing the same. He's the program director for HCG Chennai, and his specialization is in surgical oncology and robotics. So we welcome him. He will be the moderator instead of Dr. Vishal. Thank you.
Thanks, Kavi, and thanks to me. So I think without spending much time, I'll just jump into the panel discussion. And I think the topic that we are looking at is innovations in surgical oncology. So before I introduce the panelists, I thought I'll just give a brief, and then the panelists here, Dr. Sameer Kaul and Dr. Kanika Gupta, they don't need any specific introduction. They're pioneers in their specialty, and have been, in the fight against cancer for quite some time now. Just to introduce myself, just a correction, I'm from HCG Bangalore and not from HCG Chennai. The entire evolution of surgical oncology as a specialty, as a core specialty, started somewhere I think around 1970s, 80s, where though surgical oncology was still around, it was not like as a subspecialty that it grew. It grew somewhere around that time where we started forming larger societies, and these societies grew to a substantial phase, and that is where there fine line which is drawn, thinking that there will be a exponential increase in the surgical oncology work, and will be a lot of innovations in terms of surgical techniques developed, and a lot happened. But I think the cornerstone remains the early diagnosis and detection, and beyond what the surgical innovations have grown, those are around these technologies and innovations which would have come around to help the surgical oncology grow as a specialty, and it will continue to grow from here on. So I first like Dr. Sameer Kaul to make a brief presentation on his take on the innovations in surgical oncology.
Dr. Anand, I think Dr. Sameer Kaul has dropped off for tech issues. Can we move to Dr. Kanika Gupta in the meantime?
Sure, sir. Then what I'll do is I'll just open up the discussions and put across some talk about recent trends which are there in surgical oncology, and how the specialty has shaped from the past to the present, and how is it going to be in the future from here on. As I told,
absolutely. However you want to manage the panel, it's up to you.
The early diagnosis and detection, as I told, has remained the mainstay of the entire of oncology. And I think one of the important things which have happened in the recent year in terms of oncology, recent past, has been the blue ribbon, panel, an elite panel in US. Looking at when Joe Biden was back then the vice president of US, looked at funding cancer in a large way, which is called the cancer moonshot, wherein he said the committee set for four ambitious goals. One is to accelerate scientific discovery, foster greater collaboration between institutions, and to improve the sharing of data. And what emerged out of these, there are probably five drivers which would be looking at how the future of oncology will move forward. One is the enabling technologies, the latest technologies and advances coming in. The other important aspect would be the development of immunotherapy. The immune system playing a key role, and this is not just in the forte of medical oncology or radiation oncology, but even from a surgical point of view. To understand the immune system will be a great way forward. Personalized medicine, precision oncology, wherein our newer devices are able to not just anatomically preserve function structures, but also functionally also preserve structures. Then the other key important thing is the big data, the amount of data that is getting generated. If we are able to collate this and put it into perspective, we are definitely going to make advances. And huge amount of data is being generated across, with each time, a treatment is happening. If we are able to, put together this into perspective and, learn from this, we'll be able to make our treatment decisions better. I think each one of the panelists here have a particular interest in robotics, and I think one of the most important things that have happened in the recent times in surgical oncology, at least in the last decade or so, has been robotic surgery. And this particularly, has changed the way the cancer is being treated today, from a maximally invasive approach to we are going more and more minimal invasive, yet the oncological outcomes are getting better and our patients are actually doing well. And on that front, I would like to open up the discussion and call upon Kanika Uttar before just to talk about the robotics in oncology as such, how it has evolved. What is this robotics in oncology? Where are we and what are we looking at in the future?
Yeah, very nice question, Dr. Anand, and beautifully started, although we are the only two players left now in the field. But, if we see the history, long back when they used to treat CA breast, the treatment was, if you are doing a surgery, remove everything. Remove the pectoralis muscle, if possible, remove the ribs, remove the hand. So more the incision, more bigger the surgeon, and more you want to remove, just that recurrence should not be there. We were not bothered about the life afterwards. What is the quality of life is going to happen after the surgeries are going to be there. So gradually the time passes and we learn that this is not required. We learn about the lymph nodes, how it spreads, how it comes back, the recurrence. And then we realize in breast, like minimal breast conservative surgeries can be done. And gradually, if we see, meanwhile in 90s, the video photography was developing, the technology was developing, and meanwhile, in this side, we got the minimal invasive surgery because of all that. When the video came in and the picture quality was good, we started doing minimal invasive surgery. And next to that, we do realize that we have certain problems when we are doing the laparoscopic surgery. So all of us are not a good laparoscopic surgeon. It has a long learning curve. So for us, here comes a help called robotic, which is a really, really good surgery. I have learned 1 year back only. And I always, when I'm taking the different CMEs, I always say I'm in love with now robotics at age of 62. Why? Because, you have a 3D picture. You're not dependent on camera on somebody else. The energy sources are so good. So the robotic has definitely is going to play a bigger role. If we see the history in US, they had from 2010 to 2018, and now I'm seeing that same boom is coming in the India, where recently in Delhi itself we have many of robotics was equipped in so many corporate hospitals, and I'm doing robotic radical hysterectomy with sentinel nodes. So it is a further advancement where I can do the ICT dye. I need not to remove the lymph nodes, so the complication with lymphocytes and infection, and it goes down. So definitely robotic is going to play a very good role in oncology, specifically in a deep pelvic surgery, which I mean, I'm as a gynae oncologist, I operate. Yes.
Just adding to what you brought about, Madam, that yes, these robotic platforms have become, a convenient tool wherein you can still, break, have a cup of coffee, and yet continue your surgery, maintaining all the sterility parameters. And in a way, it's more relishing to do a procedure here where you don't have those nasty scars, running all the way down your abdomen, and you see the patient recovers a lot faster.
Specifically, if the BMI is too high or they are elderly, I have done an radical hysterectomy at age of 83, BMI more than 40, and next day they are back home.
And earlier, what was there were only very limited surgical platforms, robotic platforms that were available. But now, just around the corner, we have over 20 different platforms that are out there for people. And I think this is gonna right now, the robotic surgery in India at least is concentrated only in few cities across India. But I'm sure in the years to come there will be deeper penetration, and probably even the smaller cities will have more and more of robotics coming in. That's where I would just want to ask you, Madam, any thoughts on how the robotic technology, where the future is headed? What all are the platforms that you think are going to make the difference or the cut in the coming years?
So what I think, when you start doing certain thing, the advantages are there, and then you realize these are the disadvantages of this technology. Like we all know, we have done surgery by touching, open surgeries, then minimal invasive, so haptic was not there. So they are, I heard, going to come back with certain vibrations, or so the haptic sensation you may going to get in, and 3D picture without putting your head inside the viscera. So these are the few things I think it's going to come with the sentinel nodes, and all is already there with ICD dye. You can incorporate your radiology picture and can see where the tumor is. So that is going to help us in robotic, I think.
I think on the contrary, what we say is that we as humans have small eyes and big hands, whereas robots have small hands and big eyes. And I think that magnification definitely makes a difference. And from what I know and what I've seen across the platforms that I've used, the system is actually going to if we bring in the concept of artificial intelligence here now, the robotic systems that we are currently using are at the very basic levels, the level 1. We're not even gone wherein they are still looking at thinking on their own and helping make any decision. So the learning part of it is still being enabled in these systems, wherein some bit of training. Right now the current systems are able to fine tune or mitigate your tremors that are there in the surgical hand, so that those are not transmitted across to the patient. And that itself is a huge advantage, because as you age, also your fine skills may be compromised, or it may reduce. And that's when I think these robotic platforms are going to be a great advantage, and this would translate into better patient care as well.
Definitely.
So another thing which I think will be driving the future in robotics would be the image guidance and navigation systems. I think a lot of specialties are using it right now. It's being used even for radiation therapy deliveries, to more precise treatment. Any thoughts on that, ma'am? How is it going to be an add-on to gynec oncology, and or the overall surgical oncology? Because we feel in the head and neck surgical oncology, there will be a huge impact of having image guidance and navigation systems enabled on these systems.
So definitely it's going to help you if you know the image is there, and you can know where to cut, so you can remove the complete hysterectomy, complete radical can be done. So definitely, like ICG helps us for sentinel nodes. These are definitely going to give you better results, and lesser the surgery, less the trauma to the patient. Definitely, the more the technology is, it's going to give advantages to the patient and to you also, with your good results and good recovery.
Ma'am, you spoke about ICG, and that's where probably I thought of bringing in the sentinel node biopsy. I think that has been another important advance in the general practice of oncology. Proven in some subspecialties of oncology, and some it's still in the very nascent state. But I think it's somewhere around the corner where we may shift from a proper dissection of lymph nodes to the sentinel node biopsies.
Yeah, so for at least CA endometrium, if we talk about, I'm regularly, whenever I'm doing the robotic, it's methylene blue, I don't have a very good experience, but yes, with robotic and ICG dye, it's a very good experience, and you can trace them and can remove those nodes only. So they are looked after better, the micrometastasis can be seen, and you can send them for frozen. So you can take a call whether you want to do a complete surgery, you don't want to do it. Generally, in atypical hyperplasia also, where you don't, if you send them frozen and the reports are not conclusive, even if you have done the sentinel, she need not to come back for another surgery. So definitely, yes, for CA cervix, if I discuss CA cervix, whether we do have a role of sentinel or not, because the minimal invasive and robotic is after the 2019 trial, LACC. We are not doing the minimal invasive and robotic, and trials are going on where they are blaming to the uterine manipulator, and so there are two trials going on, where one, they are doing it robotic and without manipulator, and one where they are adding both. But you can, if you have used the manipulator, you write it down. So let us see those results. And the third trial on cancer cervix is with sentinel nodes, where they say if you can do sentinel nodes in CA cervix. So this will help in removing, in helping not to remove the complete lymph node dissection. And sentinel nodes in vulva is not now that common. So it's mainly the CA endometrium, where with robotic, yes, sentinel node is a major play, where you can see it's very rarely even at the para-aortic, so which you are not going to remove in early disease. So you can, with sentinel nodes, see where actually the first node is.
Ma'am, that brings me to the other important development, which has now, at least in the last few years or in a decade, that has become a popular thing is it may not be always required that you completely remove the tumor, and this is where I'm coming to cytoreductive surgeries, where you look at reducing the disease burden to optimize outcomes. And I think it is a fairly recent concept as compared to what you spoke about earlier, where you could go and remove everything that is on your way before. But now we are looking at a little more conservative approaches. And your take on that, ma'am?
For cytoreductive?
Yes, ma'am.
Yeah. So generally, you whenever the new patient comes in, you take a call whether you want to do an interval cytoreductive or primary cytoreductive. So definitely the interval cytoreductive, generally when they come, to my experience, you need not be so drastic, because already the tissue has come down, the disease has come down, it's been taken care of. So the minimal, you need not go much for, the intestinal surgery in these cases. Generally, that is what my take is. You need not to go for colostomy and think. Yes, HIPEC can be added at that time. But if you are doing the primary surgery, yes, sometimes you need to remove many things. So that is the call you have to take by putting a diagnostic laparoscope. You can see initially whether you want to go ahead with the primary surgery or you want to go ahead with the interval surgery. As such, the results are not very different. They do say if you can do the primary cytoreductive surgery, the tissue biology is good and you can go ahead with that. But if we consider the results in both, there is not much of a difference if you do primary or you do the interval.
You did bring up, speak about HIPEC. If you can just probably speak a little more about HIPEC and enlighten the audience on what this is and how this is useful as an adjunct.
So we all know the ovarian cancer is a disease which spread by peritoneum. So whenever we are giving the chemotherapy, the peritoneum is a little bit left behind. It's chemotherapy doesn't penetrate much inside. So whenever we are doing a cytoreductive surgery, total peritoneectomy is a part of cytoreductive surgery. Yes, we know cytoreductive surgery is actually when you don't see any disease from naked eye, that is R1A. And when you see more than 1 centimeter, there are different grades. If you leave around more than 6 places where the disease is more, that it is called incomplete cytoreductive. So if you have reached a complete cytoreductive, less than 1 centimeter you have left about, you can put the HIPEC. HIPEC is by higher temperature, you circulate the cisplatinum mainly. So the chemotherapy is circulated by a pump inside the abdomen, which can be done by 2 methods. Either it's the open method or you close the abdomen and then circulate that. We generally prefer the closer method. We don't form the coliseum. And this chemotherapy cisplatinum is circulated, which is high temperature. It penetrates the peritoneum much better. So the disease, microscopic, whatever it is, it kills there. It kills by apoptosis. It kills because of temperature. It kills because it interfere with the DNA mechanism. So many mechanisms are being told that when you are doing hypothermic intraperitoneal chemotherapy, it helps. It helps. If we see the data, it says that 6 months the recurrence is delayed, and if we see the overall survival, it is generally they put it 15 months, where you have that advantage if we are using the HIPEC. And in my center, I'm doing regularly HIPEC. If I'm in a corporate sector, so whenever the finance permits, we always try to explain it to them, and if the finance is there, I prefer to go with HIPEC.
Another important thing which has actually changed the oncology practice has been, the ability to control blood loss, the hemostatic agents which are now available, which have actually gone better from what it was earlier. Not just, from Lega clips to, the more biological dressings and everything, which have actually improved the overall outcomes of the procedures. Any experience on that, ma'am, where you would have probably seen that era where, where we had just sutures to, simple, more, refined hemostatic agents which are now available?
So I'm not much aware, and I'm not much using apart from those, the older one, the Surgicells. And yes, I know there are sprays and all, so you can mix them and they can stop the bleeding. But as such, in my practice, even if there is a small rent in IVC, we prefer to suture it then and there. It hardly takes a time. So I'm not much aware, and I'm not using much of them. Yes, I know there are different ethicons, and they are available, and they are, I think, costly and not always available.
I think another important would be in terms of synthetic biology. And because biology is being used right now, when we are talking to 3D printing based, to create molecules like using biological printing, it is called, when you're able to create small organs, and these can not just, they have a functional component to it as well. And this is also will be a defining point for oncology in the coming years. And another, key aspect would be the role of transplants in surgical oncology. Though it's a far-fetched thought, but I think, people have started to think about it. Attempts are being made where an organ, if removed, can it be transplanted with another one? And, surely I think in years to come, we will be, seeing these changes, and, practices is likely to change. But, with all these technologies coming in, I would want to ask Madam the last concluding question, like, do you think, we'll be replaced by technology, or will the surgeons continue to exist?
Whether the technology is going to come or getting more and more advanced, they also need to be driven. So if the robotic, one of my patients said, Madam, surgery kaun karega? Is the robot is going to do, I'm not going to get it done. I want the surgery to be done by you. So it's the men behind the machine, I think. So machine ke piche hame to rehna hi hai. So it cannot take our place. And the disease, and because the anatomy is not actually the printed one, there are variations. So even if you train them or whatever you do, you have to be there as a man behind the machine. So I don't think near future it is going to happen. I don't know afterwards.
Thank you so much, ma'am. Dr. Anand, you will have to conclude.
Yes, that was the concluding remark.
Yes, please, if you could just give us a closing note.
Yeah, so that was the concluding remark. As from the surgical point of view, we are here to stay, and we'll continue to be around here batting our way. Thank you.
Thanks a lot.
Thank you, ma'am.
Thank you.
So up next is Dr. Somashekar SP, Chairman and HOD Surgical Oncology, MHEPL, Manipal Comprehensive Cancer Center, Manipal Hospitals. We're going to talk about HIPEC, PIPAC, robotic surgery, enhanced recovery after surgery, and technological advancements.
Dr. Somashekar, can you switch on your camera so that we can go live?
Hi, very nice seeing you. Hi, good afternoon.
Hi, Dr. Somashekar. So pleasure to have you here.
My pleasure.
Yeah, I think, the earlier panel has kind of set the tone for what we are going to talk about.
Yeah.
Because we're all talking of surgery being one of the options in managing cancer. And there are always questions on what is the technology that we are going to use. We are moving towards robotics. And the last question that the earlier panel was asking was that, is it going to replace the surgeon? So, let me begin by giving a little background of who you are so that it makes sense to people who are watching us. So for everyone, Dr. Professor Somashekar, SP as you call it, is that correct?
Absolutely.
Yeah. He is the HOD and consultant for surgical oncology, gynec oncology, and robotic surgeries, and now HIPEC at the Manipal hospitals. He has done over 2,500 complex robotic oncosurgeries. So he's just the right person to speak to regarding what the topic that we have in mind. And apart from his surgery, he is also the Council EC member of the Association of Gynec Oncology in India. And he has over 300 publications in reputed national and international journals, right? So before I start, I want to get the pronunciation right. It's HIPEC and PIPEC. Is that correct? Absolutely. So let me ask my first question to you, sir. Tell us something about HIPEC. What are the kinds of cancer it is mostly used for, and what is the success rate of HIPEC?
Okay. See, there is a paradigm shift that happened in oncology. What happens in cancer is people think the treatment is more dangerous than the disease. One side you're worried about this, and people are afraid to come to doctor because he would do a surgery where even in early cancer they would cut open me too much, and they're afraid, and they think, oh, a little bit advanced cancer, there's no cure, why to waste? So this is what people actually think. But this both paradigm shift happened in oncology. For complex early stage 1, stage 2, stage 3 curable cancer, we have moved from open surgery to keyhole minimal invasive robotic. We'll touch that later. Now we have a large number of cancer, unfortunately, in a country like India, even abroad in a Western country, they come when it has spread everywhere into the abdomen. We call that group a peritoneal cancers, which all contribute. Gastric cancer, most of us think there is an acidity. Oh, it is because of the food I had, and I'm fasting, I'm drinking coffee. We take some antacid and we ignore. So gastric cancer, ovary cancer, colorectal cancers, and appendix cancer, they have a tendency to come out and spread all over the tummy with cancer water being filled and spread. They are usually advanced 3rd stage or 4th stage, where for a long time there was no cure. We used to comfort them, prolong their life, and then just give a good palliation. So this is the place where the HIPEC came. HIPEC means hyperthermic intraperitoneal chemo combined with surgery. When we do a surgery, remove all the cancer, even though human eyes remove everything, there are microscopic cells which will come back. Practically everybody will fail in recurrence within a year. So this HIPEC is an advanced technique where we put this pump, which is like a dialysis pump, at 41.5 degree warm chemo. We pump for 90 minutes after surgery is over. So the cancer cells are killed in the abdomen. So where you cannot achieve cure, you achieve cure. And where people live 2-3 years, the life goes for 7 to 10 years. So this is a technique called HIPEC, which was well developed in Washington, DC, France. It has come to India last 7 to 10 years. We introduced it, and the largest number of HIPECs are done in entire Asia Pacific at Manipal Comprehensive Cancer Center, where I am there, over 1,000 cases. And this is a referral center for such advanced peritoneal cancers.
So what is the success rate of this?
Yeah, now it depends upon the primary histology. Like, for example, if it is a appendicular cancer and pseudomyxoma, the success rate is in excess of 90%, which means out of 100, 90 are cured for 10-20 years. If it is a ovarian cancer, then the success goes up to 5 to 6 years, about 50-55%, when it was 0%. Stomach cancers, colorectal, where the average lifespan without this HIPEC would have been not more than 24 months. People have good life for 60 months. So the success is based on the primary disease. So in a condition like pseudomyxoma, appendicular, ovary, success rates are massively high. Stomach cancer, colorectal, which spread in the abdomen, which are stage 4, traditionally they are poor, it triples up. So it's fairly a very good result.
I mean, I think that's a very, very significant advancement that is there in the field of oncology.
Yes.
Now, are there any pre or post therapy precautions that need to be taken into consideration when we are looking at HIPEC?
Absolutely. Everybody is not eligible. When they come to a doctor, even though they're stage 4 spread, there should not be any cancer outside the abdomen, tummy, like in the lung, outside the body, number one. We usually give a course of chemo to see the biology of the cancer, do they respond? They must be in good physical and nutritional condition and fit. So these are some of the prerequisites for undergoing HIPEC for them. Usually, if you have 100 such patients, roughly 60% benefit. That is what has been found. Another 40% of the people, even though you may have an expertise, center, technology, they may not be a candidate to undergo in them. So nevertheless, 2/3, if they are eligible, is a big support to the Cancer Society.
So does that mean that, it is more useful in cases where there's an early detection of cancer?
No, all HIPEC is for advanced cancers when it has spread already. But even among them, they need to be in a good fit condition, and reasonably they should be well preserved to tolerate this. So as I told you, most of them are stage 4 or stage 3C advanced. HIPEC cancer is for advanced cancers. So people who come with advanced cancer, 60% are eligible for this.
So one of the biggest outcome of HIPEC is that you are able to give them a longer life.
Yes.
Post-surgery, right? Yeah. So what is the usual life expectancy after HIPEC?
Yeah. So like in colon and stomach cancer, where the life expectancy is 24 months, with HIPEC, it goes to 40 to 50 months, which is 5 years. And in appendicular cancer, when the life expectancy is 3 years, it goes to 10 years.
So what is the difference between HIPEC and PIPEC, and which is more effective?
Okay. Now HIPEC is a curative treatment. Means if you do surgery and do HIPEC, group of people are cured for life or they live. See, in cancer, we say for 5 to 10 years, if they live without cancer coming back, they achieve full cure. That is a term. So now there is a group of patients who are stage 4 advanced who come asking HIPEC. When I evaluate, we understand they cannot withstand HIPEC or they are not eligible for HIPEC. Then we use this German technology called as PIPAC, where a nanoparticle pressurized aerosol chemo is sprayed into the tummy for 80 minutes. And we send them home as a keyhole. So PIPAC as of today is not a curative treatment. It gives good palliation, improves the quality of life, doubles up our survival benefit. So anybody who treat with the advanced peritoneal cancers, ovary cancer, stomach cancer, appendix cancer, colorectal, institute like mine, will have a HIPEC for patients who are eligible to cure. Those who cannot undergo HIPEC, we have PIPEC, so they can have 3 years of excellent quality life, independent life. So it's combination of both.
So I know you touched upon that, who is the right candidate. So can you tell me in detail that, how does a patient qualify for a HIPEC procedure?
I would say that every patient who has an advanced ovarian cancer should ask their physician, along with surgery, can you please add HIPEC? Do you have the facility? Am I eligible and candidate? Number one. All the advanced colorectal cancer, gastric appendix, these patients are eligible. They should ask for surgery and HIPEC. Now, PIPEC. All the recurrent cancers of ovary, colorectal, stomach, appendix after undergoing curative surgery in past, if it comes back again, are eligible for PIPEC. In a nutshell, this is the best way to sort of convey the message.
Dr. Somashekar, what kind of innovations have been developed in the field of robotic surgery since the last decade? I know there's a huge development but can you share with us that what are these developments that have taken place in the last 10 years?
Absolutely.
See, no cards available.
I am one of the very early person who actually took
no
over.
No cards available.
Sorry.
Salman, can you mute Dr. Gupta, please?
Yeah, so, I was one of the early adapter of the robotic surgery technology. I started roughly 10 to 12 years before. There were first generation, second generation, third generation robot. Now we have fourth generation robots which are available, which I switched over last 4 to 5 years. So the advances in this fourth generation robotic over and above pre-existing robotic are, now we have added a ICG Firefly laser. We do image guided functional surgery. We give a special ICG dye with the robot. We throw the laser and look at the nodes which could harbor the cancer. Endorist, special stapler which can turn 110-degree has come. Special endorist vessel sealer has come. Ultrasound at the tip of the robot has come. 2.5 centimeter, 25 millimeter robot goes through the navel of human body, opens into forearm like a crab, do the surgery and come out, called as a robot SP has come. So these are the new advances in the robot that has come, which were not there in fourth generation. Further advancement is again happening, which is artificial intelligence integrated, and also microscope integrated into robot has come.
Dr. Somashekar, I want to ask you one more question for the interest of people who may not be understanding the technical terms.
Yes.
And this stems from my earlier conversation during the day that, the moment you say that there's a robotic surgery, in the minds of a patient or the patient's family, they think that, doctor kuch nahi karega, a machine apne aap karegi kuch. So can you in a layman's term explain what a robotic surgery is and what it means for a patient?
Okay. Number one, remember, robot surgery means it is not Rajinikanth movie. One robot will walk, do all the work, and then you sit in home. No. Surgeon, it is like, surgeon is the main person who operates. He sits and operates. Initially, traditional surgery, surgeon puts their hand into the robot, into the human body, with his eye, which can see naturally. With 2 arms, you do surgery standing. Robot is, there is a advanced artificial intelligence computerized machine between surgeon and the patient, which has got 4 arms, which can turn 360 degree with all the advanced devices. So now here what happens is, it is a slave master. Robot cannot do anything without surgeon translating it. Now with robot, I go through keyhole into the deep abdomen, chest or the mouth or natural orifice. Robot makes my eyes see 12 times magnified view, so I can distinguish where is cancer, where is not cancer, where is normal area blood vessel. I have got 4 arms now instead of 2 of my arms, which I can control. I have a laser, vessel sealer, all of them. They have got a, tremor cancellation motion scaling device, and I sit and operate. So my whole efficiency of surgery is keyhole, painless, less blood, fastest recovery, minimal invasive, highly functional, yet maximum clinical benefit, where patients can go home in 1 or 2 days. They'll not have a major cuts. Need for ICU ventilator is very less. Painkiller antibiotic is very less. They go home in a matter of 1 or 2 days back to their work, and least blood, so blood transfusion and all is less. Having said that, robot cannot act independently. They are a slave master, which I control, wearing all the joysticks. So it's just an interface between me and them. So my whole outcome increases.
I think this is one big development in the last couple of years or decades that we have seen, because the moment you are talking about the accuracy levels going up, we are reducing the human errors, and which directly are proportional to now the outcomes that we are seeing in the patient recovery. What a brilliant development that has happened in the Indian healthcare system. Now, when we look at the development, I was asking this question to another gentleman in an earlier panel, and I think it is important to understand that if you look at 2 decades ago or 3 decades ago, there was a time when the rich and the famous, if cancer was detected, they would do anything and everything to travel overseas, go to the Western world, get the doctors and the facilities to get their treatment there. And things seem to have changed, and are we as a nation well poised or well positioned to be the cancer destination for the world, where people come to India to not only get the treatment, but a satisfaction that you're getting the best treatment at the best price? What are your thoughts on this?
Absolutely. The whole previous decade was East looks West. Now whole future is in India. Whole future is in Asia. The whole West looks for East. It is a known fact everywhere in US, UK, the best doctors in the world are the Indian doctors. Ideal combination of ethics, hard work, knowledge, skill, dedication, compassionate passion. Initially, what was lacking was the training infrastructure. No longer. Now the facility infrastructure training in India are far superior. What may be available in 1 or 2 best hospital in entire US and UK is now routinely available in most of the metros and second tier city in India. The numbers, expertise are 5 times more than the best experience center and a surgeon or a doctor in abroad. So now Indian doctors, their knowledge, compassion, human touch is combined with best infrastructure, large amount of expertise and skill in India at a very, very affordable healthcare cost. Now we see routinely for hypergagate patients from Canada, Australia, Singapore, UK, for robotics, entire Middle East, all abroad they come because waiting list is short, highly expertise, skillful people, infrastructure good, not much waiting list, and yet with compassion. So take my word, already the shift has happened. West looking to East, we will be the main hub for healthcare where the human touch is never lost, compassion is never lost. Hard work, sincerity is now augmented by the infrastructure availability. There is nothing in West world which is not available in India today. And they are available at a much higher level of expertise and compassion, down to earth with human touch.
That's brilliant, because I think now we are becoming the superpower of the modern oncological development and treatment as a nation. We have the best of equipment now available in our country, and it is much cheaper than the same facility being available abroad. But do you think we have enough oncologists in our country? And what are we doing to develop the skills so that we have enough? We have the best oncologists in our country, but do we have enough oncologists?
Absolutely not. There is a statistics which is brought by World Health Organization and also Globacon. Globacon data is the one which maintains the ratio of cancer patient, infrastructure, mammogram, radiotherapy machine, robot, medical onco, radiation, and oncologist. And the Globacon data says for every 1,000 cancer patient in West world, there is one oncology group available. And in India, it is 1 to 2 lakh people, one oncologist. We are at a deficit of 30 to 40% as of today. But it is better than what it was previous year. See, like when I got trained in oncology, way back, almost 2 to 3 decades back, there were only 4 surgical oncology seats in entire India. Entire India. If you are not in top 4 rank, you don't get to be a surgical oncologist. Today, there are 213 seats in India. So in 20 to 22 years, 4 has become 212. But still, it is less, but nevertheless, it is like 100 folds more. Things are changing. Still, we have significant less availability of radiotherapy machine and oncologist per ratio to patients. It is improving, and I'm sure in 5 years, probably the bridge would be fairly okay for us. We are reaching there, still a lot to be done. But last decade has been like, suddenly changed what didn't happen last 5 decades.
So you touched upon a very sensitive thing that, you have more number of seats available now. Now, one of the debates has been that, the way you can have more trained doctors is by having more institutions and more seats available. What do you think must be done to ensure that the quantity does not compromise the quality? What, in your opinion, is something that we as a nation or policymakers need to keep in mind for this?
Absolutely, you're right. At some places, things become little lax, and then increased quantity actually compromises quality. No doubt about it. It's a law of nature. It happens everywhere. It does happen here also. These can be avoided by a structured training program curriculum. A strong body, luckily MCA has now moved to NMC, National Medical Council body, which has a very strict criteria, this much of clinical material in each institution, this many exposure, this many surgeries, this much logbook, and this many training course, mandatory annual skill course. So by strengthening the regulatory bodies, by developing protocols, and then by making a structured curriculum and not violating them and enforcing them, having periodic assessment and accreditations go a long way in doing that. It's not easy in a vast country like ours, but still we are doing pretty much good job. But we need to do that, and centralizing everything is something which can really help for us to do.
Got it. So now coming back to your core area, can you tell us more about something that we know as ERAS, which is enhanced recovery after surgery?
Yeah. See, what has happened is initially, traditionally, if you go anywhere in India, a patient just get admitted before surgery. They're allowed to fast. They say fast whole day, major surgery is there. And then after surgery, we keep them tube in the nose, urine tube in the abdomen. We make them lie, run the drip for 2 to 3 days. We are afraid to make them walk, and then they stay for a long time. So because of this, what happened is patient goes home late, complications is high. The whole healthcare system is concentrating only on changing the drip, maintaining the tubes. Patient lying down, beds are occupied unnecessarily. And because patient lies down, complication like pneumonia, blood clot is high. That's why a good concept of ERAS, enhanced recovery after surgery, not compromising the outcome and patient care, yet giving a good recovery came. In ERAS, it is found by scientific evidence scientifically. No need to make a patient fast for 1 to 2 days before. Patient should have a good meal. 2 hours before surgery, anesthesia energy drink is given. Try to use less tubes in the surgery. Good pain management, quick surgery, and then making patient walk same day, feeding patient same day, and avoiding drip unnecessary when it is wrong required. There is a 36 modification to the traditional old surgery concepts. We think surgery means no, make them rest. You know if in your home anybody has done surgery, you say 3 hafte rest lena, bahar nahi jana, kam mat karna, ghar mein khana khilana. All that adds to complication, not required. Physical activity makes you do well. Natural pulmonary breathing exercises, natural blood circulation exercises, bowel movement is fast, you eat well, digest well, immunity improves, less stress response, better outcome, less complication, less infection. So there are 36 modules in ERAS Society from Sweden, which are there. In the entire Asia Pacific, Manipal Hospital is the first hospital to get this accreditation. Like you have NABL, NABH accreditation, lot of parameter governed by third body, which takes 2 to 3 years. So our entire team of oncologists, surgical oncologists, GI, anesthesia, gynec, sister, nurse practitioner, nutritionist, we got trained in this world several years. We adapted this. We reached 91% of efficiency. By virtue of this, in last 3 to 5 years at Manipal Hospital, average day of going home, it was 7 to 8 days in colorectal complex surgery has come down to 3 days. 5 days in gynec cancer has come down to single day. Complication rates are halved. 30% save of healthcare money. Fast recovery and less complication has happened. So now this is the norm where everybody works as one team and applies. And we are happy that we are the first center to reach that level, and we got the accreditation from the European ERAS Society. And now most of the hospitals are adapting these modules and the training, and ultimate beneficiary is patient and the healthcare. 30% money saved can be used for other patients in a country like us, where resource costs are very less, number of patients who needs it very high.
Sir, you just mentioned about the cost. Is there a way that you feel that we will be able to bring at least the initial cancer detection, cancer care available to tier 2, tier 3 cities where it is not available right now? I mean, I see people traveling to large metropolitan cities, to large hospitals and they're struggling to get time.
Absolutely, I agree with you. No use having center of excellence in metro. Few people, rich and upper middle class, can do, where 60% of Indian rural population stays in 2nd, 3rd, 4th tier city. They are the people who are bread earner for her. They are the hard manual people. They feed the whole country. They are the rice bowl of India. If it cannot reach, they always say that the strength of a country is not how you maintain the rich and people at top of the pyramid, how we maintain and provide healthcare, food, and respect to the people at the base of the pyramid. That is the country. So there is no use of any cancer care, any healthcare, unless it reach the PHC, taluka level, primary healthcare level. Rural people, needy but can't afford it. I fully agree with you. Things were quite bad 10 years back. Luckily now, most of the 2nd, 3rd tier cities are equipped with radiotherapy machines. Now, oncology services has moved to 2nd tier city. Now, people understood that don't open it in major cities, metro. Go back in center. Convert all the district hospital into a regional cancer center. All the PHC peripheral units, make it into a onco clinics. All these ASHA worker, healthcare worker, ICDS health worker, which already beautiful central schemes are there, which cover a woman who is pregnant, children, nutrition, tuberculosis, infectious disease, empower them and tell them to do cancer screening. You cannot do cancer change if you tell patient come to major city for mammogram, come for a pap smear. Nobody is going to come. One day travel to a metro city is equivalent to there and 1 week earning in their farm. Nobody is going to come. So it is going to be waste. So we have to move there, empower the existing healthcare, support them, move the infrastructure to district place and taluk place. Don't ask them to come to major metro city and move. By and large, a lot of changes are started happening now. Now, most of the taluk and districts have at least one radiotherapy currently. Still very less, but it is available. And the cancer screening for, two major menans in India, cervical cancer, which can be eradicated by pap smear and HPV testing, and breast cancer by clinical breast examination and cancer awareness of breast, will contribute roughly 50% of womanhood cancer in India. This can be done by moving there. So what we need to do today, if you have COVID, it is notifiable disease. You don't notify, you, doctor, hospital, everybody is prosecutable. If you have any disease, so we have to make cancer a notifiable disease. The moment you say anywhere, any doctor, hospital, however small PHC is there, you diagnose, notify it to a central app. Then we know the magnitude, we know where we are, and then the government scheme should be there. Then we have to bring how we brought tuberculosis eradication program, polio eradication. We have to bring at least top 3 to 3, oral cancer, which human being do yourself eating, gutka, smoking, cervical cancer, bad hygiene, no screening, breast cancer. 3 of them should be brought under the habit of National Prime Minister Cancer Eradication Program. Make cancer notifiable disease, then everybody is afraid. I identified, I notified. What did you do next? You have to either give treatment there or refer somewhere and get treated. These 2 will go a long way in understanding the problem, allocating the budget money, and how to address this problem in a country like India.
I know. This is actually a very it's a brilliant thought, but I don't know. I mean, if we have too many detections that happen, then there's a liability that the government needs to actually provide a cure. So I think
no, see, just because closing eye to a problem doesn't mean it is not there. First step to acknowledge the problem is to identify and accept it is there. If we don't even ready to do that in a society, then we can never reach there.
Yeah, I completely agree with you. In fact, many a times I keep talking about the 3 A's that, first is be aware, then accept it, acknowledge it, because only then will you actually act upon it. Yes. So I think this is a brilliant suggestion. But what I really want to ask you, because while you were telling me this, the thought that was coming into my mind is that, we have less number of trained, good quality oncologists in the country. The problem is much larger. The problem is not coming to light because it is not getting detected in the tier 2, tier 3. Is there a way that technology or telehealth can bridge this gap where you have trained technicians in the tier 2, tier 3 who can be in touch with the trained oncologist in a metropolitan city? And would that serve a problem? And if yes, how do you envision it?
Absolutely, no doubt about it. A hub and spoke model is mandatory. All the villages to be linked to a district hospital, PHCs, all the district to be linked to a regional cancer center. Government of India has a regional cancer center now in most of the regions, which is fully funded by state government, central government, free treatment available. So hub and spoke model has to be done. We cannot say all the cancer has to be treated in major cancer center. Impossible. They will explode. Nobody can treat. Needy will be left behind. There will be such a long waiting queue. Stage migration. You come in stage 1, waiting, you become stage 2. By the time treatment starts, stage 3, no cure. So one way is using a telemedicine. Beautifully is now there are 10 to 12 bands from ISRO, which is available easily. Satellites have been launched according to PM program. A lot of these bandwidth are allotted to the fishermen's education, and this so optimal using of digital technology, telemedicine, sharing the protocol, training the peripheral doctors in the simple basic chemo delivery, cancer screening is the best way to go. So use technology, do most of the telemedicine consultation, get our peripheral PHC and central hospital to come down for a couple of months to major cancer centers, train them, empower them, and then send them back and try to move what can be done peripherally. Then maybe 1/3 of the patient which needs advanced infrastructure care only moves, remaining about 2/3 we can manage there. this is the way to go forward, and we have to do this.
Dr. Somashekar, my last question to you. I know you have to rush because I got that message.
Yeah.
What are the latest technological developments that have been done by Manipal hospitals in the field of oncology?
Yeah. See, number one, we were the first to embrace the robotic minimal access technology. Largest number of robotic cancer surgery is one which we did. In case of this, then we got the first HIPEC qualified US FDA approved Vision 2 of them and the PIPEC technology. We brought a ICG green light laser for sentinel lymph nodes, so the quality of life in breast cancer woman is very advanced and better. We are now moving to intraoperative radiotherapy machine, so that patients don't have to come for 1.5 months every day for radiation in breast cancer. During surgery, you give one shot and they go back to their place peripherally. Among the medical oncology, immunotherapy, targeted therapy, ambulatory pump-based chemo. No need to get admitted for weeks together for chemo. Put that pump with a remote sensor, patient go back to home, keep working, and the chemo keeps delivering. They come back after 3 days for pump change. And then moving with the state-of-art focused targeted radiotherapy. Adding with this cancer survivorship and then, counseling is something we did. So a right mixture and marriage of technology, making it cost viable, economical, and bringing the latest for the best cancer cure, both in early, advanced, is something which we adapted here, and a lot of patients have got benefited with that.
Awesome. Thank you so much, Professor Dr. Somashekar. It has been such a pleasure. Thank you so much for taking out time. I know you're a busy person, but it is so useful to have this conversation for the benefit of our audience. I really appreciate your time. Thank you so much, sir.
Thank you very much. My pleasure. Thank you.
Over to you, Kavi.
Yes, sir. Sir, can you hear me?
Yes, I can hear you, Kavi.
So now we have the closing address.
Okay.
Yes.
So should I be doing it?
So I don't.
Okay,
sir,
cool.
Okay.
Cool. Yes, I will. Yes, I will. So first of all, I mean, all of us who are watching it live, it's been a really beautiful day, because I never thought that the kind of speakers who were there would actually be able to take out that much time from their schedules. I mean, a lot of them have surgeries lined up. So for them to take out time for this conversation was really, really wonderful. So, first of all, I'd like to express my gratitude to every speaker who was there. My key learnings from the day is that, this industry, which is about 16,000 crores today, and it is growing at the rate of 13% CAGR. But what the beautiful outcome of what work is happening in oncology is that we have more number of cases being detected. Why I'm saying it is a good thing is because the moment we have more number of cases being detected, that means more number of people are getting the opportunity of getting the cancer treatment or cancer care, which otherwise they would have been deprived of just because they did not know about it. But there's a long way to go because we still have about 800,000 people who lose their life to cancer every year. So there's still definitely a long way to go. What we've learned about today is we spoke about cervical cancer, we spoke about liver cancer. One thing that is still at the back of my mind is the 7 S's, the causes of the oral cancer. We learned about the early diagnosis. We just recently, in the last panel, heard about how robotic surgery is raising the level of accuracy and in turn creating a better, lesser painful treatment directly proportional to giving us the outcomes, better outcomes as a result. the quality of care, I mean, while we have the shortage of oncologists in our country, we are still in a better position that we were a couple of years ago, with not just the technological advancement, but people coming back to India to serve the country, to serve the population. We have moved from a scenario where people would be traveling from India to the Western world to get cancer treatment. We are now in a position where we have other countries where the population is coming to us as a destination for not just getting access to the treatment, but also getting access in the most affordable manner possible as on date. We've seen that genomics is changing the way cancer could be cared for in the future. We not only will have people living a longer life, but a better quality of life for a little longer. So, it's not as much of a scare in the mind of a cancer patient, which I think is far more, impactful than anything else that we have seen. With this, I'd like to close today expressing my gratitude to each and every one who has contributed to this particular event towards creating conversations which are going to not only comfort, but give us a ray of hope that we are in the right direction. We as a nation are moving towards a better healthcare destination, which probably in turn will serve in creating a healthier population that India deserves to have. Thank you so much, everyone. Thank you so much for your time. And I want to also, as a parting remark, I would want to express my gratitude to the team that has been making this event possible. Smriti, Tanvi, Kavi, who's moderated, Salman, who's been managing the event, all the people who created the social media presence so that more and more people are aware of this conversation that was happening. I want to thank all of you in your own small ways. You have contributed to making this a successful day of conversations for the Oncology Summit 2022. On behalf of Business World, on behalf of BW Healthcare, gratitude.